Good morning, friends. Welcome to the 45th Annual Conference of Mumbai Hematology Group. Many of you must have enjoyed the industry-sponsored symposia in the form of webinars during last 5 days, Monday to Thursday evening 6:30 to 8:30. Today is the day to have the main conference, and this is the time to have our opening ceremony. We welcome our chief guest for the day, Dr. Shripad Banavali. I'm grateful to him for having accepted to spare his valuable time to inaugurate this important event. Those who are from this country, Dr. S.D. Banavali is a household name in the field of hematology, pediatric oncology, and all aspects of research in this area. However, we have audience from 14 to 15 countries today, and it's my privilege to introduce him to all of you. He is a towering personality. He's director academics at the prestigious institute in Mumbai, the Tata Memorial Center. He's professor, Department of Medical and Pediatric Oncology at Tata Memorial Center, as well as the Homi Bhabha National Institute. 40 years ago, he did his MD in internal medicine and then underwent adult oncology training at Tata Memorial Hospital, Mumbai. He moved to US and did his research fellowship in University of Cincinnati. He did his board certification in pediatrics and fellowship in pediatric hemato-oncology at the prestigious St. Jude. He spent 7 long years in US, but India was lucky to have him back. He came back and joined Tata Memorial Center. He is a member, subject expert committee of the Drugs Controller General of India. He is chairman, Indian Pediatric Oncology Group. He is founder chairman of Impact Foundation. An important feather in his cap is the development of cancer facilities at the BKL Valavalkar Hospital, Konkan, which is a rural outreach program of Tata Memorial Center. His current areas of interest are drug repurposing and development of low-cost, effective metronomic therapies for the treatment of various cancers. A prolific speaker and publisher, has over 500 scientific publications, papers and abstracts in various peer-reviewed journals. The recipient of various national and international awards, and the list is exhaustive to be narrated today. He's traveled widely across the country and the globe, delivering various orations, plenary talks, and lectures. We are indeed privileged by having this personality to inaugurate the 45th Annual Conference of Hematology this morning. I request him to give his inaugural speech and inaugurate this event.
Thank you, Dr. Agarwal, for giving me the honor to be the chief guest today. And I remember, being part of this Mumbai Hematology group, that time Bombay Hematology group, and as a student and as a resident, even presenting papers, and those were the first presentations that I must have made. And as you remember, I was your student at that time. And this, it looks like, from a local meeting to a national meeting. And this year, it looks like really an international meeting. It has really, increased in numbers and stature. And as you told, for the last few days, we were having all the appetizers, and there were really a mix of talks on both benign and malignant hematology. And looks like today we'll have the main course today and tomorrow. And maybe even after that, a dessert is there. So it looks like a really academic feast that we have, organized this year. And thanks to the pandemic and the way we are conducting the meetings now, I think many more students and participants can get involved in such activities. So I think it's really increased a lot. And according to the new education policy also, now it has become very important that students do present in meetings, and they have basically not only to publish thesis, but as per many in universities now, they have to present also oral presentations, and meeting attendance and presentation has become important. So I think today and tomorrow there will be a lot of students who will get a chance to present their work. So I think this is a very important meeting to even for the students to come forward and do this presentations, and along with that learn also. So I think there's a lot of activity planned for today and tomorrow. So without wasting much time, I will I wish that we all of us have a great meeting. There are also, I forgot, there are two orations also. There is a best paper presentation. So a lot of activities are there for today and tomorrow. So I think we'll, without wasting much time, let us start the meeting. And I wish the meeting a great success. Thank you very much once again. Hello.
Sir, we need to wait for a few minutes. Dr. Agarwal got logged out, I think.
Okay, okay, okay. Other participants are there, or it?
Yes, sir. Participants are there, sir.
Yeah. So maybe till he joins, I was just talking with Dr. MB Agarwal just before this meeting, and looks like if this year we have a lot of topics covered in AML, and I was talking with him. So slowly APML we changed from chemotherapy to targeted therapy, but looks like in the very near future, even for AML, we'll be going away from chemotherapy, and there are a lot of new molecules which are being coming in the market. But slowly it looks like even for AML, we will change from go from injectable and chemotherapy to oral biological response modifying therapy, if I may say that. So looks like even today we have Dr. Naval Dawar is there in the evening today. He had some presentation last week also, Vikram Matthews and others. So I think slowly lot of things are new things are happening, and we are changing slowly, moving away from chemotherapy only to maybe a small part of chemotherapy and more part of
Hello,
uh,
Dr. Sripat.
yeah,
Sir, sorry to interrupt. I
yeah,
just spoken to Dr. Agarwal. He's
yeah.
just joining in next 2 to 5 minutes.
Okay.
So sir has just lost the internet connection due to.
Oh, okay. Okay. Okay.
Sir, you can continue the discussion with the
No,
presenter. No issue.
instead of just looking around, I thought, why not talk about it? Because I think, there are many students also, and,
Yes, you can
some of
continue the
them.
discussion with the presenter, not an issue, sir.
Okay. Okay. So, no, I always say that, there is no cancer or no disease that is incurable. It is many of them we don't know how to treat. If we know how to treat, many of the so-called incurable diseases can be totally cured. And that one aspect was APML. When we were residents, we used to hate or dread any patient with APML being admitted, because we required a lot of support. We had to do our own platelet apheresis, and it used to take a lot of effort, and many of these patients used to lose because of bleeding and because of infection, and many of them would not even achieve remission. But now today, with just maybe even oral therapy of atra and arsenic, we are curing 97% of these patients. So something which even with transplants was being cured in, say, 40-45% now without any chemotherapy. With just oral therapy, we can cure 97% of these patients. So things have changed. The same was with Burkitt's leukemia. When we were residents, Burkitt's leukemia, the outcome was less than 10%. And now, since we have changed from treating it as leukemia, changing over to treating it as lymphoma, and now with the newer treatment, Burkitt's lymphoma, leukemia is now cured above 90%, especially in pediatric, but even in adult patients. So things are changing, and I think such meetings give us the newer perspectives and what's happening in other parts of the world. So I think today's meeting will give us not only the national aspect, but many speakers from abroad, and there are other industry related activities also, through which we'll know what's new is happening in this field. So I think slowly in next few years we will change our therapy for AML from injectable to, already the Naval Dowers group has shown, especially in adult FLT3 positive patients, by giving just azacitidine, FLT3 inhibitor and venetoclax, they have 2-year event-free survival of 80%, which was unheard of even some years back. So I think we will be changing the way we are treating many of the newer cancers. The same has happened with CML, the same has happened with CLL. So now myeloma. So everywhere we are changing the way we are treating, and hopefully next few years we'll have a lot of newer drugs to our in our armamentarium, and help us cure many more patients with especially hematological malignancies. Thank you. I think I will wait for Dr. MB Agarwal to join.
Hello, Dr. Banawali.
Yes.
I just got the update from Dr. Agarwal. He's trying to get some connective internet very soon. So we'll start again the session at 10:30. So we'll wait for the break till then. Sir.
Thank you. Thank you.
Yeah.
Bye bye.
Can you see my slide?
Yes, sir.
Moving?
Yes, sir. Perfect. Moving, sir.
Okay. So friends, sorry for all the technical hassles we had. So we begin our morning session of oral paper presentation. As you are aware, in the general category, we have 3 prizes. And later on, for Dr. J.C. Patel Best Paper Award, we will have 1 prize. We have very important personalities as the judges. We have Colonel Dr. Rajan Kapoor from Kolkata, Dr. Sharad Damodar from Bangalore, Dr. Pranta Chakrabarti from Kolkata, Dr. Priyanka Samal from Bhubaneswar, and Dr. Akanksha Garg from Ahmedabad as the judges. They have gone through the abstract submitted by you, and they will be listening to you and probably discussing with you your paper for your work, and all that put together will give their judgment. Tomorrow, at the end of the conference, that is at 8 p.m., they will announce the results of both Dr. J.C. Patel Best Paper Award as well as the 3 awards from the general session. So I invite the first paper. This is in the general category this morning. There are 5 papers. The first paper is entitled Analyzing the Utility of NAT Testing to Enhance Blood Safety, a Retrospective Study. Presented by Dr. Pragna Chavan, Registrar, Department of Transfusion Medicine at KD Ambani Hospital, Mumbai. The co-authors of this paper are Mr. Rupesh Salgaonkar, Dr. Rajesh Sawant, and Dr. Varsha Vadhera. So over to the presenter.
Good morning, sir. Hello. Is my screen visible, sir?
Good morning. It's visible. You are audible.
Yes. Good morning, everyone. I'm Dr. Pragna Chavan, Registrar in the Department of Transfusion Medicine, Kokilaben Dhirubhai Ambani Hospital, Mumbai. I am presenting our analytical data on utility of NAT testing to enhance blood safety, which is a retrospective study.
Madam, just click on the slides. Slides are not moving.
Now it's moving?
Yes.
Yeah. Nucleic acid amplification testing. It's a molecular technique that detects HIV and HCV RNA and HBV DNA simultaneously in a single reaction. It was introduced in developed countries in the late 1990s and early 2000s. And presently, around 33 countries in the world have implemented NAT testing. In India, over and above the TTI testing, which is the standard of care testing, by ELISA or chemiluminescence assay, additional molecular testing, that is a NAT testing, was implemented in 2006. In March 2012, individual donor NAT was implemented at our center. The aim of our study was, the primary objective was to study the results of NAT testing for detection of NAT yields, that is serology negative but NAT reactive, and sero yields, that is serology positive and NAT non-reactive cases. The secondary objective was to correlate enzyme immunoassay results with NAT results and study its further workup of NAT yield cases. The material and methods. The material and methods which we used. There were 84,998 blood donor samples which were tested by chemiluminescence for the detection of anti-HIV, anti-HCV, and HBsAg. Each donor was also tested by ID-NAT assay using transcription-mediated amplification. All donors testing reactive by NAT were subjected to discriminatory assay for the detection of specific virus. NAT yield and sero yield cases were reported. Additional serological tests were performed in case of discordance between enzyme immunoassay and NAT results. So let us have a look at the results. Out of 84,998 donor samples, 1164 samples, that is about 1.4%, were reactive either by the NAT technology and or the chemiluminescence technology. 532 donor samples were concordant NAT yields comprising 36 HIV, 26 HCV, and a huge number of 470 HBV cases. 484 donor samples were serologically used, comprising majorly of HCV, that were 349 samples, accounting to 72.1%. 78 donor samples were classified as NAT yield based on the testing algorithm. 21 samples of these NAT yields were non-discriminated NAT yields, while 56 were HBV NAT yields and only one was HCV NAT yield. The NAT initial reactivity rate was 6%, and the HBV NAT yield, which constituted the 4.8% of total reactive donor samples. HBV serology profile revealed positive status for hepatitis B core antibodies in 49 out of 56 HBV NAT yield donor samples tested. One donor sample showed only hepatitis B surface antibody positivity, whereas the other was negative for all hepatitis B serological markers. HBV DNA testing was not performed. The probability of a NAT yield is that 1 in 1,466 donors can miss a testing protocol and still transmit the virus. And the risk of TTI transmission is that out of 4398 components transfused, one unit can transfuse TTI if tested only by chemiluminescence assay. This is a flow chart. The reactive rate here is 1164, which accounts to 1.4%. Out of this, the greatest public health problem was the concordant NAT yields of HBV, which accounted about 470 samples. While in sero yields, the HCV component was found to be 349 samples, which were detected positive by sero yields. 56 HBV NAT yields were subjected to HBV profile. This is the HBV profile which we have done. Out of this, 36% of the donor samples of the HBV profile and the core hepatitis B core IgG positive donor samples were positive for core antibodies, IgG type, which can be likely a recovered hepatitis B donor. The second category showed only hepatitis B surface antibody, which could be a effect of a recent vaccination. 22% of the samples tested for HBV profile showed hepatitis B core IgG antibody positive, surface antibody positive, and envelope antibody positive, which is an acute recent infective phase. 26% of the HBV profiles done showed hepatitis B core IgG positive and hepatitis B envelope antibodies positive, which can be an acute on chronic phase of the donor. This fifth component was hepatitis B core IgG positive and hepatitis B surface antigen positive, which was a good 12%, which could be a long-standing latent infection. The last category of our HBV profile was negative for all the serological markers, which was one case. It could be a naive susceptible donor. Discussion. Makru et al. In 2008, in their first multicentric study, evaluated ID-NAT and found a NAT yield of 1 in 2622 donations and implicated that the routine NAT test along with serological testing would significantly improve blood safety in India. Similarly, a study by Chaurasia et al. Suggests that for endemic regions with high prevalence of HBV, inclusion of NAT to routine serology is a better alternative than equally, if not more effective, to introducing universal hepatitis B core antibody screening. Screening with HBsAg and hepatitis B core antibody could offer a suitable serological combination of tests. As 8 to 18% of donor population in India is hepatitis B core antibody reactive, inclusion of this marker for TTI screening would invariably result in attrition of large number of donors, causing shrinkage of effective donor pool. HBV NAT yield samples with detectable hepatitis B core antibody are considered as occult hepatitis B infections, whereas hepatitis B core antibody negative NAT yield donors are a window period donation. Hepatitis B core antigen testing as an approach to exclude OBI from the blood supply should be carefully examined because it is cheaper than ID-NAT. Since NAT detects a low level of viral genetic material present before body begins to produce antibodies, the reduction of window period is compoundingly high. Like in HCV, the serological window is 65 days, which reduces the molecular window by NAT testing to 3 days. So there is a significant decrease in the window period by NAT testing. NAT testing reduces the risk of transfusion transmitted HCV from approximately 1 in 1500 units transfused to 1 in 5 lakh units transfused. It also detects mutants, variants, and occult HBV infections. By decreasing the window period, early detection not only decreases the risk of transfusion transmitted infection, but also has a direct impact on the donor's health and overall public health. It also provides an additional layer of safety to the blood supply. The NAT screening methods is two types: individual donor NAT and mini pool NAT. In individual donor NAT, each sample is tested individually. There is no mixing of samples. And in mini pool NAT, multiple samples are mixed together and made to make a pooled sample. So the current risk of transfusion transmitted viruses, the cumulative risk where NAT is implemented for USA, the cumulative risk is 1 in 79,808 samples. In France, it is 1 in 86,505 samples. And in Germany, it is 1 in 126,121 samples. As opposed, the NAT screening data of experience of India shows a cumulative risk of 1 in a value of thousands. Different studies have been shown here. So the next comes the cost versus benefit debate when including with implementation and non-implementation of NAT. So the implementation of NAT bears additional cost. It also involves more discards. It needs some rationalization of testing. There is an increased safety level and increased confidence in blood supply. As against, if there is no implementation of NAT, there's a potential for TTI via the window period donation, involves litigations, it causes reduced confidence in blood and decrease in blood donation, and increased burden of health costs in treating infected donors. So conclusion, NAT testing has definitely contributed towards enhancing blood safety since HBV poses the greatest threat to blood supply in our region. The need for NAT depends on the prevalence and incidence rate of infections in blood donor population. The discard of blood units due to high rate of false positive serology test results for HCV and initial test results for NAT are avoidable. Implementation of hepatitis B core antibody testing would have enabled detection of 94.5% of the NAT yield donors. The strengthening of screening tests with incorporation of modern testing techniques and rigorous donor selection are the only remaining alternatives for developing nations to increase the blood safety. NAT being a highly sensitive and advanced technique, it has reduced the window period, but it is highly technically demanding, involving issues of high cost, dedicated infrastructure facility, equipments, consumables, and technical expertise. The decision of starting NAT should be considered only when the basic quality assured blood transfusion system is already in place, such as the voluntary donor base for blood donation, provision of of donor self-deferral donor notification, and counseling along with quality assured sensitive serological methods for testing TTI.
Thank you, Dr. Pragya.
Thank you, sir.
That wonderful presentation.
Thank you, sir.
Thank you.
Thank you, sir.
We have some of our guests here and your colleagues who may like to interact with you.
Yes, sir.
So anyone has any questions for her or comments? Especially Dr. Pranter, our judge. Yes, Pranter, some echo effect was there. You can ask now.
I just have one question.
Yes, sir.
There is also a pooled match system which is being implemented in certain blood banks.
Yes, sir.
So which is better in terms not only of cost effectivity, but in terms of making the product safe?
Sir, I personally feel the individual donor net is a better testing platform because there is a lower risk of contamination, which can be a possibility in the mini pool testing because it involves pooling and mixing of the donor sample.
Okay. Any other question for Dr. Pragna? Dr. Shruti, you want to ask something?
Sir, I think I joined a little late. I missed some part of her presentation. I would like to, have a word with her sometime later. I'm sorry, dear.
Thank you so much, ma'am. Thank you so much, ma'am.
So, well, Dr. Pragna, appears to be that there are no more questions for you. Thank you very much.
Thank you so much, sir. Thank you.
And now we'll move to the second paper. It is entitled Comparative Study of Rapid CARD Test and Nucleic Acid Amplification Test for Screening of HIV Infection among Blood Donors at SRG Hospital Medical College, Jhalawar, Rajasthan. The presenting author is Dr. Mayank Doshi, postgraduate resident, Department of Pathology, Jhalawar Medical College, Jhalawar, Rajasthan, and the co-authors are Dr. Sumit Prakash Rathore and Dr. Nidhi Soni. So, Nirav, can you tell us whether Dr. Mayank?
Yeah, sir, Dr. Mayank Doshi, as I informed you, that he's still in the attendee. So he has not accepted. So we can go with the third one, sir.
All right. Is Ivani Jain here?
Yes, sir. Ivani Jain here.
Good morning, sir.
Okay. I'll just introduce you and then we'll move on to your. Fine. So we move on to the third paper of the day. Adverse effects seen in patients with transfusion-dependent thalassemia secondary to COVID-19 vaccination in tertiary care hospitals of Ludhiana, Punjab. Presenting author is Ivani Jain. She's intern in Department of Pediatrics at Daran Medical College and Hospital, Ludhiana, Punjab. And the co-authors are Dr. Shruti Kakkar, Mr. Aniruddha Jain, Dr. Priyanka Devan, and Ms. Balvinder Kaur. So over to you, Ivani.
Good morning, everybody. I'm Ivani Jain, intern from Danan Medical College, and now I'm going to start with my presentation. So the title of my study is Adverse Effects of Transfusion-Dependent Thalassemia in Tertiary Care Hospitals of Punjab, India. COVID-19 is an infectious disease which is caused by SARS-CoV-2 virus. And COVID-19 posed a major public health emergency of unforeseen magnitude. In this scenario, vaccines against COVID-19 are the most important component of arsenal against the virus. But vaccine hesitancy has been seen in 10 to 15% of the Indian population, of which adverse effects from the vaccine being the most important contributory cause. Therefore, this study has been taken up to evaluate the safety of COVID-19 vaccine in patients with transfusion-dependent thalassemia. The aim of this study is to evaluate the adverse effects to COVID-19 vaccine in patients with TDT. So our study was a cross-sectional survey amongst patients with transfusion-dependent thalassemia, started in August of 2021, after obtaining the approval from the Institutional Ethics Committee. So we included all the participants who were 18 years and above and who had received at least one dose of the COVID-19 vaccine. We excluded all the non-consenting individuals. A standard questionnaire was prepared and it was administered electronically. The questionnaire included the demographic details, that is the name, age, gender, blood group, ferritin levels, associated comorbidities. We also recorded the details of the vaccines that was administered, the ADR of the vaccine which was experienced within 90 days, and the impact of that very ADR on the day-to-day life. The entire data collected was pooled into an Excel sheet, and statistical analysis was done using a t-test and a chi-square test. So now we're going to discuss the results that our study yielded. We enrolled a total of 100 participants, and the average age of the study population was 24.3 years. This is the gender distribution, and as we can see that our study had more males, that is 62%, and 38% females. So this is the distribution of blood group. Our study had majority of O positive blood group followed by B positive, and the least common was O negative, seen in only one study participant. So this is the distribution of iron of the ferritin levels. Majority of our patients had their ferritin levels ranging 1000 to 2500 nanograms per ml, followed by 39% of them ranging above 2500, and only a small majority of them with less than 1000 nanogram per ml. Talking of the associated comorbidities, the most common comorbidity was hypothyroidism, and the least common was cardiac dysfunction, and diabetes mellitus was seen in nearly 5% of the study population. So 89% of our participants were administered Covishield, and only 11% of them were administered Covaxin. We gave a total of 122 doses, which means that 22 participants were fully vaccinated. And 62% of our participants experienced one or the other side effect, of which 52% were experienced after the first dose, 1% after the second dose, and 9% after both doses. 11% of our study participants had COVID-19 even after the vaccination. So now we're going to talk about the specific ADRs. And in this very graph, we have compared the results of our study with the results published by Covishield and Covaxin. So our study yielded that the most common ADR is local or injection site redness, pain or swelling, followed by fever, followed by myalgia and shivering. As we can see that the results of our study are quite similar to the results yielded by the study published by Covishield, and this is because majority of our study population was vaccinated with Covishield. Now we are going to talk about how these ADRs affected the day-to-day life. The most common ADR, like I spoke about before, was local pain and swelling. It was seen in 34.4% population, and it resolved in less than 3 days for majority of them. Only 19.6 out of this had to take medication, and 11.4% of the individuals took a leave of absence. Similarly, for fever, 30.3% of the population had fever, and it resolved in less than 3 days for all of them. And nearly 27% of them took medication for the same, and 1.6% of the population took a leave of absence. So other areas like rashes, blood clotting, paralysis, or anaphylaxis, they were not documented. None of our study population experienced these ADRs. So basically no serious side effects were documented, especially the ones requiring hospitalization. There was no difference in ADRs with respect to the vaccine, blood group, ferritin levels, or any other associated comorbidities. Now our study had a few limitations, one of them being that the sample size of the study is small. Second, that the interview was based on a recall method. So some of the participants may have forgotten about the intensity of the adverse effect. In conclusion, there were no serious adverse effects that were experienced by the subset of population that is thalassemia. There were no grade 4 or 5 adverse effects like anaphylaxis, and most side effects were mild and resolved in less than 3 days. So SARS-CoV-2 vaccine appears to be safe in patients with transfusion-dependent thalassemia. That's all. Thank you.
Thank you, Ms. Ivani Jain. Any judges having any question? Dr. Shruti, Dr. Prantar?
Questions? Thank you.
Dr. Shruti?
Neerav, that's my own paper. I think I'll have a conflict of interest. I should stay out of it.
Okay, ma'am. Okay. Okay. Thank you, Ms. Ivani.
Thank you.
Yeah. Dr. Shashi, you having any question? You need to unmute yourself.
Yeah. Hi, Vani. It's a good study. I just
Thank
like to have one question. What is the effect of COVID-19 infections in the thalassemia patients? It is more common in the thalassemia, more adverse effect in the infection cases, or the less as compared to the general population. Have you studied anything regarding to that?
Okay, so the only thing that we documented in our study was that 11%, that is 11 participants experienced, I mean, they were still infected with COVID even after getting the vaccine. So we can say that it's safe. The COVID-19 vaccine was safe, and it somehow helped keep this subset of population safe from the infection.
Like there's some studies are there which says the patient who has the thalassemia infected, they have the lesser infection of COVID as compared to the general population. So do you experience this kind of anything in your studies, and how you have ruled out the previous infection in the COVID? Have you taken any the PCR results? What is the baseline testing? The patient is not infected kind of thing.
Okay, so
Any antibody test is there or not to detect what are the antibody level at the time of study inclusion? Because you said after vaccination, maybe they have already have the infection or not. Is any antibody titer has been done or not?
Okay, so first we did not compare our study with the general population. So I can't really tell if it was better or worse. But what I can tell you is that a small proportion of our study participants did have COVID after the vaccination, as told by them. But we did not get them tested before we enrolled them in our study. So we cannot 100% say that, okay, they did not have COVID before, but we went with, because it was an interview. So we took their consent and then we administered the questionnaire, and whatever they documented in the questionnaire, we recorded that. So based on that, 11% of the population was affected with COVID after getting the vaccine.
Okay. Thank you.
Thank you.
Thank you, Dr. Shashi. Thank you, Ms. Ivani.
Thank you.
So now we'll move to the next paper. Is Dr. Mayank Doshi around? Sir, you need to unmute yourself. Sir, you need to unmute. Dr. Mayank?
Good morning, sir.
Yeah. Sir, is you can invite Dr. Mayank. Dr. Agarwal?
Okay.
Yeah.
Yes, sir.
Doctor, just a second. Huh?
Hello.
We have the second paper which got postponed because Dr. Mayank.
Yes. Second one. Yes.
Comparative study of rapid CAR test and nucleic acid amplification test for screening of HIV infection amongst blood donors at SRG Hospital and Medical College, Jhalawar. Presenting author is Dr. Mayank Doshi, who is PG resident in the Department of Pathology there, and the co-authors are Dr. Sumit Prakash Rathore and Dr. Nidhi Soni. So over to Dr. Mayank, please.
Good morning, everyone. So my paper title is Comparative Study of Rapid CAR Test and Nucleic Acid Amplification Test for Screening of HIV Infection among Blood Donors at SRG Hospital and Medical College, Jhalawar. So till date, there is no treatment for managing the acquired immunodeficiency syndrome, and the etiologic agent leading to AIDS is the human immunodeficiency virus. And mode of transmission is observed to be through unprotected sex, contaminated blood contacts, and vertically from mother to child. And there is no cure for AIDS, but the etiological factors by which the infection happens are quite recognized. Thus, the main stress has been placed to prevent the transmission of HIV. Since 1980s, various different methods of preventive therapies have been applied depending upon the type of infection so that HIV can be prevented. In various healthcare settings like blood banks, hospitals, the main initiative given is to fight against the transmission of HIV that mainly contain the thorough organization of blood products that are used for transfusion. This is done by evaluating the behavioral and biological characteristic of the subject who are doing blood donation, and further by doing a thorough examination of the collected blood that is used to recognize not only HIV infection but also various other pathological phenomena then can affect the blood donation temporarily or permanently. There are two different types of net, like individual donor net and mini-pool net. Both of these methods are approved by FDA, being the reliable ways of net testing. And it has been observed that screening methods using nucleic acid testing for HIV identification has reduced the rate of residual infection of risk being linked with transfusion of blood to around 1 in 2 million of blood units being taken from repetitive donors. The approximate decrease in the window period using the net testing for HIV infection is approximately 22 to 11 days. And in resource limited settings, the applicability of reasonable substitute screening methods like rapid diagnostic test can be used efficiently to safety of blood, especially in the additional rural settings where the little number of routine tests are carried out. So the objective of my study is to estimate the proportion of HIV infection among blood donors by rapid CAR test and nucleic acid amplification test, and to find the sensitivity and specificity of rapid CAR test against nucleic acid amplification test for screening of HIV infection among blood donors. It is a hospital-based cross-sectional study which is done for duration of 1 year from August 2020 to July 2021, and it is done at Blood Bank of SRG Hospital, Department of Pathology, Jhalawad Medical College, Jhalawad, and rapid CAR test was done at Blood Bank of SRG Hospital, Jhalawad, and net testing was done at R&T Medical College, Udaipur. In this cross-sectional study, a total 1,331 blood samples collected at Blood Bank of SRG Hospital, and they are sent for net testing at R&T Medical College, Udaipur. Rapid CAR test was done by using 4th generation HIV tridot, and net test was done individual donor nucleic acid testing by Proslix Ultrio plus assay for screening of HIV RNA on blood donor samples. All blood bank samples which are obtained from the blood donors and sent for net testing are included in this study, and hemolyzed blood bank samples are excluded. In this study, I found that according to rapid CAR test result for HIV infection, out of 1,331 samples, 2 was found reactive and 1,329 were non-reactive. And according to net result for HIV infection, out of 1,331 blood samples, 3 were found reactive and 1,328 were not reactive, and the percentage of reactive samples is 0.23% and non-reactive samples is 99.77%. We compared both the tests, and on comparison, out of 1,331 samples, 2 were found positive with rapid CAR test result, and 3 were found negative with positive with net result. And 1,329 samples were non-reactive with rapid CAR test, and 1,328 with net test. We compared both the tests and we found we estimate the accuracy, sensitivity and specificity of rapid CART test. There are two samples which were true positive. One sample is false negative. 0 samples are false positive and 1,328 sample are true negative. And according to these parameters, the sensitivity and specificity of RCT rapid CART test again net was 66.67% and specificity was 100%, and positive and negative predictive value were 100% and 99.2% respectively, and the accuracy of rapid CART test was found 99.92%. In this study, I concluded that RCT is a highly sensitive and specific test in identifying HIV infection in blood donors. So rapid CART test can be used in place of NET in resource limiting settings with high accuracy. Thank you, sir.
Thank you, Dr. Mayank. And if there are questions to you, we will just wait for the people to ask you. Yes, Dr. Shashi.
Hi, Bank. It's very good. The CART test is very good in a resource limited setting, but there's certain NACO guidelines are there when we select a GARD. So, what are the NACO guidelines for selecting any rapid CART test?
Ma'am, in present scenario, we the rapid CART test 4th generation is introduced for HIV1, HIV2, and P24 antigen.
Yeah, that's okay. But as a PG, you should be know what type of card has to be selected for the any rapid card, and what types of cards are there in the markets. Like there should be certain positivity, more than 99.5% positivity should be there, and less than 2% false positivity should be there for selection of the card. The cards are 4 types are there: vertical flow, then lateral flow, that kind, EIA. So different kinds of cards of there. Just giving a message in that platform, using the card is good, is not sufficient enough. You have to know what type of cards are available in the markets and what should be the specificity and what is the NACO guideline for the selection of a card is there. Secondly, your study has a very limited values because it's a selection of only 1,000 cases are there. The question mark arise, either the net is not good enough at the technical point of view, or the sample size too low to comment on the net effectivity, because you just say only one case was detected, but I don't think one case will be detected, because even at the ELISA we have seen so many cases will come which will come in positive in the ELISA but not coming positive in the rapid, because rapid is setting when the antigen antibody level is very high is there. So it's missed so many cases. In the routine case, we see that whenever the clear-cut case is there, then its card is positive. For ELISA, it has certain number of cases which are positive. And we do with the net testing, they come positive with either. So there is either the limitation in the term of sample size or the technical point of view on the net selection, or your maybe good in the donor selection is there. Thirdly, you have to know the NACO, what are the NACO guideline, and what are the generation, how many generation of ELISAs are available, which can also be alternative to the CART test in between the net. So in a resource limited setting, CART plus the ELISA, 3rd or 4th generation cost, and then the net. That is the sequence which is guided by the NACO. Thank you.
Thank you.
Thank you. Dr. Pranta, anything?
No, I totally agree, because otherwise message goes. So doing a large number of samples, looking at the false positives and all, I think as a pilot, this can have some value, but otherwise methodologically it has flaws which has already been explained. Thank you. I don't have it.
Thank you. So, Dr. Mike, thank you very much for bringing your work to the platform by Hematology Group. Grateful to you and your group for selecting. We'll move on to the next presentation. So, the 4th paper this morning is beliefs regarding SARS-CoV-2 vaccine in patients with thalassemia. Presented by Dr. Sukhmani Sidhu, intern, Department of Pediatrics, Dayanand Medical College and Hospital, Ludhiana, Punjab. Co-authors are Dr. Shruti Kakkar, Mr. Suraj Luthra, Ms. Shaina Kamboj, and Dr. Pranjil Sharma. So over to you, Sukhmani Sidhu.
Good morning, everyone.
Good morning.
Good morning, everyone. Today I will be presenting my study titled Beliefs Regarding SARS-CoV-2 Vaccine in Patients with Thalassemia. So COVID-19 was first identified in China, and it has led to significant amount of morbidity and mortality worldwide. SARS-CoV-2 vaccination drive in India was initiated on January 16, 2021 in a phased manner involving frontline workers in the first phase and then successively adding those who were at risk for a severe infection. So vaccine hesitancy is important in terms of COVID vaccines because they were approved and developed very quickly. Vaccine hesitancy is the tendency to delay or refuse vaccination when it is available. So a study done in 2016 also explored the various environmental, agent-related, and host-related factors that could lead to vaccine hesitancy. Thalassemia and COVID-19 are important together because there are many patients of beta thalassemia in our part of the country, and they have underlying complications due to iron overload that make them at high risk for developing a severe infection from COVID-19. Therefore, vaccine acceptance in this subset of patients towards COVID-19 vaccines is important. So we wanted to evaluate the proportion of the thalassemia patients who were already vaccinated against SARS-CoV-2. We wanted to assess the beliefs regarding these vaccines and to assess the various factors that could influence vaccine acceptance in these patients. So we did a cross-sectional survey involving all the adult transfusion-dependent THAL patients registered with our Thalassemia Daycare Center during the months of June and July 2021, after taking an informed consent and approval from the Institutional Ethics Committee. We used a study questionnaire to collect their demographics, their vaccination details, their vaccine hesitancy towards COVID vaccines, and their knowledge regarding thalassemia, COVID, as well as COVID vaccines, and the probable reasons that could lead to vaccine hesitancy. So we asked them, if you have not been vaccinated yet, do you plan to get the COVID vaccine? The first response indicated that they were motivated. Second indicated they were not sure. And third indicated that they do not wish to get the vaccine. We assessed their knowledge in terms of 5 questions regarding vaccines, 19 questions exploring the probable reasons that could lead to vaccine hesitancy, and 2 questions were based on the knowledge regarding COVID-19 in thalassemia. So these 19 questions of vaccine hesitancy were graded as yes, no, maybe, and do not wish to answer. Then we split all these patients into 3 groups. The first group included the vaccinated patients. The second group indicated those who were willing for vaccination, and the third group were those who were either hesitant or resistant towards vaccination. Statistical analysis was done using chi-square test, and we took a p-value less than 0.05 as significant. So the results of our study were as follows. We analyzed 145 patients with a mean age of 25.6 years and a male-female ratio of 1.46:1. Out of the total 145 patients, 69 were unvaccinated at that time. The vaccine hesitancy came out to be 46.3% out of those unvaccinated patients. The vaccine hesitancy by gender was higher in males compared to females, with about 51.2% of the unvaccinated male patients refusing vaccination. The awareness regarding vaccines was higher in the vaccinated patients compared to those who were unvaccinated. There were differences when it came to which vaccine was preferred. Covishield was the most preferred vaccine, and the patients quoted safety, effectiveness, and the fact that their family members were vaccinated with the same as reasons for their preference. So to explore the various reasons that can lead to vaccine hesitancy, we saw that significantly higher proportion of the vaccinated group considered the vaccine to be safe compared to the vaccine hesitant group. Similar trends were seen in terms of effectivity of the vaccine in preventing both infection with COVID as well as preventing severe infection. the vaccine having serious side effects was agreed upon by almost equal proportion of patients. Also, the disbelief that the vaccine will introduce virus into their body and lead to infection rather than immunity was significantly more in the vaccinated group. They disagreed with it compared to the vaccine hesitant group. So the preference of a nasal vaccine over an injectable vaccine was reported by considerable amount of people in all the three groups. However, the group A, who were already vaccinated, were also disagreed by a large amount, thereby implying that they are comfortable with an injectable route as well. The environmental factors that can lead to vaccine hesitancy showed us that significantly more proportion of vaccinated people trusted the government in providing the best vaccine compared to the vaccine hesitant population. They also considered that the CoWIN portal, which was made for registering themselves for the vaccination, was easier to use compared to the vaccine hesitant population. And a very high proportion of our study population considered that news and social media have impacted the vaccination drive. So the host-related factors, a significantly higher proportion of the vaccine-hesitant population considered that the vaccination site is really far away from where they live. They also feared that they'll have to wait in long queues for vaccination. On being asked that do you think you will catch COVID at the vaccination site, significantly higher proportion of the vaccinated people disagreed compared to the vaccine-hesitant population. So the preference of a door-to-door vaccine over going to far-off places was also preferred by a large proportion of our study population. However, still 60% of the vaccine-hesitant people will not take the vaccine even if a door-to-door campaign is started. So on questioning them about their beliefs of having COVID due to thalassemia, 43% patients in the vaccinated group considered themselves at high risk of a severe infection due to underlying thalassemia. And the disbelief that COVID-19 vaccine is not safe in them due to thalassemia was reported by significantly higher proportion of vaccine hesitant population. Therefore, to conclude, we felt that the acceptance of COVID vaccination has challenges in this subset of population as well. And about 22% of the entire study population was vaccine hesitant. There were concerns regarding safety and efficacy of the vaccine. And there was also other reasons like mistrust of the government, as well as logistics of reaching far-off vaccination sites that can lead to vaccine hesitancy. Thank you.
Thank you so much, Sukhmani. That's very, very interesting observations. So open for discussion, comments, questions.
Yeah, I think this is a significant work. I am aware that in certain thalassemia patient groups, it was being circulated in WhatsApp that if you take the vaccine, you have a higher chance of thrombosis. Okay, so did that have an impact? I just wanted to know.
So
because some patients shared with me. Yeah.
Yes, sir. Yes, sir. So when we made the questionnaire, we specifically included people from community medicine department for this purpose, so that they can tell us what probable reasons we should be asking. And when we gave them the questionnaire about serious side effects, we gave them the option of fever, shivering, body aches, myalgias, and then thrombosis. And to our surprise, I don't think so any person reported thrombosis in that questionnaire. That is why we did not mention it during our results, because that wasn't a significant finding in our study.
Thank you. Thank you.
Thank you, sir.
Thank you. Any other question or comments? None. Then thank you so much, Sukhmani. We will move to the next paper, and just to tell all of you that the results of the best paper will be announced tomorrow at 8 p.m. So do log in. You never know, yours may be the best paper or the best one of the 3 papers on the top. We'll move on to the next one. So the 5th paper this morning is impact of COVID-19 on pediatric hematopoietic stem cell transplants. Our center experience to be presented by Dr. Amit Jain, Junior Consultant, Pediatric Hematology Oncology, MCGM Comprehensive Thalassemia Care, Pediatric Hematology Oncology in PMT Center, Borivali, Mumbai. Co-authors of this paper are Dr. Rajesh Patil, Dr. Pranoti Kini, Dr. Ashutosh Walawalkar, Dr. Sriraksha G, Dr. Paulami Das, Dr. Santosh Khude, Dr. Nidhi Mehta, Dr. Ratna Sharma, and Dr. Mamta Manglani. So, Amit, over to you.
Yes.
Thank you, sir.
Thank you, sir.
Howdy.
Good morning, everyone. So now we are 2 years down the line into the pandemic, and we have seen that it has affected drastically to the mankind. So today I'll be sharing our experience of impact of COVID-19 on pediatric hematopoietic stem cell transplant. Sir, is my slides visible?
Visible. You can only make it slideshow mode.
Yes, sir. Just
Made it. You made it.
Yeah, done.
so. As we all know that COVID-19 pandemic emerged in beginning of 2020, and it has impacted especially healthcare infrastructure services across the world. So especially in the field of hematopoietic stem cell transplant, the challenges encountered are COVID-19 infections in patient, donor, or health personnel, access to healthcare because of lockdown, lack of guidance initially in the beginning of pandemic, shortage of blood and blood products, and inaccessibility to unrelated stem cell donors. So with the beginning of pandemic, we as a team formulated and implemented the policies to ensure smooth functioning of our unit. These were even before the recommendations from various scientific societies. So the objective of our study was to assess the effectiveness of the policies implemented during pandemic, to assess the response based on total number of HSCTs, autologous versus allogenic HSCTs, benign versus malignant transplants, urgent and elective transplant, and type of donors. Along with that, the number of transplants postponed due to COVID-19 infection among patient, donor, or attendants, and its effect on outcome. Then comparison of outcome of patients who underwent HSCT during the COVID-19 pandemic and those who underwent prior to the pandemic. So when the country declared lockdown in March 2020, we halted admissions of new patients while awaiting discharge of admitted patients. As we started learning more about the pandemic, we decided policies for our center, which were implemented, like training of staff about COVID appropriate behaviors like social distancing, mask and sanitization, symptom screening at the point of entry. No visitors were allowed during the pandemic. Only one caregiver was allowed with the patient. Creation of isolation ward. Then difference of all non-emergent transplants, and the review and modifications of our policies in accordance with changing national and international policies. Then there was rotational duties of staff to decongest the hospital and teleconsultation. So policies specific to HSCTs were like I mentioned, all non-urgent transplants were deferred. Only time-bound HSCTs for malignant or benign transplants were indicated. Testing of COVID-19 infections irrespective of symptoms in patient, donor, or attendant. Donors who had COVID-19 infections or contact were not permitted for donation for at least 4 weeks initially, for later 2 weeks based on guidelines. Then conditioning was begun only after the patients tested negative for SARS-CoV-2 RT-PCR, which was 7 days apart twice. So it was a retrospective analysis. We divided our cohorts into 2 groups. The timeline in each group is 18 months. The group A consisted of pre-pandemic patients between October 18 and March 20. And group B had patients between April 20 and October 21, that is during pandemic times. So we analyzed parameters and compared like number of HSCTs performed, autologous and allogenic HSCT, benign and malignant, urgent versus elective, type HSCT based on type of donors, survival at day 100, and number of HSCT postponed due to COVID illness and its effects on outcome. We used chi-square test as statistical analysis, and p-value of 0.05 was considered as significant. Coming to results of our study, so the major impact of COVID-19 pandemic on HSCT was that we have to shut down our unit for brief duration of 6 weeks in May, June because of some uncertainties of the pandemic. To our surprise, none of our patient, donor, or attendant developed COVID-19 infections during stay in hospital for the transplant. So number and type of transplants, the numbers are comparable even in autologous and allogenic, and p-value being non-significant. So when we compare benign versus malignant transplant, the numbers of benigns were significantly less than malignant transplant because of the policies we implemented. The number of transplants in elective were reduced. However, p-value was not significant. As we shift from match-related donor to haploidentical transplants, the number were increases in Group B because of the indications of transplant in Group B were most of the malignant transplants. However, the p-value was not significant. When we compare day 100 survival in Group A and Group B, it was non-significant and the results were comparable. So there were 7 patients in which we have to delay HSCT because of COVID-19 infections in either patient, donor, or attendant. All these patients were of malignant indications, and infections in them were either asymptomatic or mild infections. They have a median delay of 14 days, range being 14 to 17 days. And outcomes were not affected. The survival in all these patients were 100% at day 100. So we find a similar study in literature by Morar et al., in which they divided the cohort into 3 groups. Cohort A consisted of 3 months. Cohort A is 3 months duration into the pandemic. Cohort B is just before pandemic with similar duration, and cohort C is similar duration with 1 year before the pandemic. So when they compared the pandemic versus non-pandemic group, the results were non-significant, like in our study. So we conclude that the timely implementation of appropriate policies in the situation like COVID-19 could help to tide over the crisis. And as we see in our study, we managed to do as many as transplant as in the pre-COVID era with optimal outcome. Thank you.
So thank you so much, Dr. Amit. Open for discussion.
So,
yeah. Director again.
We again feel that this should be documented, and the guidelines which were led will help us in fighting all our pandemics. Thank you very much to the entire team. I have no questions.
Okay. Anybody else? Shashi, you want to ask something?
I think it's pandemic have created opportunities of so many pupils, and everybody have done their best. So what next we have concluded from the study is not very what you have done great in that. Everybody was doing like that in last 2 years. They are doing best of that. You got the delaying the procedure is not reducing your survival.
Yes.
Is it what do you say?
So, ma'am, even during pandemic, we continued our transplant. We continued functioning of our transplant unit. The only difference is that we halted benign transplant and non-urgent transplant.
Okay, so that means the benign transplant can wait for some time, but not the malignant one.
Yes, ma'am.
Okay, thank you.
Transplant should be done.
Thank you, Dr. Shashi.
Yeah.
If anybody else wants to ask anything to Dr. Amit? Okay, so Amit, thank you very much, and be with us tomorrow at 8 p.m. when the results will be announced. And
yes.
That brings us to the end of the morning session of our presentations. We are going to have a little longish break, and we reassemble at 1:30 p.m. when Dr. J.C. Patel Best Paper Award session will begin. We have 15 papers in that session, and that session will go on till 6 p.m. Thank you very much. Good afternoon, friends. Day 1 of 45th Annual Conference of Hematology post-lunch session. This session will be right up to 6 p.m. and we have 15 presentations for Dr. J.C. Patel Best Paper Award session. Our judges are Colonel Dr. Rajan Kapoor from Kolkata, Dr. Sharat Damoda from Bangalore, Dr. Prantar Chakrabarti from Kolkata, Dr. Priyanka Samel from Bhubaneswar, and Dr. Akanksha Garg from Ahmedabad. The abstracts submitted by you have been studied by them well, and they will be listening to you today and decide who is the real winner for Dr. J.C. Patel Best Paper Award session. Name of the winner will be announced by them tomorrow at 8 p.m. Sunday, 13th of March, 8 p.m. So please log in before that, and who knows, you may be the winner. We begin with the first paper. The title is Decoding Blocks, Thrombosis Evaluation and Management at Tertiary Care Pediatric Hospital. Presenting author is Dr. Trapti Dabale. She is FNB trainee, Department of Pediatric Hematology and Oncology at Bhai Jabai Wadia Hospital for Children, Parel, Mumbai. Co-authors of this paper include Dr. Ritika Khurana, Dr. Archana Swami, Dr. Sana Khan, Dr. Siyog Nagre, Dr. Ekata Sharma, Dr. Vaibhav Chadda, Dr. Dhara Singh, Dhara Shah, and Dr. Sangeeta Modlia. So over to Dr. Trupti.
Good afternoon, everyone. I will start my presentation on thrombosis. We'll start the screen sharing now. Sorry for the technical error.
Madam, we cannot see your slides, ma'am.
Sorry, I'm not able to share my screen.
So should we share it from our end, ma'am? You want to share it from our end?
Yes, sir. It will
Just
be
a second. Just a second.
Thank you.
Hope you can see the screen, ma'am.
Yes, yeah, I can.
Okay, while you want to change the slide, just let us know by next. Okay.
Okay, sir. So I will start my presentation. So the title of my study is Decoding Blocks, in which I am going to see the thrombosis evaluation at the Tertiary Care Center, Pediatric Hospital. I am Dr. Trupti Dabale, FNB trainee at the Department of Pediatric Hematology and Oncology, Bhai Jabai Wadia Children Hospital. So next. So we'll go ahead with some background and the epidemiology of the pediatric venous thromboembolism. So like with the increasing clinical awareness, the pediatric thrombotic conditions are increasingly being diagnosed and treated. The overall incidence of venous thrombosis in children is around 0.07 to 0.149 per 10,000 children. But the incidence has increased in the hospitalized children to up to 100 to 1,000 times more, and it is around more than 58 per 10,000 admission in hospitalized children. The arterial thrombosis is less common compared to the venous thrombosis in children, and majority of it is found in the arterial catheterization, and the non-catheter arterial thrombus are rare compared to the venous. And there is a bimodal age of presentation in the thrombosis. More is seen in the infancy and in the adolescent age group. So next. So higher rates of thrombosis are majorly seen in the hospitalized children with a central venous line in situ. The child is convalescing from the major surgery, and the common in the child with the underlying malignancy. So more than 90% of the pediatric thrombosis have some underlying risk factor, either inherited or acquired. And the most common single risk factor is a venous access device, which account for more than 90% in the neonatal thrombus and 50% in the pediatric thrombus. So recent advances in the field of anticoagulation therapy now made it possible to reduce the mortality and morbidity which is associated with the thrombosis in the pediatric age group. So we'll start with my study. The aim of my study is to see the clinical and laboratory evaluation of the thrombosis in the pediatric patient that is presented to tertiary care pediatric center. So objective of the study is to evaluate the clinical presentation and underlying risk factor, and also to look for the indication of the extensive prothrombotic workup. So method I take the retrospective data of the patient who presented with thrombosis to upper department during the one span of age, also with the one span follow-up data taken. The data, it contains the detailed clinical history that includes the site of thrombus, underlying illness, precipitating factors, also investigation done like imaging findings and the further relevant workup if done. So result of my study, around 14 patients were presented in thrombosis during the 1 month period, that is the December 2021. Out of these, 8 were the male and 6 were the female. Presenting age ranges between the 1 month to 15 years, out of which we got 2 picks in the 1 year to 5 years of age group, 6 patients, and 10 years of 15 years, we got the 5 patients. Though we saw that arterial thrombus are rare compared to the venous thrombus, but being considered our the tertiary center, we got a 5 patient with the arterial thrombus and 9 patient with the venous thrombus. Next. So out of these 14 patients, 5 were had the underlying malignancy. Next. So we'll see the data in detail. So next, okay. So 14 patients are presented with thrombosis, out of which 5 were with the arterial thrombus. So one patient had the underlying malignancy, acute promyelocytic leukemia. He presented with the multiple site thrombus, that was arterial. Then 4 patients were without the underlying malignancy, out of which one child was a sickle cell, known case of sickle cell disease with a ICA infarct. Other child was a known case of arthritis with a TB and had a multiple site thrombus. One neonate present with a seizure and found to have a CNS thrombus. The adolescent girl was found to have a ACA infarct. Then 9 children who had a venous thrombosis, out of which the 4 patients were had underlying malignancy. Out of these, 3 patients were have a underlying PICC line and that leads to PICC line thrombosis. The 4th child the child was in pre-BLL in induction, had a disseminated aspergillosis with the CNS thrombosis. So other patient that had a venous thrombosis without underlying malignancy, out of which one had a MDR lymph node TB with IgV thrombus. One child with a refractory status epilepticus with a multiple site thrombus. The child with a lupus nephritis presented to renal vein thrombosis. One neonate with a SMV thrombosis, and one child with the EHPO had a SMV and portal vein thrombosis. I would like to tell the details of this patient in the upcoming slides. So next. So when we'll start with the child who is having the underlying malignancy. First, we'll start with the child 4-year-old. These are the 3 patients who had an underlying PICC line as a risk factors, out of which 2 patients were in the pre-BLL and in the induction phase. So all of them were presented with the tenderness and redness over the PICC line site. We did a Doppler USG as a imaging to look for the site and the presentation of thrombus. So we found the thrombus in the like in the first child, we found the thrombus in the right basilic vein around the PICC line. For the same, we start the child on the low molecular weight heparin, and we got a good response in the follow-up, like decrease in the size of thrombus. And we were able to secure line in all of these 3 patients. So there were the different site of presentation, but all there have the underlying risk factors like PICC line. They were also in the induction, so we're on the steroids and the L-asparginase. So next. So one of our patient, 11-year male child who had an underlying malignancy at acute promyelocytic leukemia. On presentation only, he presented with a discoloration at the multiple site, like at the hand, toe, fingers, arms, and forearms. For which we did a Doppler, in which we found the thrombus over the left distal brachial artery, radial artery, ulnar artery, and in the right radial artery. The child has an extensive gangrene for which he required amputation, but we put the child on low molecular weight heparin and aspirin. Now the child is improving. The thrombus part is improving, and overall the child is in the good state now. So another child was a 4-year-old male child who had underlying pre-BLL, and in the induction phase come with a fever, lethargy. On the imaging, we found that the child is having the disseminated serous aspergillosis, and the MRI brain shows a necrotic area with absence of perfusion, restricted diffusion, and hemorrhagic foci in the parietal lobe. So this child has an underlying fungal infection, and being a malignant, this child is we started him on the low molecular weight, but ultimately this child succumbed to his underlying illness of disseminated CNS aspergillus and thrombus. So next. So now we'll start with our child who is presented with a known underlying illness, but not with the malignancy. So our first child is a 4-year-old male child who was a known case of sickle cell disease and not with a regular follow-up with us, presented to us in the acute gastrointestinal inflammation and dehydration with a seizure and a right hemiparesis. So we did imaging in which CT brain we could found the non-hemorrhagic infarct in the left MCA territory, and Doppler shows a chronic occlusion of the left ICA. So the underlying risk factor for this child was a dehydration and also the sickle cell child. We start him on the low molecular weight heparin, aspirin. He required a craniotomy for this for his presentation and illness. And the child is now put on the exchange transfusion. On follow-up, there is a decrease in the size of thrombus. Another child is a 12-year-old female child, known case of MDR-DB with a lymph node abscess. Child was asymptomatic, but on imaging, we found that there is a IJV site thrombus. For the same, the child was put on low molecular weight heparin, and on the follow-up, there is a decrease in size of thrombus. Another female child who is a known case of arteritis with a TB had a presented with a discoloration over the leg. So Doppler of the lower limb found the thrombus over the anterior tibial artery, posterior tibial artery. Also, the CT abdomen shows an aneurysm of aorta. There was a occlusion of bilateral anterior tibial artery, deep peroneal artery. So this child, there was a two underlying risk factors. This child was already on steroids and prolonged immobilization. So both could lead to thrombus formation. We work up only for sickle cell, in which it was a negative, and homocysteine levels were also normal. So we start the child on low molecular weight heparin and aspirin. Our plan is to continue the slight prolonged course of low molecular heparin for this child. Next. So another patient is a known case of fever-induced refractory status epilepticus with sepsis, presented with the swelling over the right leg, which had a central line in C2. On CT, abdomen and chest confirmed there is a embolism. Also, MRI brain and MRV also shows a thrombosis in the superior sagittal sinus. So for this child, we have to remove the line and also start on the low molecular weight heparin. In other workup, we could find that this child has an increased homocysteine level. For the same, we start the child on low molecular weight heparin and other B12, B6 and all supplementation. So we got one male child who are presented with a seizure on day 4 of life. On MRI brain, we got the non-hemorrhagic infarct, and also MRI, there was an absence in the anterior cerebral artery, absence of flow in the anterior cerebral artery. This child's mother had a bad obstetric history, and on the evaluation, this mother is found to have the antithrombin 3 deficiency. But we work up for the child, which turn out to be normal. Currently, we put the child on the low molecular weight heparin, but our plan is to evaluate the child further after 6 months of age. So next. This is the next slide, which is showing a known underlying cause without the malignancy. We are continuing with the same data. So this is a 10-year-old female child who is a known case of lupus nephritis with a nephrotic syndrome and a hypertension. On Doppler found to have the renal vein thrombosis. There was an underlying risk factor that the child is already on the steroids. So now we are planning to we plan already the child on the low molecular weight heparin, but because of her underlying illness, she succumbed to the life. So another child at 1 month of age presented with abdominal distension, dehydration, and decreased urine output. On Doppler, we found there was a subacute portal and SMV thrombosis with a portal cavernoma and gross ascites. So at presentation, we thought the underlying risk factors was a dehydration, and further workup, we found the child was having an increasing homocysteine level. The child is now put on the low molecular weight heparin and B12 and B6 and folic acid supplement. Currently, the child is doing well. We will plan to work up further after the child will be more than 6 months of age. So next. So now we'll see the non-malignant child with no underlying risk factors. So our first children is a known case of EHPVO presented with the abdominal distension, and Doppler we found the portal cavernoma with a chronic portal vein thrombosis and SMV thrombosis. There was a no underlying risk factor in this child, and we work up for the same, and the workup reports were normal. Currently, the child is on low molecular weight heparin and doing well. Another child is a 15-year-old female child presented to us with a diplopia, deviation of angle of mouth to the right side, swaying while walking. On examination, there was a left-sided facial palsy. On imaging, it is showing the MRI brain imaging showing the non-hemorrhagic infarct in the right thalamus and the cerebral peduncle. MRA suggestive of ICA thrombus. So on presentation, there was no any underlying risk factor, but when we work up for the further investigation, we found the child was having a hyperhomocystinemia with the sickle cell trait. So now the child is started on low molecular weight heparin, aspirin, and the B12 and B6 supplements. Currently, the child is doing well. Next. So how we go ahead with the child, like for the workup, we do the radiologic workup just to confirm the site of thrombosis and whether the thrombosis is there or not.
Dr. Trapti, how many more slides you have?
3 slides, sir.
You'll have to pick up.
Okay, sir. So next. Okay, next. So these are the radiological workup we did at our center, like to confirm the thrombus, USG Doppler in the PICC line or limb thrombosis or in the neck thrombus. In MRI brain to look for the CNS thrombus, MRA, MRV for the site of thrombus, and CT scan. So this is thrombophilia workup which we do at our center. This is not a standard of doing, but we do like level 1 thrombophilia workup we do is CBC with hematocrit, WBC and platelet count, protein C activity, free and total protein S antigen, sickle cell by HPLC, antithrombin 3, prothrombin mutation, and then fasting homocysteine level, factor V Leiden mutation, and lupus anticoagulant. Level 2 workup, just click level 2 workup includes plasmin. If we found everything normal and if we want to find out the cause of thrombus, then we go for the level 2 thrombus, which includes the plasminogen, dysfibrinogenemia evaluation, which includes the fibrinogen, thrombin time, and the degradation product. Level 3, that also if we couldn't find the cause, then we further look for the PNH workup and plasminogen activator inhibitor. Next. So appropriate time to screen is at the 4 to 6 weeks interval after the acute thrombotic event. Also 4 to 6 weeks interval after the use of anticoagulant or thrombolytics. Thrombophilia test that we can do even if the child is on anticoagulant is the anticardiolipin antibody, anti-GB2 GP1, factor V Leiden mutation, thrombin gene mutation, and homocysteine level. So next. So take-home message from our side is, if the in children with a malignancy, we should have a high index of suspicion of thrombosis. So timely investigation should be done. As most of the patients with thrombosis have the underlying risk factors, so extensive and expensive prothrombotic workup is not always warranted. And sickle cell is one of the known risk factors in children with thrombosis, and they should be screened for the sickle cell. Duration of anticoagulation is depend on the underlying cause of the thrombus, and line removal is not always necessary, as most of the line can be salvaged with a prompt medical management of the thrombosis. Thank you.
Thank you, Dr. Tripti. We aren't left with much time to ask you questions, but still I'll ask you one question from my side.
Yes, sir.
Looking at the literature, what is one new finding that your presentation contributes?
What, sir? I didn't get the question, sir. Sorry.
You are competing for a prize. So we want to know your presentation and your workup. It's a beautiful workup, clinical real life story of thrombosis in children, veins and arteries. So what is one new data or finding that you have generated which is different from what is existing in the literature?
So, we always got some underlying risk factor with the thrombosis, so we should not go directly for the all thrombophilia workup in the children. As a careful history and the careful knowing the risk factor could avoid to go for the extensive thrombotic workup, thrombophilia workup. Also, as most of the clinician think that if line is there, it should be removed with the thrombus. But if we take the prompt management and if we secure the line, then in the child with the cancer who will require the line for the further management, so we can save the line for this patient with the prompt management.
So are these two things not there in the literature?
These are the line as per the ASH guideline. They are saying we could save the line if there is.
We have two judges here, so at least one question from each one of them. Dr. Akanksha and Dr. Prantal.
I think present as an you have to and the things because I don't have any question. Oh.
Yeah, I'm so sorry, you're not audible properly. Akanksha, you have a question? Okay, anyone else wants to ask any question to Tripti? Okay, then Tripti, thank you very much for a wonderful presentation and be there tomorrow at 8 p.m.
Yes, thank you, sir. Thank you, sir. Thank you for giving the opportunity, sir. Thank you, sir.
So we move on to the second presentation.
Hello.
Is my slide visible?
Just put it full screen, sir.
It's visible. Okay, leave it. We have second presentation as thromboelastography, determined fibrinolysis shutdown and its correlation with complications and outcome in patients with coronavirus disease 2019. Presenter is Dr. Tushar Sehgal. He's Assistant Professor, Department of Lab Medicine, AIMS, New Delhi. Co-authors are Dr. Mukul Agarwal, Dr. Upendra Baitha, Dr. Gaurav Gupta, Dr. Bindu Prakash, Dr. Ganesh Kumar V, Dr. Ashutosh Biswas, Dr. Shalimar. So over to you, Dr. Tushar.
Thank you, sir. So is my screen visible?
Yes.
Yes, sir. Just put it slideshow.
So, is it okay now?
Not yet.
Not yet.
We can see the slide, but it is not in slideshow.
Do you have my presentation with you?
Neerav?
Yes, sir. Just we are sharing. Just a second.
Share it, yeah. Okay. Then you stop sharing, Tushar.
Okay, sir.
Tushar, can you see it?
Yes, sir. It's visible, sir. Should I continue, sir?
Yes, sir. You can continue.
Yes. Good afternoon, everyone. The topic of my presentation today is thromboelastography determined fibrinolysis shutdown and its correlation with complications and outcomes in patients with coronavirus disease 2019. Next slide, please. So, as we all know that COVID-19, the short form of coronavirus disease, is caused by severe acute respiratory syndrome coronavirus 2 virus, briefly called as SARS-CoV-2. It predominantly affects the lungs and causes pulmonary disease, including pneumonia, and has fatal respiratory complications like ARDS and respiratory failure. But apart from these pulmonary complications, the coronavirus disease is also associated with coagulopathy. Next slide. So coagulopathy is a frequent and a severe phenomena in these patients, and it was first studied in a large comprehensive evaluation by Tang et al. In April 2000, in which he showed that 71% of the non-survivors exhibited DIC, which is disseminated intravascular coagulation, and such in these patients there was a unique phenotype of DIC with a propensity towards thrombosis rather than a bleeding diathesis. Next slide. So this coronavirus associated coagulopathy is called as CAC or CAC. This CAC is different from the regular DIC by the following points. DIC has moderate and severe thrombocytopenia, whereas CAC has mild thrombocytopenia. The D dimer is elevated to significant levels in CAC, up to 4-fold in some cases, and there is minimal prolongation of APTT and PT. On the other hand, in DIC, prolongation of PT in APTT is markedly prolonged. There is increased fibrinogen in COVID-associated coagulopathy, whereas in DIC, we all know that fibrinogen has lower value. Next slide. So to assess coronavirus associated coagulopathy, we can do either the conventional clotting tests, which are the PT, APTT, and INR, or we can perform thromboelastography. So thromboelastography is a global viscoelastic technique which can assess the overall coagulation function in a better way, because it assesses the platelet also, which is not assessed by the conventional coagulation test. The conventional coagulation tests rely on platelet poor plasma rather than the whole blood. Therefore, the assessment is not complete. So we aim to assess the various abnormalities seen on thromboelastography and explore the predictors of outcome in our patients. Next slide. So we conducted the study at COVID care facility at AIIMS New Delhi. This was approved by Institutional Ethics Committee, and the diagnosis was of the coronavirus was based on the RT-PCR chain reaction. The severity of COVID-19 was as per the MOHFW India guidelines. All the patients admitted in this study were given low molecular weight heparin, 40 milligram once a day in moderate and severe category. Next slide. So these patients were included, which were 18 to 65 years of age with coronavirus infection admitted to the hospital, and those underwent TEG assessment. Patients with prior vascular thrombosis, pregnancy, malignancy, any prior history of platelet drug, and aspirin, clopidogrel were excluded from the study. Also, patients with chronic liver disease, chronic kidney disease were also excluded from the study. And those patients who were expired on admission were also excluded from the study. So this is the basic diagrammatic representation of the thromboelastograph. So this is the instrument. You can see the instrument. So this is the chamber in which the reaction occurs. So the sample received is in the form of citrated sample. The citrated sample is put into the cup. So the cup is always oscillating and the pin is stationary. When the blood is loaded in the cup, the blood also oscillates. And when we add kaolin, which is the activator, and heparinase to nullify the effect of heparin, there is a reaction which takes place. There is a reaction forms the fibrin clot. This fibrin clot attaches to the pin, and so the pin, which is stationary, now keeps on moving. So it generates a thromboelastogram. Next slide. This is how a thromboelastogram looks like. There are two phases: clot formation, fibrinolysis. The clot formation is further divided into enzymatic reaction and polymerization reaction. It is depicted by the R time, or the activated clotting time. Polymerization is depicted by K time and the alpha angle and the maximum amplitude. In the fibrinolysis phase, we have MA, which is actually representation of the clot strength, which is contributed by platelets and fibrin. And then we have lysis, which takes place after 30 minutes, depicted by lysis at 30. So this is the classical normal thromboelastogram, which is actually a leaf-like picture. Next slide. So clinical laboratory data were obtained from the patients, from their case files, the comorbidities, COVID severity. The various tests were done: hematology tests, biochemical tests, coagulation tests from the automated hematology analyzers and biochemistry analyzer, as well as the coagulation analyzer from Diagnostica Stago France. Next slide. These were the statistical analysis which were performed. Next slide. So these are the results. So we obtained the thromboelastography results from the whole cohort, the normal and the hypercoagulable. So it was classified into normal and hypercoagulable state. So total patients were 27. Normal patients with normal thromboelastography were 8. Patients with hypercoagulable thromboelastography was 17. And these are the p-values. You can see the age and the gender is almost similar in the normal and hypercoagulable group. Patients with hypercoagulable had more diabetes and more hypertension. Patients with hypercoagulable had more severe and moderate COVID intensity. They had more acute kidney injury, and the overall mortality is also higher in hypercoagulable group as compared to the normal group. Next slide. Also, when we compared the laboratory parameters in the two groups, we found that patients with hypercoagulable group had low hemoglobin, higher platelet count, high CRP, which was almost like 6 times, high ferritin, higher urea, and higher creatinine. And CRP was found to be clinically significant. Also, the ALP was high. Next slide. Tabulating the coagulation profile of these patients, we found that the D-dimer was on the higher side of 882. Fibrinogen was 569, which was statistically significant. The various TEG parameters were also statistically significant: R time, K time, alpha angle was markedly high in the hypercoagulable group as compared to the normal group. The maximum amplitude was higher as compared to the normal group, and the clot index was also higher in the hypercoagulable group. All these values were statistically significant. Next slide. So we also observed 4 patients with fibrinolytic shutdown. These 4 patients were 3 males and 1 female. Two had mild COVID infection, 1 had moderate COVID, and 1 had severe COVID infection. You can see all the patients had elevated fibrinogen and elevated D-dimer values. Next slide. So also assessing the TEC parameters in this group of patients, we observed that K time was markedly low in these patients. Angle was high in 3 patients. The maximum amplitude was higher in all 4 patients. Also noted is the clotting index, which was higher in all patients and giving the hypercoagulable state. Next slide. So this is the diagrammatic representation of the fibrinolytic shutdown which was observed. You can see that R time was within normal limits, K time was shortened, alpha angle which was 80, which is high, maximum amplitude was high, the clotting index was markedly high. The lysis was 0. So this is the graph showing the high MA value and there is no lysis at all. So impression was hypercoagulable state with fibrinolysis shutdown. Next slide. And these are the representation of the normal hypercoagulable and hypocoagulable phenomena. You can see in hypercoagulable, the MA is high, R time is short, whereas in the hypocoagulable, the R time is markedly prolonged and MA is short. Next slide. So when we compare this whole cohort versus the fibrinolytic shutdown, we found that these patients were younger patients, more males were there, and they were hypertensive, and the new AKI was more in these patients, and the mortality was also higher. Next slide. Similarly, the lab parameters were deranged more as compared to the whole cohort. They had low hemoglobin, they had high TLC, they had high platelet count, the inflammatory markers markedly elevated, ferritin, CRP, all were elevated. The LFT were deranged. Next slide. Also, when we compare the coagulation parameters, again, we found that D-dimer was high as compared to the whole cohort. Fibrinogen was high. R time was on the lower side. K time was on the lower side. Alpha angle MA was high, showing a hypercoagulable state. Next slide. So when we estimated the Kaplan-Meier estimated, we found that the median follow-up of these patients were 21 days. 10 patients died, of which 1 was in the normal TEG category, 7 were in the hypercoagulable category, and only 2 were in the hypocoagulable category. Next slide. So discussion. We found the distinct coagulation abnormalities in COVID-19 patients. Hypercoagulable state was most common, seen in 2/3 of the patients. Abnormal coagulation parameters, patients with abnormal coagulation parameters had high mortality, and this high mortality was exaggerated by the fibrinolytic shutdown caused by the plasminogen activator inhibitor and TAFI. So next slide. So this is the diagrammatic representation of what happens in the body when coronavirus and causes endothelial injury. So this is the coronavirus depicted by this this cartoon, showing binding to the endothelium by the ACE2 receptor. This attaches to the endothelium, causing endothelium injury, causing the generation of the coagulation cascade, causing fibrinogen generation, thrombin generation, and fibrin. And also this cytokine storm, which is generated in the alveolar macrophages, augments this coagulation cascade. This coagulation cascade generates fibrin, which is normally cleaved by urokinase and plasminogen activator. But in coronavirus infection, this is suppressed, and there is increased PI1 and TAFI, which suppresses the fibrinolysis and hence causing fibrinolysis shutdown. Next slide. So therapeutic implication, currently 50 RCTs are going for the usage of thrombo TPA in the coronavirus, and they have shown improvement in a few scenarios, but there is suggestion for redosing, higher dosing, and addition of anticoagulation therapy also. Next slide. Next slide, please. So conclusion. So hypercoagulability together with severe inflammatory state is called as thromboinflammatory state, which was found in our patients also. We found that TEG could better identify and assess hypercoagulability in patients with COVID-19 infection than the conventional clotting test. And also, despite thromboprophylaxis, all the hypercoagulable states and severe inflammatory states are prevalent in COVID-19 infection. Next slide. So limitations, we had a small sample size of 28, which limit the widespread applicability of this study. But also, we also could not perform sequential TEG analysis on our patients because of logistic issues, which could have been provided on in-depth analysis and understanding the coagulation status of the patients better. Next slide. And these are the references. Next. Next. Thank you.
Thank you, Dr. Tushar, for an elegant piece of work and presentation.
Thank you, sir.
Thank you. Could your study have an impact on the clinical management of these patients? Could you help the clinician in changing their treatment?
Yes, sir. Sir, basically, clinicians were initially relying on the conventional coagulation test, PT, APT, and INR. Now, since our study was done in gastroenterology department, which were taking maximum burden of the COVID-19 patients, so these patients were upfront done TEG at admission. So TEG improved their survival and stay in the hospital, which was reduced. So when we did upfront TEG, we found that many patients were hypocoagulable, hypercoagulable, and similarly we can give the treatment according to the protocol. So we found that this reduced the mortality and reduced their hospital stay.
So you could tell them that who out of this needed anticoagulation and who did not need particular demarcation line?
Yes, sir. Sir, actually, all moderate and severe patients upfront were requiring anticoagulation. But in spite of that, these patients developed hypercoagulable state in spite of being on heparin. So we identified those patients that required more anticoagulation as compared to the prophylactic anticoagulation. And we gave more anticoagulation in the form of low molecular weight heparin, so that could be helpful. And when we repeated the sequential TEG on these patients, the inflammatory state and the thrombophilic state was reduced.
At AIMS, do you have an access to ROTEM?
No, sir. Sir, we don't have access to ROTEM. We use TEG.
Questions from our judges? Akanksha?
Yes, sir.
Right.
So thank you, Dr. Tushar. That was a very nice study. So I'd like to ask you that in the patients who survived in the hypercoagulation group, were you able to give them an assessment of when they were to continue the anticoagulation? What was the practice from clinician side, regarding the anticoagulation?
Ma'am, those patients who were found hypercoagulable on TEG, when we performed TEG analysis, they were already on low molecular weight heparin.
Yeah.
And we had performed this TEG analysis giving heparin so that the anticoagulation effect of heparin is neutralized. So we found that in spite of giving this low molecular weight heparin, the MA was high in these patients. So clinicians, they immediately found this thing which could impact these patients, and these patients may develop thrombosis in the long run. So they started with heparin, low molecular weight heparin protocol, depending on the weight and the age of the patient.
Okay, and after discharge, were they put on prolonged, prophylaxis or,
Yes,
like?
ma'am. Correct. So after discharge, they were given heparin and they were followed regularly.
Okay, thank you.
Thank you, ma'am.
Pranjal, you have a question?
Yeah, I was thinking on the same lines. That means if you said it was hypercoagulable, do you mean to say that you increased the dose of low molecular weight heparin, or did you add something to it?
Sir, they were hypercoagulable on the TEG analysis, and they on ultrasound and Doppler, there was no evidence of thrombosis. So we followed up with the sequential TEG in some patients, and we give prolonged low molecular weight heparin therapy. We followed up later on. So after doing a TEG analysis after 4 weeks, we found that they were stable now.
Right. Thank you, Tushar.
Thank you,
sir. Okay, what I was supposed to, yeah.
Okay, we'll move on. Thank you. So we have the third presentation. The title is Enigma of ITP. What works? Presenting author Dr. Vaibhav Chadda, FNB trainee, Department of Pediatric Hematology Oncology, BJ Wadia Hospital for Children, Parel, Mumbai. Co-authors Dr. Ritika Khurana, Dr. Archana Swami, Dr. Purva Kanvinde, Dr. Ekta Gupta, Dr. Suyog Nagare, Dr. Sana Khan, Dr. Dhara Shah, Dr. Trupti Dabale, and Dr. Sangeeta Mudliar. So over to you, Dr. Vaibhav. Unmute.
Yes, sir. Thank you, sir. I'll start my screen sharing. So is my PPT visible, sir?
Yeah.
Okay. So thank you. Good afternoon, everyone. My name is Dr. Vaibhav, and I'm a FNB fellow in Pediatric Hematology Department from Vijayawada Hospital. So my topic for today is enigma of chronic ITP and what works. So ITP is an acquired immune autoimmune disorder, which is characterized by an isolated thrombocytopenia after we have excluded other causes of thrombocytopenia in children. So we call it as chronic based on the duration that is like more than 12 months. And they have multiple therapeutic agents which have been tried that have shown a heterogeneous response. And some of them come with a very high cost and very severe side effects. So aim of our study was to study the clinical profile, disease course, and response to differentiate response to different therapeutic agents in patients who are having chronic ITP. So it's a retrospective observational study conducted between Jan 2015 to December 2019 in a tertiary care pediatric hospital. So we have included patients with chronic ITP on regular follow-ups during the study period. So we have accessed the records of these patients and then look at the clinical presentation, lab evaluation, follow-up, and treatment details of all the patients were noted and analyzed. So in results, we had around 79 patients of ITP which were registered during the study period, in which there were 35, that is 44% of the patients were acute, and 44, that is 56% of the patients were chronic ITP. So from now on, I'll be talking about data of the chronic ITP, that is these 44 patients. So the average age of presentation in this was 6.5 years, with range from 2 to 16, and there were 27 females and 17 males. If we talk about initial bleeding manifestation at onset, so there were the petechiae purpura, that is cutaneous bleeds, were 35, seen in 35 patients, mucocutaneous in 24, visceral bleeds in 5, and there was one intracranial bleed which was presented at onset to us. So during follow-up, there were most of the patients had bleeding manifestations, with mucocutaneous and visceral bleeds being maximum 72%. There were 2 patients who had intracranial bleed with an incidence of 4.5% in our cohort, and there was 1 patient with life-threatening ovarian bleeding, that is 2.2% of life-threatening bleed incidences there in our cohort. So based on workup, there was average platelet count of 14,668, ranging from 1,000 to 84,000, and 18 children had anemia, which an average of 9 hemoglobin, which was postulated secondary to bleeding. And there was 1 patient who had an ovarian hemorrhage, was the lowest hemoglobin of 4.1 at presentation. Other workup, we have done bone marrow afferent for all ITP patients, in which 40 had shown an increased megakaryocytes, 4 had a normal megakaryocyte value. And then based on different time durations, we have done for chronic disease, we have done HH, ANA, immunoglobulin, and NGS. HH was negative for all the patients. ANA we had done for 22 patients, which was negative. Immunoglobulin and LSSA levels, in which 15 had shown a normal level, 1 had low immunoglobulin level. NGS we had done for 7 patients, in which 1 patient had shown a NBEL2 and JAK2 mutation, and 1 had a complement C3 defect. So based on first line agents, when these chronic patients were acute, that time we have used steroids and IVIG. So we have used steroids in 40 of our patients and IVIG in 20 patients. So we have seen a platelet rise with steroid in 24 patients. There was no bleeding after starting steroids in 9 patients, and there was platelet rise plus no bleeding in 5 patients. And IVIG we have used in 20 of our patients, in which 4 patients had shown platelet rise, only 1 with no bleeding, and platelet rise plus no bleeding seen only 1 patient. So this is as compared to other literature, this is a lower response that is seen in our study. Then we had used second line agents in 29, that is 66% of our chronic ITP patients have been on second line agents, in which 15, that is 34% patients did not require second line agents because they had shown a very good response on steroids and IVIG, maintaining an average count of 20 to 40,000. In this cohort, 5 did not have any bleeding manifestations, 7 had minor mucocutaneous bleed, and 3 patients were lost to follow-up. We had used Dapsone as our first second-line agent in 29 of our patients, which was discontinued in 3 patients because 2 had allergic reaction and 1 had methemoglobinemia. And this Dapsone has been used for an average duration of an year in these patients. So platelet rise with Dapsone is seen in 7, and there was no bleeding manifestation in these 7 patients with a response of around 24%. We had used rituximab, and 7 patients we had used 37 milligrams per meter square standard dose and 100 milligram per meter square plus high dose steroids. There's DEXA in few patients, in which we had shown platelet rise only in 2 patients. Then we had used mycophenolate mofetil in 4 patients. There is no response. L-Trombopag we have used in 7 patients at multiple doses based on the age. And in that, we have seen platelet rise in 4 patients with no bleeding in 7 patients. So, which was a very significant result that 100% patients who were started on L-Trombopag did not have any bleeding manifestation. We had used romiplastin in 5 patients from 1 to 10 micrograms. And we had seen a platelet rise in 1 patient, that in a patient we have used a maximum 10 micrograms per kg. And he required around 20 doses of romiplastin, then later on it discontinued. So in our results, we have seen L-Trombopag after putting none of the patient had bleeding manifestation, even though 3 patients had a low platelet count. So 2 patients underwent splenectomy initially, out of which 1 is lost to follow-up, and another patient after splenectomy had a fall in platelet, and we had put him in L-Trombopag. Now he's having good response. So in our conclusion, so patients with chronic ITP, they continue to have multiple bleeding episodes which affect their quality of life, and sometimes these are very life-threatening. So newer TPO agonists like L-Trombopag seems to improve the quality of life by reducing the chance of bleeding, as we've seen in our study. But there are further studies which are required to assess the safety and cost effectiveness of long-term treatment with this new TPO agents.
Thank you, Vaibhav. Thank you very much. Beautiful study on ITP from Wadia Hospital, large data. As I had asked Dr. Trapti, I'd like to ask you,
yes, sir.
What is one new information that you have obtained from this real life story of ITP that you didn't know before your study?
Sir, actually, there are multiple observations that we have made in our study. So one, if you look at the response to IVIG and steroids, so IVIG had a response of around only 4 patients that responded to IVIG, whereas if you look at the literature, there is 80% response, which is documented. So explanation might be that these patients, the disease per se might be a refractory disease in these patients, or because this IVIG and steroid was started in their acute phase. So these patients are prone to go into a chronic phase. That's why we have not seen a good response in them.
This is presumption.
And second thing, yes, sir. So and second thing, in second line agents, we have seen, sir, rituximab has shown a very good response, around 60 to 80% response. And in previous studies, splenectomy was deferred by using rituximab in these patients. But in our study, we have not seen such a great response. And romiplastin, which also shows around 60% response, 80% response in other studies, has also shown a platelet rise in only 1 patient in our study. So there's something discrepancy in the responses that we have seen in multiple agents.
What was your criteria of doing NGS studies in 7 patients?
Sir, NGS studies, these actually patients were who were actually not very typical, like they were not very responding to IVIG, steroids, and multiple, like we have used Dapsone, we have used mycophenolate mofetil. These were not responding. So we want to rule out other underlying disorders. So we had sent LSS immunoglobulins, but it was not working. So we were able to send only for 7 patients, in which one had NBEL2 and JAK2. So usually NBEL2 is associated with gray platelet syndrome, alpha granule deficiency, but it also has some amount of autoimmunity like SLE, so that can contribute to ITP. And another was complement C3 defect, but did not clinically fit with like multiple infections or like that. So
I have one question, sir. Just to know, the L-Trombopag showed a response after how many days, like how many months or days? Because
yes, ma'am. We have seen a response ranging from 2 weeks to 4 weeks. So as early as 2 weeks, also we have seen response in our patients. And the first thing that we have noted is that immediate these patients stop complaining of bleeding episodes. Until 4 weeks, we have seen a rise in platelets. Sometime at 2 weeks, also we have seen a rise in platelets. And the average duration, we have used it around 4 to 6 months. Into 1 patient, we have used it till 1 year also. And after tapering, also these patients are, although not maintaining a very high platelet count, but they have a significantly better reduction in bleeding manifestation and improved quality of life after using L-Trombopag.
So you could taper and stop for L-Trombopag for 1 patient, but continued for rest all.
No, ma'am. So we have for 2 patients, we have given 1 patient we have given for 4 months, 1 for 6 months we have given, and 1 for 1 year. So 3 patients we have.
So you are following the guidelines of continuing and discontinuing L-Trombopag for these patients also.
Yes. So the one whom we have given for 1 year, for that we were able to taper like weekly 3 to like 1, like that we have tapered.
And they sustained.
Yes, ma'am. And like platelet wise, they're not like platelet falls down. Remember, bleeding manifestation and the quality of life. So we are able to maintain a functional level in these patients.
Now you said romiplastin is helped only in 1 patient. And what dose you had given? basically, because dose is also very important.
We start at 1 micrograms. We have gone maximum till 10 microgram, and it is a 10 microgram dose in which there was a response in the patient.
Okay, I think we will stop here. Thank you so much,
Okay.
Dr. Vaibhav. And we'll move on to the next presentation. So now we have the fourth paper, that is low-dose emicizumab prophylaxis, an effective treatment for severe hemophilia A patients with progressive joint damage. It will be presented by Dr. S. Leo Prince Mathan, Assistant Professor, Department of Clinical Hematology, KM Hospital, Mumbai. Co-authors are Professor Chandrakala, Dr. Rucha Patil, Dr. Puloma Pandey, and Dr. Farajji. So over to you, Prince.
Good afternoon, sir. I'll share my screen. Is my screen visible, sir?
Yes.
Very good afternoon to everyone. Topic of my study is low-dose emicizumab.
Hello. Sir,
Am I audible?
just put it slideshow.
Yes, sir. I have shifted to slideshow, sir.
No, not visible, sir.
Okay, sir. 1 second. Sir, is slideshow is visible, sir?
No.
Still not. Just on your presentation slide deck, you can see that the options of slideshow over there.
Oh. Yeah. It shows end show. I'll stop scaring. I'll screen. Sir, is it in slideshow, sir, now?
No. Okay, I think you go ahead. There is no choice. Go ahead.
Yes, sir. Good afternoon, sir. My title is low-dose emicizumab prophylaxis, an effective treatment for severe hemophilia A patients with progressive joint damage. Severe hemophilia A is a factor VIII level less than 1%, which is a congenital factor VIII deficiency, which is X-linked recessive disorder present with spontaneous and post-traumatic bleedings. The treatment of hemophilia A has evolved from just a factor replacement, plasma replacement, cryo replacement, and then specific factors derived from plasma and recombinant factors, and then extended half-life factors, now non-factor therapy. The fashion in which we treat these patients has also evolved. Earlier, we were treating an episodic factor replacement. Now we are treating as a regular replacement factor. What is really happening with prophylaxis is when a patient with severe hemophilia with spontaneous bleeding phenotype is there, we are replacing factor at regular intervals so that he becomes a mild to moderate hemophilia without spontaneous bleeding. But such available therapy has multiple limitations. Patient has to visit the hospital very frequently, and the trough level is not maintained throughout the week. And even this standard prophylaxis is and low-dose prophylaxis is not available for most of our patients in India. And the standard factor VIII prophylaxis still has an annual bleed rate of 1%. The actual very low dose prophylaxis, which we commonly use in India, has an annual bleed rate of 3 to 5%. The WFH data of 2020 says only 9% of our pediatric population and 4%
Dr. Prince.
our adult population.
Hello, Dr. Prince.
Yes, sir.
Sir, sorry to interrupt. Your slides are not moving. Okay, so would like to share it from our end if you want.
Yeah, sure, no problem.
Just a second, sir. Sir, just let us know on which slide you are speaking, sir.
The next slide. Next. 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 Yes, I'll continue from this slide. The available treatment, the standard factor VIII replacement 3 times weekly or 4 times weekly has multiple limitations that patient needs frequent hospital visits, and the trough level is not maintained throughout the dose. Immediately after the injection, the dose when the levels go up, but before the next planned dose, the levels fall below the critical level, so where patient can have bleed. So such a standard dose prophylaxis has annual bleed rate of 1%. But the very low dose prophylaxis where we use 10 to 15 units per kg of factor 8 has annual bleed rate of 3 to 5. Please next slide. The WFS data says in 2020, only 9% of our pediatric population and 4% of our adult population were on actual prophylaxis. Next. So this leads to disability in most of our Indian patients. Only 6% of our patients were deformity free at the older age. Next. During treatment of factor 8 prophylaxis, 30% of them develop inhibitor positivity. Next. Which associated with marked economic burden and quality of life compromise. The cost of the therapy increases more than 3 times. Next. Inhibitor development is also associated with high mortality. Next. So here comes the role of emicizumab, which is a bispecific humanized monoclonal antibody which mimics factor 8 in its function, which is structurally and biochemically not similar to factor 8. And it can be used in hemophilia A with inhibitors to factor 8 also. It has a long half-life. Next. Basically, factor 8 does its role by being a cofactor for between activated factor 9 and 10. When it is not there, it is hemophilia A. The Hemlibra also does the same work as factor 8. Next. The standard dose established for emicizumab is initial 4-week loading dose followed by maintenance dose. Maintenance dose can be once weekly, once in 2 weekly, and once in 6 weeks. Next. The pharmacokinetic profile of the above regime, once weekly, once in 2 weekly, once in 4 weekly regime. This is depicted here. The initial loading time, the drug level increases and then it maintains a fairly well trough level, which corresponds to 40 to 50 microgram per milliliter. Next. Which correlates with the factor 8 equivalent activity of 10 to 20%. Next. So the Havan 1 to 4 studies established its clinical role and its pharmacokinetic properties, which was done in both in pediatric population, adult population, with inhibitors, without inhibitors, and they had used these clinical parameters: annual bleed rate, percentage of patients who had zero bleed rate, and how patients did well before emicizumab and after emicizumab. All these are showing promising results. Next. More than 99% patients had target joint resolution, and more than 80 to 90% of them had zero joint bleed. Next. So this is one of the study which says where they have used low dose emicizumab 1.1 to 1.6 milligram per kg without loading for 6 patients, and then they could reach a trough level of 4 to 10, and which is equivalent to factor 8 activity as 1 to 3%. Next. So basically, to compare emicizumab with the factor 8, emicizumab has a long half-life. It can be given once monthly dose. It can be given as a subcutaneous dose. So home therapy is very much possible, and it can be administered by non-medical person, by parent probably, and children below 2 years who have poor venous access. This can be used, and this is very less immunogenic compared to factor 8. All the Havan 4 studies show anti-drug antibodies with the neutralizing potential less than 1% patients, and it can be used in factor 8 inhibitor positive patients, and it has a stable trough level. Next. Next. So our hypothesis is in a resource limited setting, low dose emicizumab prophylaxis can be clinically effective. So if you use a low dose factor 8, there is short-tooth per ton of factor 8 level. If you use a factor 8 at a standard dose, there is a good trough level, but cost of which is very high. We are going to use a low dose and we expect it to give a good clinical effect. Next. So aim of our study is to objectively measure the clinical effectiveness of low dose emicizumab and correlate with the laboratory assessment of efficacy of hemostasis. Next. We selected
Hello, Dr. Prince.
It's frozen. Should we move to the next presentation? Come back to him later on?
Yes, sir.
Okay, so fine.
He's also got locked out, sir. Dr. Prince also got logged out.
Dr. Abhijay is there. No?
Yeah, Abhijay is there.
Yes, sir.
You can see my slide, right? So the fifth paper, comparative analysis of quality, efficacy, and safety of pooled Buffy-coat granulocyte concentrate versus apheresis granulocyte concentrate, will be presented by Dr. Abhijay Babuji from Department of Transfusion Medicine, KD Ambani Hospital, Andheri, Mumbai. Co-authors include Dr. Rajesh Sawant, Dr. Balakrishna, Dr. Santanu Sen, and Dr. Samir Tulpule. Over to you, Dr. Abhijay.
Hello.
Yes, please. We can see your slide, slideshow mode.
Okay. On behalf of my team, I'm presenting our study on the comparative analysis of pooled Buffy-coat granulocyte concentrate versus apheresis granulocyte concentrate in terms of quality, efficacy, and safety. With the advent of the potentially curative intensive chemotherapy regimens used alone or in combination with hematopoietic stem cell transplant, there is also an increase in patients with prolonged neutropenia and consequently increased risk of severe infection in these patients. Granulocyte therapy therefore continued to be used as a supportive therapy in patients with life-threatening neutropenia. Granulocytes can be procured by two means, by apheresis from a stimulated donor or as a pooled Buffy-coat derived component. When it comes to apheresis granulocyte concentrate, the logistic difficulties such as finding a donor availability, or a suitable donor mobilization regimens, or donor adverse events during the procedure are all well acknowledged. Whereas an alternate source of granulocyte, which is derived from the whole blood donation, that is a pooled Buffy-coat derived component, can be made easily available on even a daily basis if adequate whole blood donations have been collected on the day. This may also be clinically important, say that the early onset of severe infection may be crucial to the patient. In vitro tests have also demonstrated that neutrophil function of these pooled Buffy-coat granulocytes are well preserved during the 24 hours of storage. To note that a Buffy-coat pooling method for preparation of granulocyte concentrate has also been approved and enlisted in the latest amendment of Drug and Cosmetic Act published in March 2020. We have seen a recent increasing trend in the utilization of granulocyte therapy at our center. So we aim to comparatively analyze the quality, efficacy, and safety of this Buffy-coat granulocyte concentrate against the apheresis granulocyte concentrate. Our methodology initially was a Buffy-coat pooling method, which was done as per the institutional SOP, which includes a collection of 5 to 6 units of Buffy-coat as per patient's blood group, then confirming the TTI, NAT, and blood grouping, cross-matching of these units with patient serum sample, gamma irradiating, and then proceeding with the pooling process, after which samples were collected for QC and CBC and calculation of product yield, after which the product was stored at room temperature until being issued without agitation. As per our standardization of pooling procedure, we found that at least 5 Buffy-coat units were required for obtaining a minimum yield of 1 into 10 raised to 10 WBC per bag. In pediatric patients, a particular importance is given to the dose per kg rather than the product yield. The recent ring trial suggested that the patient receiving a dose of more than 0.6 into 10 raised to 9 granulocyte per kg per transfusion have better clinical outcomes, whereas the European guidelines says a dose of 1.5 into 3 into 10 raised to 8 neutrophils per kg as standard. We have taken the European guidelines as for our study. Coming to the apheresis donations, granulocyte donations were performed by voluntary donors recruited by the family of the patient after clearing the medical serological screening and undergoing a mobilization using a combination of GCSF and dexamethasone. All the procedures were performed using complex automated continuous flow cell separator at around interval of 8 to 10 hours of mobilization. The quality parameters of the product studied include the volume, total leukocyte count, granulocyte yield, platelet content, RBC, plasma content, blood group compatibility, and any post-procedural modification done on the product. And the variables affecting the clinical efficacy studied include the patient primary diagnosis, indication for the therapy, total leukocyte count, average days of neutropenia before starting therapy, time to respond, and even outcome of the therapy. Coming to the results part, over a period of 2 years, 220 granulocyte concentrate were prepared for 62 patients. Out of this, 171 were apheresis granulocyte concentrate and 49 were pooled Buffy-coat. Coming to the choice of granulocyte concentrate, among our 62 patients, 46 patients received only apheresis granulocyte concentrate, whereas 8 patients received a combination of both, and 8 patients received only pooled Buffy-coat during the course of treatment. And the patient population, the majority were pediatric population comprising of 83% out of the 62 patients. Coming to the patient diagnosis, majority were hematological malignancies comprising more than 50%, aplastic anemia around 26%, and other solid tumors comprising of 17%. Out of this, 21.7% received granulocyte transfusion in the pre-engraftment phase of hematopoietic stem cell transplant. Coming to the indication, the majority were gram-negative bacillus sepsis, followed by Klebsiella fungal, Pseudomonas, and other bacterial and fungal infections. Coming to the comparative analysis of quality parameters of the product in both groups, from this table we can see that there is no major significant difference among both the groups, but in case of platelet and RBC content, there is a higher content of platelet and RBC in Buffy-coat granulocyte concentrate. Coming to the clinical parameters analyzed, we can see that the total leukocyte count at the initiation of the granulocyte therapy was higher in terms of apheresis granulocyte group, whereas it was much lower in terms of pooled Buffy-coat granulocyte, and number of transfusions required per patient was more for patients receiving only pooled Buffy-coat. And adverse transfusion reaction, one case of Trally-like reaction was seen in a recipient of apheresis granulocyte concentrate, and an allergic reaction was seen in a recipient of pooled Buffy-coat. Coming to the patient outcome, out of our 62 patients, 43% of patients were non-responders. The response criteria studied was absolute neutrophil count of more than 500 millimeter cube for 2 consecutive days. Coming to the discussion part, pooled Buffy-coat granulocyte concentrate is still an unexplored territory in India. Many times this product is requested on an emergency basis, and finding a mass apheresis donor would be more challenging. Blood centers must have all standard operating procedures in place for any such granulocyte preparations in such emergency situations. And also the ethical consideration, exposure of healthy voluntary donor any form of medication with potential side effects, however, presents with ethical and safety issues. In UK, the blood services do not permit the usage of GCSF and steroid administration to voluntary unrelated donors, and it is reserved only for family unrelated donors for collecting granulocyte. This is to ensure the absolute safety of voluntary donors. Coming to the analysis of clinical efficacy, out of our 43% of non-responding patients, which is 26 patients, 24 patients received only apheresis granulocyte, and 2 patients received a combination of pooled Buffy-coat and apheresis granulocyte concentrate. However, all the 8 patients who received only pooled Buffy-coat showed clinical improvement. So in this regard, the inference can be made that the choice of the product did not, however, make any significant difference in the clinical outcome of the patient, as there are also many other confounding factors affecting the improvement. It is also important to understand that the granulocytes are often a last effort to gain control of a dire situation in an extremely ill patient. So expecting miraculous outcome is also not reasonable. In this, we can see in assorted case reports and small uncontrolled series, we can see that the clinical efficacy is variable as low as 0% to 100%. So in our case also, we have seen a variable clinical response. Coming to the quality, we have seen that there is a higher content of platelet than RBC. Therefore, caution must be exercised in patients with polycythemia pediatric. They might need a vein section if on repeated transfusions, and whereas it can also be beneficial to anemic patients. And also, granulocyte concentrate, whether it being an apheresis granulocyte or pooled Buffy-coat, contains platelet almost equivalent to a adult dose of STP. Hence, additional platelet transfusions can be and need and effectiveness of the granulocyte transfusion hence should be decided on an individual patient basis. Conclusion is that the whole blood derived pooled Buffy-coat granulocyte concentrate may be considered as a valid alternative to apheresis granulocyte concentrate in terms of quality, efficacy, and safety. Yes, pooled Buffy-coat granulocyte concentrate still has a lot of logistic issues, and each blood center should have its own standard operating procedures. Further follow-up of recipients who RBC and HLA-LO immunization is required. Thank you.
Thank you, Dr. Abhija. Wonderful. Questions from judges, Dr. Pranter, Dr. Akanksha, and others.
Yes, so I had a question to Dr. Abhija. Thank you so much for your study. Hello.
Yeah, go ahead, Akanksha.
Yeah. So I'd like to know that the patients you said that they were non-responders. Did you analyze which was the baseline diagnosis for these patients? Like, did you find that patients who had fungal infections with cases of aplastic anemia, did they have a poorer response as compared to other patients who were having post-chemotherapy neutropenia? Did you analyze that in your data?
Yes, ma'am. We have seen that the patients are responding better with those who had bacterial infection rather than fungal infections.
And disease, any difference with the disease or patients having post chemotherapy neutropenia, did they respond better to the granulocytes?
Those patients who are in the post chemotherapy phase and post transplant neutropenia, they are better responding. But if they have any other infection, but like I've said, those with fungal infections are responding a little. Their response is little lower when compared to bacterial sepsis.
And I also like to know that presently in your institution, how do you decide, regarding which patient should receive apheresis granulocyte? I mean, is it dependent on availability of donor, or you just randomly decide which patients to give the pooled granulocytes or apheresed ones?
It is depending on the donor availability, ma'am. Many of times the finding a suitable donor who is fitting to all the regulatory requirements is often difficult for the patients related. So in such cases, the patients who are not from in and around the city, they do not end up getting a donor. So for them, like without any options left, like they have been lack of donor availability.
Yeah, because majority of the patients that you described, they had received apheresis granulocytes. That's why I asked that. So, okay, thank you.
Thank you. Any other question? We have a minute or two. Okay, if none, then Dr. Abhija, thank you very much. We go back to Dr. Prince. Prince, you can start from where you left.
Yes, sir. Sorry, sir. I apologize for the technical error.
You can't do anything. This is technical issue.
So, am I audible, sir?
You are audible.
Yes. Thank you, sir. So we selected patients, severe hemophilia A patient without inhibitors who had recurrent joint bleeds despite regular low prophylaxis, 25 units per kg 2 times to 3 times a week, or who had a target joint but do not have access for regular replacement therapy. And we selected severe hemophilia A with inhibitor patient with the target joint. Next, please. So we included 9 patients for this study and who had completed 6 months of therapy. Now we are including for this interim analysis. Written informed consent was taken from all the study participants. This is a single arm study. The baseline characters were recorded during treatment. Clinical and laboratory monitoring was done. At the end of the 6 months, intra-patient pre-treatment and post-treatment comparison was done. Next, please. The data collected were, the pre-treatment data collected were whether they were an episodic treatment or prophylactic treatment, whether they were inhibitor positive and what was the titer, how many target joints they had, what was the annual bleed rate, what was the joint score. Next. During treatment, the new bleeds were recorded and new bleeds that required a clotting factor replacement was recorded, and ROTAM assays were done at monthly interval. At 6 months of the treatment, annualized bleed rate was calculated and resolution of the target joint was looked for. An intra-patient comparison of pre-treatment and post-treatment details were noted and cost of the therapy was analyzed. Next, please. The dose we utilized is, sorry, please go back. The dose we used is emicizumab 3 mg per kg once a month, subcutaneous dose. The ROTAM methodology we used is NATM. Next, please. The standard definitions for annualized bleeding rate, target giant and resolution of the target giant we used. Next, please. So this is our results. We included 9 patients in the study. The age ranged from 6 years to 12 years. The median age was 10 years. 3 of the participants were on episodic treatment previously, and 6 of them were on regular replacement therapy. Still, they had recurrent joint bleeds. 3 of them were inhibitor positive and 6 of them were inhibitor negative. All these patients together, all the 9 patients together had 70 treated joint bleeds in the previous year. They had 12 target joints. The mean annual bleed rate was 7.7. And there were baseline Hajj joint scores were recorded. Next, please. So during the treatment over the 6 months, there were no new bleeds, which makes the annualized bleed rate to 0. And there were ROTAM assays done. We couldn't have the baseline ROTAM assay because we analyzed through INTEM methodology. Later, we realized INTEM is too sensitive for emicizumab. Next, we adapted it to a NATEM method. So I am not included the baseline values. Please go to the next one. So since we don't have the baseline value, we compared it with the pooled control. So when we did a NOTAM analysis in a severe hemophilia A, the mean of 10 patients was 3,900. For moderate hemophilia A, it was 1,700. For mild hemophilia A, it was 1,200. And for normal patient, it was normal person, it was 544. This is the NOTAM method clotting time. So if we see our patients, 1 to 9 subjects, the first subject, if we see he had all the, even at 1 month, he had the profile close to mild hemophilia A, but subject 7 and 8, they had a profile close to severe hemophilia A. But over the time, we can see clearly all of their clotting times are declining in trend, which is approaching towards mild hemophilia A to normal person. Next, please. So this is the graphical data. So the of the above data, the first line, if you see the blue line, that is the first month clotting time by ROTAM value, and the orange is the second month, and the subsequent lines we can see clearly the clotting time is reducing. Next, please. So this is at 1 month and 5 month comparison of the subject 5. At 1 month, the clotting time was prolonged. The mean clot firmness was less, and the clot formation time was less. When compared to 5 months, the clotting time is less. Mean clot firmness is increased. Next, please. So if we compare the pre-treatment and post-treatment at the end of 6 months, out of our 9 patients, none of them had a 0 joint bleed ABR. So 0 ABR rate becomes 0, but at 6 months, all of them had a 0 ABR rate. It makes it 100%. Next, please. If we compare the annual bleed rate in the previous year, they had multiple bleeding episodes, 1 episodes to 16 episodes in range. The mean ABR was 7.7, but during the course of treatment, they had all of them had a 0 bleed rate. Next, please. If we compare the Hajj joint score, which was ranging from 0 to 13 in the beginning, but all of them are declining. If we compare the each subject's baseline and at 6 month level, it is declining, which is saying that all these target joints are approaching towards resolution. Next, please. So finally, we analyze the cost that taken for this treatment. If we are doing plasma derived factor 8, 25 units per kg twice a week, or then we would have used 1,200 units per kg over 6 months, which cost about 12,000 rupees per kg per patient. If we use emicizumab at standard dose, we would have used 42 milligram per kg, the cost of which is 70,000 for the same period. But that is without the scheme. Now we are getting emicizumab with 1+2 scheme, where it becomes 23,500. Price reduces by 1/3, but still this is double as that of plasma derived factor 8. But when we use low dose emicizumab, we had used only 18 milligram per kg, the cost of which is 30 without the scheme, and with the scheme it becomes 10,000. So making it cheaper compared to the plasma derived factor 8. Next, please. So here to conclude, low dose emicizumab prophylaxis is efficacious to reduce the annual bleed rate significantly. With the low dose treatment, the cost reduces by 43%, making it cheaper compared to factor 8 prophylaxis. low-dose emicizumab practice are both clinically and cost-effective. This treatment would be applicable to all the patients of middle income and low income countries. Thank you.
Thank you, Prince. Questions? Judges and others?
Just one practical question. I just want to know, once dissolved, was the vial fully used for many patients, or you store the sample because the dose is very less, no, 1.1 milligram?
Yes, 3 milligram per kg, ma'am. We pooled the patients, ma'am.
You pull the patients and finish the vial, right?
Yes, yes, ma'am.
So at centers where the patients are less, it will be little difficult. We have to have that much of crowd of patients to do the study.
Yes, ma'am. Even we included only 9 patients because of the availability of emicizumab was less with us also. So we didn't want to waste any that we had.
Okay, fine, yeah.
Dr. Srimati Shetty.
Yeah, Dr. Prince, it was a good presentation, but what I wanted to know was, don't we have to do the emicizumab trough levels and post-treatment, I mean, to confirm your observation?
Yes, exactly, ma'am. Actually, we had participated in WFH training for emicizumab trough level monitoring, and we had sent samples and our results. That is not yet validated, and we have not got approval for the same. So at present, we are not doing. In future, we will be doing the same, ma'am. So we did it by notum.
Thank you.
But Prince, do we have a data that what is the drug level which is hemostatic?
Yes, sir. Yes, sir. Actually, there are studies, whichever in the Haven studies, the hemostatic level were correlating between 40 to 50 microgram per ml.
As we know, hemophilia is a changing story. The
Yes,
lower and lower level are also equally effective when given in.
Yes, that is what we want to establish, sir.
Yeah, so we probably do not know whether the lower drug level may also be enough.
Yes, sir. Yes, sir. Yes, sir.
Right. Okay. Anybody else wants to ask him any question? We do have a couple of minutes.
Yes, I have one question.
Yes.
Thank you, Dr. Leo. That was a very elegant presentation. A nice cost analysis that you've done. So I'd like to ask you, was there any effect on the inhibitor levels post emicizumab in the patients who had presence of inhibitors? Did you follow up on that as well?
No, ma'am. We have not looked into it.
Thanks.
Thank you, ma'am.
Any other question? Okay, so thank you very much, Prince. We'll move on to the session 2. Thank you.
Thank you, sir.
To the session 2 now. And we have the 6th paper, which is assessing the role of microRNA in hydroxyurea-mediated fetal hemoglobin induction and ameliorating the disease severity in hemoglobinopathy patients. It will be presented by Neha Kargutka, PhD student, Hematogenetic Department. My slide is lost. Anyway, go ahead.
Sir, is this slide visible?
Visible.
Yes. Am I audible, sir, enough?
Audible.
Thank you, sir. Good afternoon, everyone. I, Neha Kargutkar, PhD student from ICMR NIH, would be presenting my work on assessing the role of microRNA in hydroxyurea-mediated HbF induction in hemoglobinopathy patients. MicroRNAs have emerged as a potent molecular regulator that modulate mRNA expression. So many studies have investigated microRNA expression during blood cell development, but relatively few studies have focused on the importance of mRNA expression for HbF induction. Our preliminary study showed significant improvement in the clinical condition of 98% sickle patients taking hydroxyurea. Thus, we hypothesized that mRNA regulation of promoter gamma globin gene may be involved in HU-mediated HbF induction. Hence, we propose to investigate the role of microRNA in HU-mediated HbF induction with following 5 objectives. To explore the expression pattern of mRNA in beta homozygous patient compared to control, to correlate differential mRNA expression with severity of disease, and so on. This was the overall workflow. Total of 250 patients were enrolled in the study, including 50 each of THAL major, intermediate, S homozygous, S-THAL and E-THAL, which were followed up after 3 and 6 months of HU treatment. These were the number of follow-up patients along with control. Coming to results, this slide shows age at presentation of hemoglobinopathy patients. As we can, THAL intermediate patient has a higher age of presentation compared to THAL major, which was found to be significant. This slide shows the frequency of blood transfusion among hemoglobinopathies patient, where we can see thalassemia intermediate patients has a lower frequency of blood transfusion compared to THAL major patients. This slide shows that hepatosplenomegaly is pronounced in thalassemia intermediate patients compared to baseline, compared to major patients, which is found to be statistically significant. Coming to molecular analysis and identification for beta globin mutations, we found 14 different mutations in thalassemia homozygotes and 5 in compound heterozygous cases, where IVS15 was found to be most commonly encountered mutation, whereas other milder mutations were reported in thalassemia intermediate cases. We tried to study secondary modifiers because they are known to ameliorate clinical severity of disease in patients. First was alpha thalassemia, where we found a higher prevalence of alpha thalassemia in THAL intermediate and sickle patients compared to other groups, which is found to be statistically significant. This suggests that alpha thalassemia, due to alpha thalassemia, there is a milder clinical presentation in THAL intermediate and sickle patients, homozygous patients. Then we studied X-men-1 polymorphism, where we found a high percent of homozygosity for T allele in sickle cell anemia patients and thalassemia intermediate patients compared to other groups. As we know, X-men-1 polymorphism is linked to HbF induction. Therefore, we tried to study that the homozygous T allele has been associated with elevated HbF levels in all the patient group, which was found to be statistically significant. Then, in order to look the effect of hydroxyurea on HbF level, we did a paired sample analysis of all the hemoglobinopathies patients at baseline 3 and 6 months after hydroxyurea treatment, where we found an elevated HbF levels after 3 and 6 months in all the patient group compared to baseline, which was found to be statistically significant. We also tried to look for gamma globin gene expression post hydroxyurea treatment in all the patient groups, where we found an elevated expression of gamma globin gene post hydroxyurea treatment, that is 3 and 6 months compared to baseline, which was found to be significant. For assessing the role of microRNA in hydroxyurea mediated HbF induction, we initially carried out a global microarray consisting of 754 miRNAs. So this card map, which shows altogether 754 mirs. This slide shows the hit map of mRNA expression pattern in control and thalassemia intermediate patients at base 3 and 6 months, where we can see 42 mRNAs were upregulated after hydroxyurea treatment and 17 were shown to downregulate. This shows the fold increase and decrease of mRNAs post hydroxyurea treatment of those 59. Based on the primary result of global mRNA profiling, we customized our microRNA profile comprising of these 59 differential mRNAs. And this was a customized card made with 4 endogenous control. This slide shows the hit map of 59 mRNAs in THAL major, intermediate, and sickle homozygous group at base 3 and 6 months post hydroxyurea treatment, along with control, which shows the differential expression of 59 mRNAs. This is the Wiley plot, shows the relative quantification of those 42 upregulated and 17 downregulated miRNAs in all the patient groups, which was found to be significant. This table shows the fold increase and decrease in miRNA expression post hydroxyurea treatment compared to baseline. Then we come to target prediction. as target prediction is an important component to understand mRNA and its function, we predicted it using computational tools. So this table represents various targets of our customized mRNA, which are responsible for gamma globin modulation. And surprisingly, most of the targets shared by mRNAs were BCL, MYB, KLF, and GATA. So this is the schematic representation of our selected mRNAs, which work through, like the ones in purple, which are shown to regulate the modulators of gamma, thereby increasing gamma globin gene, and the one in red, which are inhibiting gamma. So these are negative regulators and these would be positive regulators. In order to correlate mRNA expression with HbF levels in patient and gamma globin gene expression, we use Spearman correlation analysis, where we can see MIR484 has been positively correlated with HbF levels as well as gamma globin gene expression level, while MIR105 has been negatively correlated with HbF levels and gamma globin gene expression at baseline 3 and 6 months, 3 different time points. Similarly, we studied the same experiment with other miRNAs also. In order to understand the function of mRNA, we used mimic and anti-MIR system of mRNAs, which were studied in K562 cell lines. We have selected BCL, KLF, MYB, KLF, and GATA as a mRNA targets for functional analysis. So initially, we studied functional validation of 12 mRNAs, which were positive gamma globin gene regulators. So here shows the transfection. It is transfected with mimic 15, result into increase in mRNA 15 expression and corresponding upregulation of gamma globin gene and downregulation of the modulators of gamma globin gene. While when it is inhibited with anti-MIR, the expression of MIR decreases with downregulation of gamma globin and upregulation of the modulator. The opposite effect have been seen here. Similarly, we carried out the experiments with other MIRs also. This table shows the overall upregulated mRNAs, the positive gamma regulator mRNAs, and the transfection and the resultant gamma and modulator gene expression. Next, we studied the functional validation of 6 mRNAs, which are negative gamma globin gene regulators. Here, the MIR193, when it was mimicked in cell line, its expression increased, but it's a negative gamma, so gamma expression was downregulated and resulting modulators expression were upregulated. And when it was anti-MIR was used, the opposite effect was seen, where the expression of MIR93 will downregulate and gamma would upregulate, with corresponding modulators will also get downregulated. Similar experiment results were shown with MIR411 and other MIRs also were studied. This table shows the overall downregulated mRNAs with the fold change pattern of gamma and modulators. To support our in vitro findings in K562 cell line, a parallel transfection experiment was performed using actual CD34 cells of sickle cell anemia patient, where we mimicked 16:1 expression in the cell of patients, where we found the upregulated 16 along with gamma gene was also upregulated and downregulation of the modulators were observed. In order to understand the target network and pathway of mRNA, our in vitro studies documented that BCL, KLF, MYB, GATA are HbF modulators. Thus, in order to understand the relationship between the targets, we developed a network using strings where we found few additional targets which were linked with BCL and GATA, such as HDAC, RBP, MBDL, which are essential modulators of fetal hemoglobin. We also constructed microRNA and target network using MIR tools and enrich their pathways using KEGG pathway. And the most common pathways were erythropoiesis, cell cycle regression, and JAK and STAT pathway and cancer pathway. So this table shows our microRNAs, their targets, and the pathway which they are involved in. Coming to the conclusion of our study for clinical relevance. So given that MIR484, MIR105, 210, 16, 120, and 96 play crucial role in HbF and gamma globin gene regulation, it can be used as a diagnostic and therapeutic value and might be therefore be useful to understand the function of hydroxyurea in HbF induction. The role of mRNA mediated post-transcription regulation of HbF has a diagnostic therapeutic value. For example, MIR34, MIR222 have been used in the clinical trials for cancer treatment and HCV treatment. Future studies would provide a relevant protein targets that may lead to understand the HU mechanism in the patient to the drug, including interpatient variability response. These findings need to be expanded to the clinical sickle cell disease mouse model to develop mRNA as a potential therapeutic option. So this, in nutshell, this slide shows mRNA replacement therapy that can be used to treat a patient. Thank you. The study has been accomplished under the guidance of my guru, Dr. Anita Nadkarni, and love and support from my department. Thank you.
Thank you so much, Dr. Neha. Let's decide about the question. There's one question from the audience. What is the highest level of fetal hemoglobin you have seen after hydroxyurea therapy?
Sir, highest level of fetal in thalassemia intermedia I have seen to be 97.
And what was the level before giving fetal hydroxyurea?
In thalassemia intermedia?
In that particular patient where it went to 97.
So,
he wants to know the maximum uplift that occurred in fetal hemoglobin level by hydroxyurea.
Okay. So overall, I analyzed fetal hemoglobin level in thalassemia intermedia patients 50. So the overall upliftment was found to be 3 to 6 fold increase in thalassemia intermedia, the HbF levels.
3 to 6 fold. Okay, thank you. Any questions from people here? There's one question that has come up. Role of microRNA interference in reducing the alpha globin gene.
Okay, as such, there is study reported MIR144 has been established as a has been linked with alpha gene regulation, and it has been established. Like our previous study has also established that MIR144 has been linked with alpha thalassemia. How it is linked? It ameliorates the clinical indices of patients.
Thank you.
Yeah, I have a question, madam.
Yes, sir.
You said that it is of diagnostic and therapeutic value, and you gave examples of anti-cancer drugs. Now, diagnostic value means what? Can we predict that which all thalassemia patients will benefit most by using hydroxyurea? Is there some kind of a role there if we understand what the expressions are?
Sorry, here, sir, your voice was.
Okay, I'll type it in.
If I'm not wrong.
Yeah.
Till Pranta comes back with the. Anybody else has a question? So he has typed it. What is the diagnostic value? You said it is of diagnostic and therapeutic importance.
About microRNAs, yes, as we know, hydroxyurea ameliorate disease severity by increasing fetal hemoglobin, but the mechanism is not known. So through microRNAs targeting the modulators of gamma globin gene, so by identifying such microRNAs, we can predict it to ameliorate. That would be one of the mechanisms. And coming to the diagnostic value, there are few microRNAs which have been shown to be upregulated in thal major or thal intermedia or sickle, which are constitutively expressed. So such microRNA panel can be decided for as diagnostic tool to identify the microRNA panel in those patient groups.
Thank you.
Can we predict who would respond better? So in our study, we have found in response is better in thalassemia intermedia and sickle, because along with microRNAs, there are also other modifier genes which are also helping or complementing the amelioration in patients.
Thank you, Dr. Neha. We'll move on now.
Thank you, sir.
So the 7th paper is potential of biocanin A as an anti-sickling agent. Elucidation by multispectroscopic thermophoresis and molecular modeling techniques by Dr. Syed Muntajid, research scholar, PhD, Division of Biochemistry, Department of Chemistry, Savitribai Phule, Pune University, Pune. Co-authors are Dr. Pooja Doshia, Sudham Kate, and Jignesh Doshia. So over to you, Dr. Syed.
Am I audible?
Yes, your audible. Slide is visible.
Okay. Good afternoon, everyone. Today, I'm going to present potential of biocanin as an anti-sickling agent. Elucidation by multispectroscopic thermophoresis and molecular modeling techniques under the guidance of Dr. Pooja Doshi. Background. The sickle cell anemia is a autosomal recessive genetic blood disorder characterized by the hemoglobin variant called as HbS. The prevalence of sickle cell disease, the 5% world population carry the gene responsible for hemoglobinopathy. The burden of sickle cell disease will increase about 30% globally by 2050. Nigeria and India hardest hit of sickle cell anemia. Both countries already have largest number of sickle cell disease. Major symptoms of sickle cell disease: vaso-occlusive crisis, intravesicular hemolysis, and hypersplenism. Biocanin A is a bioactive compound present in the various medicinal plants such as rosa and all. Biocanin support is a positive action for human health, such as it enhances the cellular antioxidant defense mechanism, support cardiovascular health, help modulate the body immune response mechanism, anti-inflammatory, neuroprotective, chemoprotective, and anti-allergic. In the material method, sickle cell blood sample was collected from the Sani Guruji Hospital, Hadapsar, Pune. After that, HbS confirmation by using cellulose acetate electrophoresis, anti-sickling assay by using HbS polymerization inhibition, reversal of sickling. After that, we purified the HbS by using ion exchange chromatography. After the purification, biocanin A and HbS interaction was done by using fluorescent quenching measurement, circular dichromism, MST. After that, we study the cytotoxicity of biocanin A on the peripheral blood mononucleated cell and erythroleukemia K562 cell line. Wet lab work correlate with the dry lab work, molecular docking, phytochemical and drug likeness property of biocanin A, molecular docking, and molecular dynamic stimulation. HbS confirmation by using cellulose acetate electrophoresis. The migration distance of the sickle hemoglobin is shorter than the HbA because substitution of glutamic acid in the sickle cell hemoglobin. The polymerization inhibition of HbS in the presence of biocanin A, as the concentration increases, the percentage of polymerization was decreases from the 20 to 100 micromolar. At the highest concentration of biocanin A, it shows the 78% polymerization inhibition. Reversal of sickling. In that reversal of sickling, we study the two concentrations, 60 micromolar and 100 micromolar. After the 100 micromolar concentration treated with the sickle cell blood sample under the hypoxic condition, the percentage of sickle cell around 24%. Fluorescence study, as the concentration increases, the HBS was quenched at different temperature like 25, 30 and 37 from the 20 micromolar to 100 micromolar. After that, we plot the Stern normal plot. From the Stern normal plot, we confirm that the static quenching formation between the group formation between at the ground state between the HBS and biocanine A. After that, we plot the logarithmic plot. In the logarithmic plot, we calculate the number of binding site and binding constant. The binding constant and number of binding site as decreases as increase the temperature. It confirms that the unstable complex formation between the biocanine A and HBS. After that, we study the thermodynamics of the HBS and biocanine A. In that, we confirm that the hydrogen bond formation between the HBS and biocanine A due to negative delta G and positive delta S. Secondary conformation changes of HBS with the biocanine A. As the ratio of biocanine A increase in the presence in the HBS, the helicity, the reduction of alpha helix indicate of the partial unfolding of HBS in the presence of biocanine A. The content of alpha helix gradually decreases while the beta sheet and beta turn were increased. This indicate that the alteration of HBS hydrophobicity with the formation of hydrogen bond between the HBS. MST, small kd value indicate the graph binding affinity. Response amplitude represent the difference between the bound and unbound state of the HBS with the biocanine A. The response amplitude increase with the increasing temperature indicate the strong changes in the thermophoretic mobility of the HBS in the presence of biocanine A. The in vitro cytotoxicity of biocanine A, we studied the cytotoxicity on the PBMC and K562 cell line. This result indicate that the no severe cytotoxic effect were caused by the biocanine A with the effective range of the concentration. These are the physiochemical property and drug likeness property of biocanine A. In silico, physiochemical and drug likeness property was calculated from the Swiss ADME tool. Biocanine A shows the good binding affinity towards the sickle cell hemoglobin as well as higher drug likeness property with the no excretion problem from the GI tract, good solubility, no interference in the P glycoprotein and no inhibitor for the CYP enzyme. Toxicity of biocanine A. In silico toxicity of biocanine A was predicted, studied by using test web tool. Lethal dose of bioactive compound biocanine A was higher when compared to the FDA approved drug of sickle cell anemia, which denote that even highest doses of bioactive compound are less toxic as compared to the hydroxyurea, 5-FCMF and GBT. From the molecular dynamic stimulation, we confirm that the biocanine A complex formation with the HBS, the binding energy obtained from the molecular modeling and fluorescent emission study was near about negative 25 to 26 kilocalorie per mole. The biocanine A destabilized the HBS polymer. Conclusion: overall, this study for the first time highlight the interaction of HBS with the biocanine A and intercellulally interpret polymerization inhibition, binding constant and alteration of secondary structure of HBS in the presence of biocanine A. Thus, the biocanine A could promote as a new generative therapeutic drug for the sickle cell disease. Bibliography: these are my publication related to sickle cell anemia. These are the press release about the article. Acknowledgement: I would like to thank Dr. Pooja Doshi, Professor Sudham Kate, and Sickle Cell Group, Sani Guruji Hospital, Hadapsar, Pune, CIF facility of Savitribai Phule Pune University, lab mates, parents, and family members. Thank you.
Thank you, Dr. Syed. Wonderful piece of work. Questions from anybody? A difficult subject for many of us to digest. So,
Hello. Yeah, I had a question, sir.
Have you actually seen the sickling rate reducing after your experiment? You
Yes, ma'am.
said that polymerization was reduced, but actually, because see, ultimately, if the sickling reduces, then only your patient will be milder presentation. So, have you seen that?
Yeah, actually, I have seen that in the in vitro analysis. I have showed you some slide in that. This one. It is the control under the hypoxic condition after the treatment with 60 micromolar and 100 micromolar. The sickling RBC sickle RBC converted into the normal RBC.
Okay.
Thank you. One question put up by Pranter. Pranter, you were nicely audible. You want to speak? Morning there was difficulty. Just now you were nicely audible. You want to ask your question directly? Okay. What he has put is there a synergistic action with other molecules which are currently being used?
Actually, we are in the process for the study the synergistic effect of.
Yeah. Any other question? We have time. Okay, if none, then Dr. Sayyar, thank you very much for bringing your work to our platform. We move on to the 8th paper, hemoglobin REAMS, an alpha globin chain variant eluting in sickle hemoglobin window in HPLC. The first report from India, presenting author Dr. Milu Jain, Department of Hematology, Suburban Diagnostics, Mumbai. Co-authors Dr. Tripti Shetty, Dr. Leena Salunke, Dr. Anita Nadkarni, Dr. Manju Goriwale, and Dr. Amar Dasgupta. So over to you, Dr. Milu.
Good afternoon, everyone.
Good afternoon.
I'm Dr. Milu from Suburban Diagnostics, and today I'll be presenting a case of hemoglobin REAMS, which is a rare alpha globin
Hello,
variant.
Dr. Milu?
Yes, am I audible?
Yeah, you are audible, but yes, not slideshow, ma'am.
Okay.
Slideshow.
Yes, sorry.
Yes.
I'm going to talk about hemoglobin REAMS, which is a rare alpha globin chain variant eluded in S window in HPLC and its interaction with beta thalassemia. And it is the first case report from India. HPLC is widely used for screening of hemoglobinopathies, and HB variants are identified on the basis of their retention time and contour of the peak. Several non-HBS hemoglobin variants elude in the S window, causing diagnostic dilemma. So it is important to identify and characterize the non-pathogenic variants from the pathogenic ones, like hemoglobin S. Here we present a case of two brothers which had unreported hemoglobin variant that eluded in S window, and with one of them also co-inheriting beta thalassemia trait. These two brothers were referred to our laboratory for hemoglobinopathy screening since the father was diagnosed to have thalassemia. They were born of non-consanguineous marriage, and there was no history of low hemoglobin or any signs and symptoms of hemolysis. There was no history of blood transfusion in the past. CBC and sickling tests were done using standard techniques. HB analysis was performed on variant 2 HPLC system. Alpha and beta globin gene mutation analysis was performed by direct DNA sequencing on 3730XL genetic analyzer. The CBC findings showed a normal hemoglobin in both the brothers with thalassemic red cell indices, and the peripheral smear shows mild microcytic hypochromic RBC. These are the chromatogram of the two brothers. They showed an elevated peak in S window, and AT also showed elevated HbA2. HbA and F in normal limit. HbS, there was a peak in HbS about 21.7% in ST and 13.8% in AT, with retention time of 4.51 minutes and 4.48 minutes in both. And AT additionally had an elevated HbA2 with 4.9%. Hence, since it was the peak was in sickle cell window, we did a sickling test, which was negative. We repeated it, it was persistently negative. Hence, we thought it must be some variant which is eluding S window, and we went for a globin chain sequencing. The globin chain sequencing showed alpha chain mutation at codon 23, where adenine was replaced by guanine, with additional single alpha 1 globin gene deletions in both the brothers, and 80 had additional beta thalassemia trait, where there was a mutation in beta globin gene at codon 15, where guanine was replaced by adenine. Hence, a diagnosis of HB Reims heterozygous with single alpha globin gene deletion was made in both the brothers, and 80, which was a compound heterozygous for beta thalassemia trait with HB Reims and single alpha globin gene deletion. This electrophotogram shows the mutation where the two overlapping peaks shows that at codon 23, adenine is replaced by guanine in heterozygous state, resulting in glutamate being replaced by glycine. HB Reims is a rare globin chain variant that eludes in HBS window in HPLC. First case was reported in 1898. In 1989, in 60-year-old French Caucasian woman, and this is the only case report till now in our literature search. And this is the first case report from India. Both the brothers, ST and AT, presented with microcytosis, hypochromasia, and thalassemic red cell indices without anemia. In ST and AT, HB Reims eluted at retention time of 4.51 and 4.48 minutes respectively. Several non-hemoglobin S variant elute in S window. Hence, sickling test becomes an important test for further evaluation. In these two brothers, sickling test was negative, and this was our first clue that the abnormal hemoglobin peak was not HBS, and that they warranted further evaluation. Globin chain sequencing showed alpha globin gene mutation in codon 23 in heterozygous state with single alpha globin chain deletion, and additionally beta globin gene mutation at codon 15 in heterozygous state in 80. HB Reims levels were significantly lower, 13.8% in 80, who had coexisting beta thalassemia trait as compared with 21.7% in ST. The role of concomitant beta thalassemia in lowering the level of hemoglobin Reims is a strong possibility in 80. This indicates a preferential formation of hemoglobin A over hemoglobin Reims in condition of relative beta globin chain deficiency. This also suggests that the rate of assembly of monomers to form dimers or tetramers can be an important mechanism of controlling the quantity of certain hemoglobin variants with critical substitution in heterozygotes. These are some of the hemoglobin variants with retention time between 4.30 and 4.70 minutes with negative sickling test. They are a mixture of alpha, beta, and delta chains, globin chain mutations. These are few variants reported from India that eluded in HBS window. Hemoglobin Vellore, hemoglobin D Agri, hemoglobin Q Thailand, hemoglobin Titusville, hemoglobin Raizu, and hemoglobin Reims as we report. This is an example of hemoglobin Titusville, an alpha chain variant eluding in S window, and the globin chain sequencing showed guanine being replaced by adenine at codon 94. This is a case of hemoglobin Raizu, a beta globin chain variant, eluding in S window with the globin chain sequencing showing replacement of guanine by adenine at codon 79. It is important to differentiate a pathogenic hemoglobin variant from a non-pathogenic one. HPLC retention time alone cannot be used as a diagnostic tool for identification of hemoglobin variants, but as a presumptive one. Hence, a stepwise approach is necessary for diagnosis of these cases. Sickling test can differentiate a non-hemoglobin S variant eluding in S window from HBS. Globin gene sequencing is required for definitive identification of hemoglobin variants. Hemoglobin variants in combination with other common hemoglobinopathies such as beta thalassemia represent a public health problem, and hence an accurate diagnosis can help the individual and their families in genetic counseling. These are my references. Thank you.
Thank you, Dr. Milu. So your family had any French connection?
No.
No? Okay. It originated right from India. All right.
Yes.
Okay. Any questions for Dr. Milu? Ranta?
Yes, sir. No, I just appreciate that they use the technology and got it. And I think with the sequencing coming around, the most important thing would be to determine whether they are pathological or incidental findings. Thank you for the presentation.
Thank you, sir.
Combination of Amar Das Gupta and Dr. Anita Nadkarni.
Yes.
You will keep new variants.
Yeah.
Okay, so no more questions for Dr. Milu?
Sir, luckily we have reported, from Dr. Das Gupta, we have reported many variants which are eluting in HBS window. That was really good.
Yeah.
Congratulations.
And I think, Anita, that is important because there are still some labs who find something in S window and report it as sickle only without doing a sickling test.
Correct, sir. That's why sickling should be the first step, actually.
If you start sending samples to Dr. Anita, there will be 40 more variants.
Yeah.
Yes.
You've got a khajana lying there.
Yeah.
Okay. Well, thank you, Dr. Milu. We will move on. Thank you very much.
Thank you all.
Yes. So ninth presentation is the study of role of monocyte distribution width as an early marker of sepsis. Dr. Sudarshan, WP, Registrar, Department of Internal Medicine at PD Hinduja Hospital, Mumbai, with co-authors as Dr. Rita Dalal, Dr. Vidisha Mahajan, and Dr. Shanaj Kodaiji. Over to Dr. Sudarshan.
So am I audible?
You are audible.
A very good afternoon to everyone present here. I would like to present our study on the role of monocyte distribution with MDW as an early marker of sepsis under the guidance of Dr. Rita Dalal, Dr. Shanaz Kodaiji, and Dr. Vidisha Mahajan. Sepsis is defined as a dysregulated host response to an infection that leads to an acute organ dysfunction. It is amongst the highest causes of mortality in India, especially in those patients admitted to the ICUs. Blood cultures have been the proverbial gold standard investigations in the diagnosis of sepsis, but the high turnaround time of around 36 to 48 hours has been its major pitfall. And hence newer diagnostic modalities like CRP and PCT have been developed for this very purpose. But they also have their own disadvantage, their high cost and their cost of ineffectiveness to perform infrequently being the major one. There's a dire need for a new testing modality, one that is quick and cost effective, and such a parameter is the monocyte distribution width. MDW is an in vitro diagnostic parameter that reflects a change in the volume of circulating monocytes in response to pro-inflammatory signals. It is based on the principle that as a part of the innate immune host response to inflammation, monocyte volumes increase initially during an inflammatory process, and then monocytes subsequently leave the peripheral circulation to migrate to the extravascular cellular pool to then form tissue macrophages to elicit the immune response. The aim of our study was to validate MDW, which is an FDA-approved parameter available as an early sepsis indicator in the Beckman-Coulter DXH 900 hematology analyzer. Our objective was to study the sensitivity and specificity of MDW in the diagnosis of sepsis and compare it with that of CRP, PCT, and blood cultures. We used the validated Q-SOFA score comprising of the following three parameters, that is a respiratory rate of more than 22 per minute, a change in mental status, and a systolic blood pressure of less than 100 millimeters of mercury to recruit and classify our patients. Our study had a sample size of 225 patients divided into three equal groups of 75 patients each. Group 1 comprised of normal healthy volunteers, Group 2 of sick but not septic patients, and Group 3 comprised of culture-proven septic patients who proved as a positive controls. MDW was measured using the Beckman Coulter Unicell DXH 900 with a Coulter Latron CPX control run daily for quality control. And an MDW value of more than 20% was considered a positive result. And an MDW value of less than 20% was considered a negative result. The exclusion criteria for the study were patients less than 18 years of age, those not willing to take part in our study, those with chronic kidney disease, hematological and solid organ malignancies, pancreatitis, trauma, and burn victims, patients on growth factors, patients with acute myocardial infarction, and those with autoimmune conditions. Participants were recruited from the inpatient, outpatient, and health check departments. All patients fulfilling any of the exclusion criteria were removed from the study. Informed consent was obtained from all participants, and they were divided into 3 groups, as previously mentioned, on the basis of the history and physical examination, and also the QSOFA scores. Patients within Group 1 with a QSOFA score of 0 underwent a CBC with MDW. Patients in Group 2 with a QSOFA score of 1 to 2 underwent a CBC with MDW, a CRP, PCT, and blood cultures, and other cultures as appropriate. And patients in Group 3 underwent an MDW, a CBC with MDW, CRP, PCT, and within 24 hours of growth on their blood cultures. On looking at the CBC results, we noted that 82% of our, 72% of our study population were males, and the remaining 28% were females, who were pretty much evenly divided into 3 equal groups. Amongst the participants, 28% of our patients were diabetic, 32.9% were hypertensive, and 7.6% had ischemic heart disease, and 12.4% of patients were hypothyroid. On looking at the CBC parameters, we noticed that 82% of our patients from Group 2 and 66% of patients from Group 3 had a raised WBC count, with nearly all differentials showing a neutrophilic predominance. A whopping 93.3% of patients belonging to Group 2 had a positive MDW, and 81.3% of patients from Group 3 had a positive MDW. 82.7% of patients from Group 2 and 86.7% of patients from Group 3 had a positive CRP. And even procalcitonin was elevated in 86.7% and 84.7% in patients of Group 2 and Group 3 respectively. Surprisingly, only 38.67% of patients from Group 2 had a growth on their blood culture on follow-up. And the most common organism isolated was carbapenem-resistant Klebsiella pneumoniae, with a resistance pattern of OXA48 and C3XM carbapenemases produced. The median MDW for Group 2 was 22.9%, and for Group 3 was 21.5% at a p-value of less than 0.001. The ROC curve shows that MDW has a high true positivity rate and at a cutoff of 20%, with a calculated area under the curve of 0.747% at a 99% confidence interval of 0.682 and 0.812, and was hence statistically significant. From this busy slide, we can infer that by itself, MDW at a cutoff of 20% has a high specificity and positive predictive value and a fairly high sensitivity. But on closer examination, we can begin to see that it has a synergistic effect that MDW has when combined with other lab parameters like to high WBC counts, a positive CRP, and a PCT. The sensitivity of all these parameters when performed together is more than that of each component itself, and also having a higher negative predictive value when combined can help us in ruling out sepsis early in such patients. So to conclude, we can see that MDW is a prime candidate for a new diagnostic marker for sepsis, which can help us in the early diagnosis of sepsis, and thus helping clinicians institute corrective measures like volume replacement, antibiotic initiation and/or escalation, and institute life-saving measures like inotropic support. It is an easily available parameter as part of a complete blood count, thus having a quick turnaround time and being cost-effective. It has a sensitivity of 67% and a specificity of 83% at a cutoff of 20% in diagnosing sepsis. It also augments the sensitivity of tests like CRP and PCT when performed together. And the limitation of our study was that serial monitoring of MDW, CRP, and PCT could not be studied owing to budgetary constraints, and that a serial study would have helped us establish a temporal relationship between MDW and sepsis. Thank you all so much for your time.
Thank you, Dr. Sudarshan. What was your Group 1?
So group 1 comprised of normal healthy patients who were negative controls, or who acted as negative controls. So we could establish that our cutoff of 20% MDW was normal. So all patients who were in group 1 had an MDW of less than 20%, sir.
So when you say normal, healthy patients, what do you mean? Patients, normal, healthy.
So we define those patients as those who are admitted for elective surgeries and who did not have any fever in 7 days prior to getting admitted in the hospital, sir. Any acute febrile illness on 7 days prior to getting admitted, sir.
Not having acute febrile illness.
Not having any acute febrile illness in the preceding 7 days preceding admission.
Some of them you showed CRP and PCT high in your group 1.
Yes, sir. Some of them did have a CRP and PCT high, so that we could not explain as to why. Probably it was because of their existing, probably those CRP and PCT are known to be slightly elevated even in patients who have fractures, long bone fractures. So sometimes that could be a confounding factor, sir.
All right. Any questions for Dr. Sudarshan, please? Renter, Akanksha, and others.
Yes, I'd like to ask one question to Dr. Sudarshan. Where do you think that this MDW has the most applicability? In which group of patients do you think it would be the most useful, by saying, that it has a lower turnaround time? So where do you think that it can have, application in which group of patients?
Yes, sir. So especially the patients we would like to target are those who come to the emergency department with a febrile illness and who have symptoms of impending sepsis, like with a borderline, with a slightly altered mental status, with a borderline blood pressure. And since one of the first investigations we send for these patients is CBC, if we ask for a CBC with an MDW, which we get usually within half an hour to 1 hour, we'll come to know if they have a very high MDW. We know that these patients are in impending sepsis. We'll catch them early. We can send, if more blood cultures, if we can send a CRP and PCT early, and we can start antibiotics early, and not wait to institute corrective measures in these patients. So the patients coming to the ED with either a febrile illness or symptoms like tachypnea, who are that is a low BP or altered mental status, as sometimes fever is not necessary presentation of sepsis in older patients. They might just come with these symptoms. So in such patients, if we get a high MDW within half an hour to 1 hour of them presenting to the emergency department, it would help us in catching these patients earlier, ma'am.
So do you think that this has any applicability in patients of COVID-19 who are admitted in the ICU, and you want to differentiate, if they're going into sepsis as well? So what are your comments?
Absolutely. So there was a paper published by Dr. Ognibene from Arezzo in Italy in 2021, where they studied MDW in mildly and moderately sick patients, COVID-19 SARS-CoV-2 patients. And they studied about 1,000 patients where they found out that MDW is also raised in patients who are present with mild and moderate COVID. There is a paper that has come out from one of the lab in Italy, which says that even in severely sick COVID patients with ARDS who present, in them also MDW has a diagnostic value, but the prognostic importance has not been yet studied, ma'am. It does have a role in the diagnosis and mainly prognostication of patients with severe COVID, mild and moderate COVID-19.
Okay, thank you.
Thank you, ma'am.
Dr. Tejaswini Gudibande wants to know what was the mean monocyte count, the absolute monocyte count.
Yes, sir. So the absolute monocyte count for these patients was so about 13 sorry, sir. In group 2 patients, the absolute monocyte count for these patients were more than 8%, sir.
More than 8%.
More than 8% of the differential, yes, sir.
Any more questions for Dr. Sudarshan? So has the
Sorry.
Ranta, now you are not audible.
Yeah.
Sorry. Has the demand for PCT test come down in Hinduja Hospital now?
No, the PCT is still being done, sir, but for patients who are admitted to the ICU, getting a PCT daily for them to keep looking for some infective etiology is still difficult. Even with our fantastic labs, we are not able to sometimes catch the bug with multiple blood cultures and multiple PCTs. Doing multiple PCT racks up the bill. So, but all patients in the ICU and most patients in the ward get a regular CBC, and ICU patients get a daily CBC, unless requested specifically by the admitting consultant to not do it, or if there is no, if they're in the ICU just for a post-operative review, they undergo a daily CBC. And since we have the machine with us, we can also publish an MDW with that CBC. Also, a rising MDW or a falling MDW can help prognosticate such patients.
It has impacted the demand for PCT?
It is not yet, sir, since we have not started publishing the MDW value along with the CBC, sir.
Okay. Ranta wants to know, is this parameter available in all 5-part cell counters?
It is definitely available in the DXH8, in the Unicell DXH 800 and the Unicell DXH 900, sir. The others I am not aware, sir. I'm sorry.
And the non-Coulter cell counters?
Non-Coulter cell counter, it's a flow cytometry based, sir. So base parameters, sir. So I don't think it will be available in those, sir.
Fair enough. Is that the last question anymore? Okay. Thank you so much, Dr. Sudarshan. We'll move on now.
Thank you so much, sir. Thank you, ma'am. Thank you, sir. Thank you for your time.
So paper number 10 is diagnostic utility of bone marrow aspiration biopsy in pediatric age group from Dr. Chanda Varshini Sindhia, second year postgraduate, Department of Pathology, JJM Medical College, Davangere. Co-author is Dr. Suresh Hanangawadi. Go ahead.
Good afternoon, sir. Am I audible, sir?
You're audible.
Good afternoon, everyone. I'm Dr. Varshini from JJ Medical College. Today, my paper presentation is on diagnostic utility of bone marrow aspiration and biopsy in pediatric age group. And moderator for my paper was Dr. Suresh Hanagwadi, sir. These are the contents I'll be going through: introduction, etiopathogenesis, bone marrow aspiration and biopsy, and present study. Introduction. Bone marrow aspiration and biopsy is important diagnostic tool. Bone marrow aspiration and biopsy is important diagnostic tool in evaluation of various hematological disorders. It is important to know normal bone marrow to detect the abnormal bone marrow. So we need to know what happens in bone marrow. There is a production of blood cells from hematopoietic stem cells, which is called as hematopoiesis. These hematopoietic stem cells have a capacity of self-renewal and also differentiation. So when the hematopoietic stem cells goes into self-renewal, they will produce more and more stem cells. If they go into differentiation, they will produce progenitor cells, that is common myeloid, committed myeloid and committed lymphoid progenitors. So there is a niche called hematopoietic stem cell niche, which is a microenvironment which regulates and maintains the stem cells. So there are two types of niche: osteoblastic niche and vascular niche. Osteoblastic niche is one which is adjacent to the trabeculae, and it is for long-term storage of hematopoietic stem cells, whereas the vascular niche is adjacent to blood vessels and marrow sinusoids. It is for short-term storage of hematopoietic stem cells. So there are various sites of hematopoiesis in various stages of life. In embryo, till 3rd week, it occurs in yolk sac. Till 3rd month, it occurs in liver. And in fetus, it will be starting occurring in bone marrow, and it will be continued. And in adult, it will be occurring in skull, vertebrae, ribs, pelvis, proximal epiphyseal regions of humerus and femur. So coming to structure of bone marrow, there are two kind of elements, that are cellular elements and stromal elements. Coming to cellular elements, which includes erythroid precursors, myeloid precursors, megakaryocytes and thrombopoiesis, lymphoid cells, monocytes, macrophages, mast cells, and plasma cells. Coming to stromal elements, which have stromal cells, adhesion molecules, fat cells, blood vessels, fibroblasts, endothelial cells, iron deposits, osteoblasts, and osteoclasts. So in order to immature cells to get matured, there is a role of humoral growth factors which helps in maturation of various immature cells. So these are the important ones which are involved in this, that includes erythropoietin, thrombopoietin, granulocyte colony stimulating factor, granulocyte monocyte colony stimulating factor, monocyte colony stimulating factor, interleukin 196, interferon gamma, and tumor necrosis factor alpha, which are involved in maturation of various cells. We need to know pathogenesis before diagnosing any disease. So these are the stem cells which have a capacity of self-renewal and also differentiation into committed progenitor. So once this hematopoietic stem cell differentiate into committed lymphoid progenitor, it will definitely form any cell of the lymphoid series. And in the same way, if it differentiate into committed myeloid progenitor, it has to definitely form a cell of myeloid series. So when there is any infiltration or any disease, metastatic deposits, or any nutritional anemia, any other cause obstructing the maturation, and there will be the related disorders accordingly. So as the cell differentiate, the capacity of self-renewal will decrease and capacity of proliferation will increase. We need to know where, how, when, and when not to do the bone marrow aspiration and biopsy. Coming to the site, in children less than 2 years, usually tibial tuberosity is very easy to access and less painful. So the tibial tuberosity is preferred in less than 2-year-old child. And in adults, the most preferred site was posterior superior iliac spine, as there are no much vascular area around it. And how to do? There are various needles involved in bone marrow aspiration and biopsy, in which the modern Jamshedi needle is more into the practice. So first we'll be giving anesthesia and then enter the from there. Coming to when and when not to do. Indications are to assess the cellularity, pattern of infiltration, architecture, to detect the focal lesions, and it is also useful for assessment of aplastic anemia, metastasis. Whereas bone marrow biopsy will help in dry tap when there is a aspiration having dry tap because of fibrosis. In such cases, biopsies will be helpful. Coming to contraindications, coagulopathies are contraindicated for bone marrow aspiration and biopsy, but due to modern technology, we can do it under the factor replacement if it is really necessary. Coming to present study, background, bone marrow examination is essential for differential diagnosis of various myelo and lymphoproliferative disorders. Aims and objectives. This study is aimed to evaluate the contribution of bone marrow aspiration and trephine biopsy to arrive at final diagnosis. Material and methods. This is a 2-year retrospective study of 75 bone marrow aspiration and trephine biopsy lesions in pediatric population, that is 0 to 18 years, was done from January 2020 to January 2022 in Hematology Unit Department of Pathology, JJMC, Davangere, Karnataka, India. The bone marrow biopsy is processed with H&D stain, and special stains were done wherever needed. Institutional Ethical Committee clearance was taken for the same. Coming to statistical analysis, descriptive statistics like mean and percentage were used to interpret the results. These are the results. Coming to demographic data, age and sex. Out of 75 cases, females were 39 and males were 36, with the female to male ratio of 1:0.9, showing female predominance, and age group ranged from 65-day-old to 18 years with a mean age of 9 years. Taking clinical presentation into consideration, out of 75 cases, most common complaint given by the patients was fever in 61 cases, followed by generalized weakness in 12, vomiting in 3, bleeding gums in 2, loose stools and failure to thrive was seen in 1 case each. Coming to symptomatology, the most common sign elicited was failure in 53 cases, followed by splenomegaly in 25, hepatomegaly in 22, lymphadenopathy in 10, knuckle pigmentation and frontal bossing in 5, polynuria and ecchymosis in 2 cases. So the bone marrow aspiration and biopsy helped us in diagnosing 75 cases. These are categorized accordingly. Coming to anemias, out of 75 cases, 41 cases are diagnosed as anemia, whereas megaloblastic was most commonly diagnosed in 19 cases, followed by combined nutritional deficiency and aplastic anemia was diagnosed in 9 cases each, and iron deficiency anemia was diagnosed in 4 cases. Coming to another category, leukemias, Out of 26 cases, out of 75 cases, 26 were diagnosed as leukemias, in which acute myeloid leukemia was diagnosed in 8 cases, in which the staging was done, and AML M2 was diagnosed in 5 cases, AML M3 was diagnosed in 2 cases, AML M5 was diagnosed in 1 case. And whereas acute lymphoblastic leukemia was diagnosed in 17 cases, in which ALL L1 stage was diagnosed in 4 and ALL L2 in 13. There is one case diagnosed as juvenile myelomonocytic leukemia. Coming to others, Gaucher's disease was diagnosed in 3 cases, Chidik-Higashi syndrome, congenital dyserythropoietic anemia type 2, acute ITP was diagnosed in 1 case each, and whereas the study was normal in 2 cases. According to availability of the slides in the archives, I would like to show some of the features. Here we can see the megaloblasts showing open sieve chromatin and basophilic cytoplasm suggesting megaloblasts, and there are small normoblasts, micronormoblasts suggesting combined nutritional deficiency having both megaloblasts and micronormoblasts. This is the case of acute promyelocytic leukemia. Here we can see the promyelocytes having OR rods, and there is a clump of OR rods suggesting Faggot cells, and we can also see myeloblasts with scant cytoplasm and nucleoli. In the same case, biopsy was done, and here we can see the reniform shaped bilobed nucleus with prominent nucleoli suggesting and confirming the acute promyelocytic leukemia. This is a case of juvenile myelomonocytic leukemia. We can see here the monoblasts, and here the lobed nuclei showing promonocytes, and also we can see the left shift here, suggesting both myelo and monocytic components seen. We can diagnose it as a juvenile myelomonocytic leukemia. And this is a case of Gaucher's disease. We can see wrinkled tissue paper appearance with the eccentrically pushed nuclei on the bone marrow aspiration. And this is another case of acute ITP. We can see here the megakaryocytic proliferation is there, and usually in ITP the megakaryocytes will show the smooth border. That is how we can diagnose. And then comparing the aspiration and biopsy, about 88% cases showed complementary to each other, whereas in 9 cases it was not complementary. Aspiration was unsatisfactory in 8 cases, where both biopsy helped in diagnosing those 8 cases as aplastic anemia, ALL L2, ALL L1 in 2 cases each, and iron deficiency anemia, megaloblastic anemia in 1 case each. Whereas 1 case of was diagnosed as megaloblastic anemia on aspiration, whereas biopsy have showed diagnosed as AML M2. Our study was compared to other similar study, Patil LY et al. Coming age into consideration, it is almost the same in both the studies, and taking sex into consideration, our study showed female predominance, whereas the Patil LY study showed male predominance. Signs and symptomatology was same in both the studies. Coming to diagnosis, anemias followed by leukemias were more common in our study, whereas anemias and infectious diseases were more common in Patil LY study. So the bone marrow aspiration and biopsy findings were complementary to each other in 66 cases, accounting for 88% in our study, whereas Patil LY study showed bone marrow aspiration and biopsy was complementary to each other in 72.5% with 87 cases. Coming to conclusion, the bone marrow study helped in prognostic classification and assessment during and after the therapy, staging of lymphoma and marrow infiltration. The bone marrow aspiration and bone marrow biopsy are confirmatory for tissue diagnosis and plays important role in clinical diagnosis, prognosis, and also decide the line of management. These are my references.
Thank you, Dr. Varshini. Very good presentation. So at your institution, the bone marrow aspiration biopsy are done by the pathology department or by the clinicians?
Pathology department, sir.
So they send the patient to you, do the bone marrow aspiration biopsy at in your department. Right?
Yes, sir.
Okay, any questions for her? Okay. So do the clinical residents learn how to do the bone marrows, the pediatricians, the physicians, and all those people? Or they totally leave it to you people?
No, sir. They will also be knowing, sir. In very less than 1 year old who needs sedation and all. For sometimes they will be calling us to the OT, sir, like ICU, and under their prevention we will do that, sir, under sedation. So it's like.
Okay. And in pathology, the different residents do it, or you have a fixed team?
Sir?
Do the different residents do it? I mean, when you get new batches of residents, they all do bone marrow aspiration biopsies, or you have X number of people who do it?
No, sir. Actually, second year and third year people will be doing, sir. First year people who joined, they will be seeing how to do, and once they come to second year, they will get chance of doing it, sir.
And you do both for all the patients, aspiration and biopsy?
So usually, recently we got a 2-year-old child, sir. We have done only aspiration to the tibial tuberosity, and biopsy was not done, sir. It was like less than 2 years. Usually, aspiration alone is done. Above 2 years, and if it is very mandatory, then biopsy and aspiration.
Okay, thank you so much for bringing your work to MHG platform. Thank you.
Thank you for giving opportunity, sir. Thank you so much.
Yes. So we move to the 11th paper, and this paper is related to PBSC collection by large volume leukapheresis in children of weight below 15 kg. Presenting author Dr. Amit Jain, Junior Consultant, Pediatric Hematology Oncology, MCGM Comprehensive Thalassemia Care, Pediatric Hemato-Oncology, BMT Center, Borivali, Mumbai. Co-authors Dr. Rumela Nayak, Dr. Nidhi Mehta, Kavita Pawar, Dr. Kalyani Patil, Dr. Paulami Das, Dr. Srishti Srivastava, Dr. Rajesh Patil, Ms. Carolina Vayaghar, Mr. Nikhil Mane, Dr. Kunal Sehgal, Dr. Ratna Sharma, and Dr. Mamta Manglani. So over to Amit.
Good afternoon, everyone.
Good afternoon.
So I would be presenting the experience at our center of peripheral blood stem cell collection by large volume leukapheresis in children weighing below 15 kg. As we are aware that the collection of autologous stem cells is now a routine procedure, in pediatric patient, it is very important to collect an adequate CD34 stem cell dose with a minimum number of apheresis. However, it is very challenging in low body weight children because of technical and clinical issues. So the challenges faced in pediatric apheresis are difficulty in securing vascular access, low extracorporeal volume, various metabolic and hematological issues, and along with that, psychological impact on the patients and especially parents. In low birth weight children, these issues are greatly magnified. So the strategies that are being used to improve the yield in a single apheresis are use of Plerixafor, chemomobilization, very rarely salvage bone marrow harvest, large volume leukapheresis, or combination of the above. Today, we will be focusing mainly on large volume leukapheresis, which differs from standard apheresis by processing a large volume of blood that is more than 3 TBV, increased blood flow rate, additional anticoagulant, and longer duration of procedure. So the objective of our study was to assess the efficacy and safety of large volume leukapheresis in children less than 15 kg body weight to achieve target stem cell dose in single apheresis being the outcome measure. It was a retrospective analysis performed between July 17 to January 21, and all the patients who were less than 15 kg underwent apheresis at our center were included in the study. So to cater the challenges which I mentioned before, we started with extensive counseling of the parents before the procedure. They were mobilized with either GCSF with or without Plerixafor based on the peripheral blood CD34 count before the procedure. Then large bore cannula was secured in the either in the jugular or femoral vein. The large volume leukapheresis was performed on spectropia machine with prior PRC priming to overcome the low extracorporeal volume. Administration of prophylactic calcium supplement to avoid metabolic issues. With all these strategies, our aim was to achieve a target CD34 dose of at least 3.5 into 10 raised to the power 6 per kg of stem cell dose, and a repeat apheresis was performed if this target was not achieved. The anticipated adverse events that were analyzed under they were analyzed under three headings: the vasovagal effect, the effect due to anticoagulant, that is citrate, and catheter-related adverse events. All clinical signs, symptoms, and investigations related to these effects were documented. So coming to the results, 49 apheresis procedures were performed in 45 children up to 15 kg of body weight were analyzed, and incidentally, all these were a case of neuroblastoma. So out of 45 patients, male-female ratio was 1.64:1, with a median age of 3 years, range being 1 to 5 years. So the stratification of cohort based on weight is as shown in cohort. As shown in the chart, we had 9 patients which were less than 10 kg in our study. So the mobilization regimen, 2/3 of the patient required Perixafor along with GCSF to mobilize CD34 counts because of low absolute peripheral blood CD34 counts. So this table depicts the leukapheresis procedure and product details. The median total blood volume processed was 4 TBV, and the median duration of harvest was around 5 years, 5 days. 5 hours. 41 out of 45 patients achieved target CD34 stem cell dose after single apheresis. The median stem cell dose being 9.7 into 10⁻⁶ per kg, while only four patients required second apheresis to achieve the target yield. So more than 90% of the children achieved target stem cell dose in a single apheresis. So apart from manageable side effects like mild symptomatic hypocalcemia and chills, all LVLs were well tolerated, and none of the procedure had to be discontinued. So we could find a study similar to our study in which they performed large volume leukapheresis in children weighing less than 15 kg. So similar to our study, the demographic characteristics and the study population were same like our study, and the target stem cell dose achieved was comparable in both the studies. However, the target CD34 dose in the study was more than 5, but with the dose of more than 3.5, none of the patient had difficulties in engraftment. So it is comparable. So to conclude, large volume leukapheresis in children below 15 kg with or without with GCSF with plus minus Perixafor can save repeat apheresis as depicted in our study, and there are no major adverse event, and large volume leukapheresis can be safely done as shown in our study. Thank you.
Thank you so much. Wonderful. Questions for Dr. Amit?
Yeah, hello, Dr. Amit.
Yeah.
Hello, ma'am.
Yeah, I'd like to ask you what was the CD34 level on day 5 in the morning before, on day 4, what was the CD34 level before you decided to give Perixafor in these patients?
So, ma'am, yes, ma'am. So initially in the initial phase, ma'am, we took cutoff of around 20 to give Perixafor or not, but based on our experience, ma'am, as we were evolving, so we could achieve adequate stem cell dose with large volume leukapheresis, even with the cell dose of 10 to 20, between 10 to 20. So later we kept a cutoff of 10 to give Perixafor.
Okay. And secondly, if you have the allogenic donors are there in those, what is your experience of this particular large volume apheresis?
So, ma'am, in allogenic donor, more than 95% of the donors get adequate stem cell dose. In allogenic, adequate is more than 5 into 10⁶.
Okay, thank you.
Yeah, Amit, just a minute, one question.
Yes.
Does any of these patients develop complications while apheresis happening during the
No,
procedure?
ma'am. No, ma'am. Like 3 patients, ma'am, they developed a mild symptomatic hypocalcemia, which was managed with calcium infusion.
And
Apart from that,
all required priming with one of the extra sample.
yes, ma'am, because of low weight of the donor, ma'am, to counteract low extracorporeal volume, or we as a policy giving PRC priming to all the donors.
Okay. Yeah, thank you.
Thank you.
Any other question? Okay, if none, then Amit, thank you very much. And that brings us to a coffee break, bio break.
Thank you.
We are going
Thank
to
you, sir.
Thank you. We are going to reassemble at 4:45 p.m. So have coffee with your family. Bye-bye.
wait, Dr. Gupta. There is some formality by Dr. Agrawal. Wait.
Yeah.
Okay.
Whenever you give us a signal, we will start.
Everyone, today I am presenting a research paper entitled.
Wait, Dr. Gupta.
Okay,
Dr.
okay.
Gupta, please wait. Dr. Agrawal will let you know.
Okay, perfect.
Start in, sir. 3, 2, go to Dr. Agrawal, please.
So, friends, we come to the post-coffee session, and the 12th paper, the J.C. Patel Best Paper Award session, is entitled Delineating the Genomic and Proteomic Landscape of BCR-ABL1-like ALL subtype, Bench to Bedside Translational Research. The presenting author is Dr. Dikshit Gupta, MSc PhD Scholar, Department of Hematology from PGI Chandigarh. And the co-authors are Dr. Neelam Verma, Dr. Ashish Kumar, Dr. Shano Nasim, Dr. Man Sachdev, Dr. Singh Updesh, Dr. Yogeshwar Binota, Dr. Parveen Bose, Dr. Srijesh Sridharanamuni, Dr. Amita Trehan, Dr. Alka Khandwal, Dr. Pankaj Malhotra, and Dr. Subhash Verma. Over to Dr. Dikshit.
Okay. This one. So my slides are visible?
Yes.
Yeah. A very good morning, a very good evening. So I am presenting a research paper. So coming to the introduction, BCR-ABL1 like acute lymphoblastic leukemia is a new provisional entity. It exhibits similar gene expression profile to that of BCR-ABL positive ALL and does not express the RNA fusion transcripts and proteins resulting from PH chromosome. Two widely used approaches, gene expression profiling and or next generation sequencing and Tegman load and stRA are used for the detection of BCR-ABL1 like ALL cases. As NGS is very costly and the data interpretation requires a lot of bioinformatics skills and TLD is not commercially available in India. To the best of our knowledge, there have been no previous study in India regarding the actual heterogeneity and cost-effective diagnostic approaches of BCR-ABL1 like ALL cases. The aim of the study is genomic and proteomic heterogeneity of BCR-ABL1 like B lineage acute lymphoblastic leukemia. Now coming towards the materials and method, this was a 5-year study starting from a period of 2016 to 2021. Flow cytometry, immunophenotyping, and multiplex RT-PCR were performed on 1,021 BLL cases to detect the positivity of translocation 922, 1221, 119, and 411. Further, 12 BCR-ABL positive cases were subjected to transcriptomic profiling using Affymetrix microarray. Now, for the detection of BCR-ABL1 like ALL cases, we use two independent platforms. The first one is a total of 96 BLL cases were subjected to targeted panel using Encounter platform according to our microarray gene expression profiling findings and previously published data. Molecular characterization of chimeric fusion genes in various subgroup of identified BCR-ABL1 like ALL cases was performed using FISH. Elucidated the copy number variation of IKZF1 having deletion of 4 to 7 exon in 108 BLL cases. The second platform is RQ-PCR. Selected 8 best classified genes were quantified in 536 BLL cases to make a 5-race logistic regression model for the rapid detection of BCR-ABL1 like ALL cases, followed by its validation in 93 BCR-ABL negative cases. The outcome of BCR-ABL1 like ALL cases were evaluated in terms of MRD positivity and induction failure in identified BCR-ABL1 like ALL cases. 9 housekeeping genes was evaluated using 6 algorithms in identified BCR-ABL1 like ALL cases, and finally delineated the global proteome of BCR-ABL1 like ALL cases using LCMS. Now coming towards flow cytometry immunophenotyping results, these are the clinical symptoms presented by BCR cases at the time of diagnosis. This is the flow cytometry getting strategy. Firstly, we get the singlets, then Weibel cell, then leukemic blast, that is CD45 dim positive, in order to see the expression of B lineage markers. This is a complete immunophenotypic profile of 1,021 BLL cases, and in some BLL cases, there's an aberrancy of myeloid-associated markers, and we found CD13 was 19.17%, CD33 was 18.11%, and CD117 was 3.52%. This now coming towards the multiplex RT-PCR results, in a cohort of 1,021 adult BLL cases, the incidence of BCR-ABL1 fusion transcript was 18.66%, including major fusion transcript was 9.43% and minor fusion transcript was 9.22%. Translocation 119 was 3.85%, 411 was 1.21%, and 1221 was 5.27% as revealed by multiplex RT-PCR. This 2% agarose shows 4 written fusion transcript in BLL cases, and we published these findings in the Journal of Leukemia, Turkish Journal of Hematology. Coming towards the microarray results, a total of 1517 4 differentially expressed genes, 460 in patient with minor fusion transcript, 515 genes in patient with B2A2 major fusion transcript, and 599 in patient with B3A2 major fusion transcript have been identified. Differentially expressed genes were identified according to the criteria. We use INOVA with a cutoff of 0.05 and log fold change of cutoff of 2. Differentially expressed genes were further filtered through hierarchical clustering, and total of 45 genes with 10 to 86 folds were identified. Now, after that, we validate the differentially expressed genes, but before that, we perform the identification of stable housekeeping genes using RefFinder software. In this study, we used 6 housekeeping genes and quantified in 48 BLL cases, including 24 BCL positive and 24 BCL negative cases. And we found GUSP and ABL shows the maximum stability in our study cohort and were used for further analysis. After that, we validate 12 differentially expressed genes identified from gene expression, microarray gene expression profiling, and quantifying 48 BLL cases, and the RQ-PCR results are in accordance with microarray gene expression profiling findings. Now, for the detection of BCL-like ALL cases, we use 2 independent platforms. So, initially in 2009, Mulligan et al. Used 257 probe set and predictive analysis of microarray to classify PH-like ALL cases. The second group is Den Boer from Dutch Oncology Children's Group, used 110 probe set and used hierarchical clustering for the detection of BCL-1-like ALL cases. In our study cohort, a targeted panel of 15 differentially expressed genes was constructed according to our microarray findings. A total of 96 PLL cases were subjected to gene expression profiling using Encounter platform. We refined 45 identified genes and selected 15 genes by performing pinnalized logistic regression analysis using GlimNet R package based upon previous literature and their regression coefficient values. Finally, 15 genes were selected whose performance was individually analyzed using ROC and AUC. Now, for the detection of BCL-1-like ALL cases from B others, we use hierarchical clustering and principal component analysis. Now, coming towards the result, initially 45 genes, we performed pinnalized logistic regression and select 15 genes. Now, out of 78 examined BCL-negative cases, 25 BCL-negative cases were clustered together with 15 BCL-positive cases and were attributed as BCL-like ALL cases in principal component analysis. Now, after that, we categorized BCL-1-like ALL cases. We found 20% CRLF2 upregulated cases in BCL-1-like ALL cases. The criterion taken as 10-fold increase from the median value, and the same were validated by RQ-PCR. The second category is 80% we found CRLF2 downregulated, and we performed chimeric fusion transcript evaluation using FISH in 12 cases of BCL-1-like ALL cases. Now, the first category is we found 20% CRLF2 upregulated cases. We performed the Sanger sequencing of exon 16 of JAK2 in 5 CRLF2 upregulated cases and found 2 missense variants. First is at 683 position where arginine gets converted to serine, and the second one is 694 position where phenylalanine gets converted to leucine. After that, we performed a quantification of 2 cytokine rearranged genes, and we found the downregulation of P2YR8 and CSF2RA. We evaluated chimeric fusion transcripts using FISH, and we found CRLF2 IGH and CRLF2 P2YR translocation with 8.33% each. Now, in the second category, we performed the expression of 13 kinase genes in different ABL class in different kinase groups. In ABL1 class, we found the downregulation of SNPC, FOXP1, NUP153. In ABL2 class, we found the upregulation of RCDS1. And the JAK2, we found the upregulation of PAX5 and ZNF274, and we found the downregulation of IL2RB, E4, FLTA3, and NTRK2. And we found 10% JAK2 rearrangement using FISH. And we evaluated the BCL-1-like cases in terms of MRT positivity and induction failure. We found 55% that is very high in BCL-like ALL cases as compared to 25% BCL-negative cases in our study cohort. And the same manuscript is ready for the public submission in the British Journal of Cancer. Now, after that, we illustrated IKZF1 copy number variation using digital droplet PCR. We found 9 cases having IKZF1 4 to 7 exon deletion in 108 BLL cases with a range of 6.14% to 69.8%. This is the overall workflow detection of BCRABL1 like ALL cases using Encounter nanostring. Now the second platform is like RQ-PCR. So initially we have 45 genes. We quantified 15 genes using penalized logistic regression, but it's very difficult to multiplex all these genes in a single reaction. So, and this technology has little drawbacks, like the cost is very high and the turnaround time is very high. So we propose the use of RQ-PCR because it overcomes all the drawbacks. And we again perform penalized logistic regression and select 8 best classifier genes quantified in 536 BLL cases. In using RQ-PCR, we found 143 out of 536 BCRABL inactive cases showed clustering with BCRABL positive ALL cases and were attributed as BCRABL like ALL cases. Using 3 different approaches. First one is hierarchical clustering, principal component analysis, and heat map analysis. Now, after that, we finally created a binary logistic regression model entitled PHI-RACE using R software. Initially, we identified 143 BCRABL1 like ALL cases and 285 B others. Here, B others means that is negative for 4 recurrent translocations in BLL cases. We performed the univariate analysis and identified age, fever, pallor, CD33, 58, and all the 8 genes are statistically significant. Then we performed the multi-collinearity of data, and we didn't get the multi-collinearity in our data. Then we performed the correlation matrix, and we didn't found a strong correlation between genes. Then we divide the data into 2 sets, training and test set. We performed a logistic regression classifier using GLM package, and we found a very good ROC of 0.927% with a sensitivity of 95.2% and 83.7%. Then we generate different confusion matrix and set a cutoff of 0.28 to differentiate BCRABL1 like ALL cases from B others. Finally, we validated this PHI-RACE classifier with 93 BLL cases, including 56 BCRABL like cases and 36 B other cases. This classifier accurately detects BCRABL like ALL cases, and this classifier we have published in Leukemia and Lymphoma journal. Then finally, in BCRABL like ALL cases, we performed the quantification of 9 housekeeping genes using 6 different softwares, including Genome, Norm Finder, Keeper, Delta City method, Ref Finder, and Component Finder. And we found GAPDH, EAF2, PGK1 shows the maximum stability in BCRABL like ALL cases. This is the first report from India because no other reports shows, because for the detection of BCRABL1 like ALL cases, the gene expression profiling is the gold standard. And we showed these 3 genes which show the maximum stability in BCRABL like ALL cases. And the same manuscript is ready for the submission in Journal of Molecular Diagnostics. Now, finally, we delineated the global proteome of BCRABL like ALL cases. The sample preparation are according to in-house protocol of PGIMEA. We found 3,079 proteins, 1,578 were upregulated and 137 were downregulated in BCRABL like ALL cases. Further, we dissected the biological network of this BCRABL like ALL cases using 6 different softwares. This is a Manhattan plot, shows the functional profiling of upregulated and downregulated proteins in BCRABL like ALL cases. 279 proteins crossed the threshold and was further studied. Gene ontology in the molecular function, majority of the proteins in BCRABL like ALL cases are of binding nature. In terms of biological process, majority of the proteins involved in the splicing process, and in terms of cellular component, majority of the proteins are intracellular. Then we perform the which pathway is statistically significant. We use 3 different softwares, CAG, Reactome, and Wiki pathway, and we found 4 pathways are very highly statistically significant in BCRABL like ALL cases, including mRNA splicing pathway, spliceosomal mediated mRNA splicing pathway, RNA transport, and mRNA cell-based pathway. This is I'm not going to details of this mRNA splicing pathway, but in BCRABL like ALL cases, majority of the splicing factors were upregulated. Finally, we model all the splicing factors in a single platform using Klugo and Klugopedia. There's one publication published by Black et al. They showed the aberrant splicing factors in B-cell acute lymphoblastic leukemia. But in our case, we found majority of the splicing factors were upregulated in PH like ALL cases. There's one more study by Sarah et al. They showed the fusion partners of kinase genes highlighted in boxes, and we found majority of the kinase genes were upregulated in BCRABL like ALL cases. As J chain is very important predictor in BCRABL like ALL cases because it's highly upregulated in genomic part and highly upregulated in proteomic part. We found the protein-protein interaction of J chain. We found 6 interacting partners were already reported in acute leukemia. So one prospective study will be required to evaluate the expression of these 6 interacting partners of J chains in order to find the early biomarkers for PH like BCRABL like ALL cases. We also found 4 different microRNA which is highly statistically significant in BCRABL1 like ALL cases and were already reported in acute leukemia patients. So one prospective study will be required to assess the expression of these 4 microRNAs in order to find a novel early biomarker for the detection of BCR1 like ALL cases. Finally, coming to summary and conclusion, we have detected BCR like ALL cases using two independent platforms. First is NanoString. We found the incidence of 32.05%, and RQPCR we found the incidence of 26.67% using hierarchical testing and principal component approach. Our RQPCR finding in accordance with Jan et al., who reported the incidence of 33.1 BCR like ALL cases using TLDA approach. As TLDA is not commercially available in India, we have devised a very simple, efficient, cost-effective RQPCR method using 15 and 8 selected genes for the detection of BCR1 like ALL cases. Finally, we have created a machine learning binary logistic regression model, FIRACE, for the first time in developing countries to detect BCR1 like ALL cases. And also, we have shown EF2, GAPDH, and PGK are stable SK genes for gene expression profiling BCR like ALL cases for the first time in India. It is very important to detect BCR1 like ALL cases, so to provide them the benefits of desirable TKI therapy. And we have delineated the protein profile of BCR1 like ALL cases for the first time in Indian patients. So, thank you so much.
Thank you, Dr. Dikshit.
Thank you so much.
Discussion, questions? Our judges, Dr. Pranter, Dr. Akanksha. So I presume there are no questions for you. Thank you so much for that elegant piece of work. Fantastic. We move on, go to Dr. Ashish Joshi, consultant medical oncologist and hematologist, clinical research, Mumbai Oncocare Center, Borivali. He's going to present dasatinib-induced lymphocytosis and pleural effusion in a patient of chronic myeloid leukemia, a rare Indian case report. And the co-author is Dr. Disha Bipin Murzaria. Over to Dr. Ashish.
Thank you so much, sir, for this opportunity. So I'll share my screen. Is my screen visible to everyone? So good evening, everyone, and respected senior colleagues and judges. I'm here to present a fairly uncommon, though reported phenomenon of dasatinib-induced lymphocytosis, pleural effusion in a patients with chronic myeloid leukemia, a rare Indian case report. We all know that occurrence of a large granular lymphocyte proliferation and pleural effusion is one of the most common complications following dasatinib therapy. Lymphocytosis after achieving a complete hematological response due to LGL proliferation, though reported in literature, is fairly uncommon or underreported event. Such lymphocytosis can possess clinical dilemma, and hence understanding this phenomenon during the TKI therapy, especially with dasatinib, is very, very crucial. LGL proliferation, pleural effusions are interrelated events, and they are probably due to immunomodulation induced by TKI, though the exact etiology is not known. And more interestingly, in LGL proliferation may have a prognostic significance too. So here we have a case who was a 60-year-old lady who presented with asymptomatic leukocytosis and then subsequently was diagnosed to have a CML-CP. She was in so-called intermediate risk group. She was started on tablet dasatinib at 100 milligram OD for initial period of 3 months, and she underwent a complete hematological response in 1.5 months, and treatment was continued subsequently. Now, this table elucidates how her molecular response was achieved. We started in Jan 2018, and almost in 8 months' time, her BCR-able RQ-PCR by IS was 0.0126, almost approaching a MMR4 cutoff of 0.01%. So she was doing very, very well on the treatment and was tolerating treatment also pretty well. But then came in a couple of months, she presented to us with severe fatigue, mild breathlessness along with low-grade fever. She was clinically pale, and her hemogram shows hemoglobin of 7.9. She had leukocytosis with absolute lymphocyte count being 56%, and they were reported as dysmorphic / atypical lymphocytes. Platelet count was normal. Her LDH, serum ferritin level, iron studies, vitamin B12 were all within normal limits. And an RQ-PCR, BCR-ABL by IS also was dwindling, showing a sustained molecular response. So this made us think about one, because of the breathlessness, is there a effusion which is coming up? And what is this lymphocytosis because of? Is it something else? Is there a clonal evolution, though very uncommon because BCR-ABL is dropping? She subsequently underwent a bone marrow aspiration and a biopsy and a flow cytometry to rule out lymphoid clonality and tri-lineage hematopoiesis. So this was an typical X-ray that we often see for patients who are on dasatinib. She had a moderate effusion on the left side. This particular chest X-ray again amplifies the same. So as per the guidelines, the dose modification or the one level dose reduction was done, and it was reduced to 50 milligram per day. Patient was started on steroids and diuretics, which is again a very common way of managing dasatinib-induced pleural effusion. Subsequently, patient also underwent immunophenotyping, which was done on flow cytometry using panel of multiple antibodies, as you could see here. And more interestingly, this flow cytometry revealed that there is a lymphocytosis, but the predominant lymphocytes being the increasing NK cells, as has been described in this particular cartoon, because there were certain CD expressions which were typical of NK cells which were seen. So there was exuberant NK cell lymphocyte proliferation, which accompanied the pleural effusion in this patient. After reducing the dose of dasatinib and also temporarily discontinuing it for a period of time, patient's pleural effusion improved, and she was subsequently restarted on dasatinib. These were the CBC counts, as we could see, starting from 31st December when she started having the leukocytosis and drop in the hemoglobin, but which subsequently improved with over a period of time after we reduced dasatinib temporarily and then restarting it. So the steroids and the diuretic helped her to improve her effusion. The lymphocytosis was then confirmed to be LGL and pleural effusion had subsided. So the dasatinib was continued at a lower dosages and then subsequently increased to the normal dosages in spite of leukocytosis being there, because we knew that it's LGL leukocytosis which was happening and there is no clonal proliferation. Subsequent, she's been on follow-up since last few years with us, and she has achieved MR 4.5, in fact, complete molecular response, and her BCR-ABL continues to remain undetectable, and she continues to receive dasatinib at 100 milligram per day. So the discussion points and take-home is that lymphocytosis is an immunomodulatory phenomenon which is often associated with dasatinib therapy, and there is a LGL lymphocyte proliferation which is known to have associated with TKIs, especially with dasatinib. It has been speculated that the SRC group of kinase, which has a very crucial role in lymphocyte trafficking between intravascular regions and tissue, are inhibited by dasatinib, which may be the reason for lymphocyte alteration and proliferation. The temporal association of lymphocytosis preceding the effusion highlights the scientific fact that both of these phenomena are interrelated, though lymphocytosis is not as prominently described as pleural effusion. It is important to continue dasatinib with required dose modification, but lymphocytosis and leukocytosis per se should not alter the therapy. And more importantly, there was a study which was recently reported, which showed that lymphocytosis occurring during dasatinib therapy, patients had a higher rates of pleural effusion, but this was also associated with improved response rates and a better outcome. So with this, I conclude my short presentation. Thank you.
Thank you very much. Any discussion, questions? Okay, if there are none, Dr. Ashish Joshi, thank you very much for contributing to this meeting.
Thank you so much.
Go to the next presentation. And that is our 15th presentation, comparison of FISH results before and after plasma cell separation in 299 cases of multiple myeloma, to be presented by Mr. Rupesh Sanak from Department of Assisted Reproduction and Genetics, Jaslok Fertility International Fertility Center, Jaslok Hospital, Mumbai. Co-authors include Dr. Prochi Madon, Dr. Arundhati Atle, Dr. Dhanashri Waran, Dr. Preetam Tari, Dr. Prashant Padyal, Dr. Vasant Dhumal, Dr. Mahendra Sute, and Dr. Firoza Parikh. So over to you, Rupesh. Rupesh, you are there?
Hello.
Yeah, Rupesh.
Am I audible, sir?
You're audible.
Yeah. Is my screen visible, sir, to all?
No, not yet.
Hello. Is the screen visible?
It's starting, I think.
Hello.
The screen is
starting,
not yet visible, starting.
Not yet started. Okay.
Start. Yeah, now we can see it.
Okay.
Dr. Rupesh?
We lost your audio now.
Okay. Is it there?
Now we can hear you. Yeah.
Okay. Thank you so much, sir. Hello.
Yeah, go ahead. Go ahead.
Thank you so much, sir. Yeah, it's been always pleasure to talk in MHG, and I would like to thank Mumbai Hematology Group for giving me this opportunity to talk about my fish results in multiple before and plasma cells. Myeloma accounts fall and 10% of all the hematological malignancies. It is a cancer of plasma cells, which is are a type of WBCs which make antibodies, and those antibodies fight the infection. Plasma cells are CD138 positive. So when plasma cells grow out of control, they form tumor in bones called plasma cytosis. So when there is only one tumor in the bone, it is called solitary or isolated plasmacytoma. And many plasmacytomas, many tumors in the bones, the condition is called as multiple myeloma. So much more chromosomal abnormalities than the conventional cytogenetics, that is karyotyping, in multiple myeloma cases. So a majority of myeloma patients, when you see the bone marrow, are often non-malignant, that is non-PCs, non-plasma cells, rather than the malignant PCs. As a result, if the PC population is low in the bone marrow, it may be difficult to identify the abnormal cells, and the test results may not be accurate to give the diagnosis. So this requires purification of the plasma cells to get accurate fresh results. So basically, this was to on the unsorted bone marrow cells and isolated plasma cells in multiple patients. Also in the study, the fish abnormalities detected in cases of fish abnormalities. That's what we wanted to check. So for doing this study, we used heparinase bone marrow myeloma cases sent to our laboratory for the routine cytogenetics study. So total of 299 cases were studied, of which 8 samples were used for the protocol. And for that, the part of unsorted bone marrow sample was directly used for fish setup without isolation of the pieces. And fixative using a standard fish protocol. Then the fish was set up on these cells. And the remaining portion from the bone marrow aspirate was used for the plasma cell isolation. So for the plasma cell, CD1 positive selection kit from stem cells technologies was used, and the operation was using magnetically CD1 positive cells, which was followed by positive selection using magnetic separation. Using manufacturer's protocol, CD138 positive cells were isolated and treated with hypotonic solution and Carnage fixative to set up the phage on those cells. Different probes were different chromosomes. Those were used from the Oasis company. For the loci, we used the fish probe for 13q14.3, 13q34, P50, 12, and also IGS, that is 14q3. On both isolated plasma cells and unsorted bone marrow, the fish was set up to compare the results. Next day, according to the protocol, next day the signals were observed under the microscope using Metasystems software, which is ICS. And when there was the rearrangement of IGS locus, those cases were further tested for 414, and then 16 find the partner chromosome of IGS rearrangement. Another 191 case, we set up only on isolated cells of isolation was those fish showed the comparison showed the percentage of cells with abnormalities was 3 to 5 times higher in isolated plasma cells compared to unsorted bone marrow. So 108 samples, 6 were uninformed that those give the results, while 42 were uninformed for the isolated CD138. So we could not report or get the results, maybe because of low plasma cell count or insufficient leftovers So these are abnormalities, average percentage of the abnormalities on unsorted bone marrow also, and isolated PC and showing number of cases. So there was deletion 13q14, deletion P53, IGH rearrangement, then translocation 414, 1416, trisomy 11, and etc. Just for the representing purpose. So the first image is bone marrow is showing a normal cell basically, showing 2 green, 2 orange, and 2 alpha signals for chromosome 12, the loci 13q143 and 13q normal cell of both. As is a plasma cell showing 1 green orange fusion on the left sides and 1 red green and orange, which is a positive cell IGH arrangement group showing a break apart signal pattern. Now the third image, you can see a plasma cell 13q34 where there are 2 screens in the chromosome 12, 1 signal from 13q14 and 2 signals for 13q34. So out of those 66 informative cases, the abnormalities were detected out of those total abnormalities. The abnormalities were detected in 49 cases on unsorted bone marrow versus 56 cases on CD1 positive isolated cell. So this was a graph showing abnormalities in unsorted bone marrow versus isolated plasma cell. And you can see clearly it is showing almost 4 times higher the abnormalities rate. Similarly, some abnormality-wise comparison, like first one is the heterozygous deletion for P53. Those that was seen in 29% cases of bone marrows, but 74% isolated pieces. This is the average percentage abnormality. Again, monosomy 13 was like seen for average 21% cases, and the plasma cell and the monosomy 13 or deletion 13q was seen in 80% average plasma cells, isolated plasma cells. Same IgH rearrangement was seen in average 60 unsorted bone marrow, 80% on isolated plasma cells. And we set up fish of IgH rearrangement in one case. It showed positive results with a break apart signal pattern, which is one fusion and three orange signals in 42% bone marrow, unsorted bone marrow versus 99% in isolated plasma. So further, to find out the chromosome, we set up a probe for translocation 414, that is IgH FGFR3, which was the dual fusion. So the results showed, like you can see in the second image, there were 3 green signals. We report as trisomy 4.
We lost him, sir.
Dr.
Dr. Dattani is also not there, sir.
Yeah, Dr. Rupesh, we lost now. So I suppose we come to an end of this afternoon session. Thank you very much for participating in Dr. J.C. Patel Best Award session. We had 15 papers today. And as was mentioned earlier, the results will be announced at 8 p.m. tomorrow. The evening program is the industry-sponsored symposia, which will begin at 6 p.m. sharp. And we will have a breakdown. So
we have come to an end. मला चालू आहे.
Kalpesh, we put it at hand?
Yes, sir, sure. Yeah.
Good evening, friends. This is 45th Annual Conference of Mumbai Hematology Group. Thank you very much for being with us for the whole day. Many of you must be quite tired. You have been with us from 9 o'clock onwards almost. And the last 45 minutes break must have been very refreshing to you. This is day 6. These webinars are supported by Mice Ideas, and they have managed everything so beautifully, and I'm thankful to them. This evening, we have 3 industry-sponsored symposia. The first one from RR Mechatronics, Masters of Measurement. The second one by Zydus, and the third one by Astellas. We come to the first webinar this evening, and this will be a lecture by Rutuja Muthal, application scientist, RR Mechatronics. The title of her talk is Functional RBC Analysis for a Better Understanding of Sickle Cell Disease and RBC Membrane Disorders. Well, over to Rutuja.
Thank you, sir, for introduction, and it is thank you for the opportunity. I have always been part of Mumbai Hematology Group since my PhD days in National Institute of Immunohematology, and then I started working as application scientist in Amsterdam-based company RR Mechatronics. So this is like playing cricket match on home pitch for me. Hello, everyone. I'll start my screen, sharing my screen.
Yes.
Is it visible?
Yes.
Okay. Perfect. So my topic for the day is functional RBC analysis for a better understanding of sickle cell diseases and RBC membrane disorders. So before we dive into the topic, I would like to give brief introduction of RR mechatronics. I can go to next slide. Just give me a minute. Somehow I can't go to next slide. There's some technical issue I'm trying to solve. Yeah, apologies for the disturbance. So I'll start with introduction of my company. It is Dutch-based company and has global presence in medical IVD technologies. It was established in 1986 and is present in Amsterdam and also in United States. So our focus is on hematology, and we are leading in 3 product fields. StarSet, that is gold standard ESR, which is based on ICSH approved Westerland principle. Then there is CORME, which is automated instrument for reconstitution of regions. And last but not the least, LORCA, which we are going to discuss in detail today. We are masters of measurement. We as RR Mechatronics team believe that every patient deserves right diagnosis and care. With our focus on hematology, we help to provide precise and accurate laboratory measurements. And by developing, producing, selling, servicing state-of-art medical technology solutions. Let's start with LORCA. LORCA is RBC ectocytometry. So LORCA helps in measuring deformability under different challenging conditions such as osmolality or deoxygenation, revealing various characteristics of the disorders. It is validated technology and is in market over a decade. Already there are many PEP publications of LORCA in LORCA. LORCA is research use only instrument, but it is also used in several labs in CLIA and diagnostic settings. Application of LORCA covers broad spectrum of RBC disorders, including membrane disorders, enzyme deficiency, hemoglobinopathies, infectious diseases like malaria, sepsis, and blood quality. So LORCA is based on principle of diffraction. LORCA has attachment of cup and bob, as you can see in this picture. Bob is a cylindrical shape that is immersed in a cup, forming thin layer of RBC, which is in flow and is exposed to shear stress. And the diffraction pattern produced by laser beam is calculated. So a circular pattern is seen at the beginning, and with increasing shear stress, it changes to elliptical shape. This quantification of this process is done with elongation index formula, which can be seen here. LORCA is small tabletop instrument which is user friendly, and it is equipped with 3 tests: deformability, osmoscan, and oxygen scan. It requires very less amount of blood, that is 25 microliters to around 200 microliters, and it ranges from 1 minute to 20 minutes depending on the test. So we'll start with deformability measurement. As we all know, deformability is important for cell viability and also is essential factor for optimal circulation. Here we can see in this graph on, on exposure to increasing pressure, the pattern changes from circular to elliptical, giving rise to a graph that can indicate various RBC dysfunctions. I would like to further explain this with the help of graph over here, which is from below mentioned publication. In this graph, you can see that patient with malarial infection on day 0 had reduced deformability. But after treatment with arginine, at day 28, it was seen that deformability was regained as good as healthy patient. So this test helps to study overall deformability of red blood cells and overall state or quality of red blood cells. We look into next test, osmoscan. Osmoscan is measure of deformability over various osmotic gradients. And this produces continuous curve, as you can see in this picture, with low osmotic pressure to high osmolality and back to low osmolality. This function is important or gives information about membrane deformability and membrane rigidity. It is important for various membrane disorders. This is used to distinguish various hereditary anemias. As we can see in these graphs, the 2 gray lines which we can see here is range of healthy control, while the graph in red line indicates various hereditary anemias, such as spherocytosis, Southeast Asian ovalocytosis, elliptocytosis. Here we can see there is right shift in the curve, while extreme left shift is seen in stomatocytosis. Next interesting feature of LORCA is oxygen scan. Oxygen scan was recently introduced in LORCA techniques and is unique and patented technique. It was introduced around mid of 2018. Oxygen scan measures deformability over gradient of oxygen, that is deoxygenation and reoxygenation. Here we can see different patterns or diffraction patterns of RBC of healthy person, sickle cell patient, and deoxygenated sickle cell. Here we can see representative oxygen scan curve. I would like to explain important parameters of oxygen scan. Those are EI max, that is elongation index maximum. It represents deformability of overall RBCs before deoxygenation starts. Next, and very critical, very important parameter of oxygen scan is point of sickling. It is typical to each patient. It is relative oxygen pressure at the point where cells start to sickle or form crescent shape. And next is EI minimum, that is elongation index minimum. That is deformability of cells when they are already changed in shape or, or in sickle shape orientation. And the last phase is reoxygenation, or is also called as recovery phase, wherein we can see how many number of cells that can go back to their original state after deoxygenation. Here is a picture of oxygenated cells in oxygen scan and deoxygenated cells in oxygen scan. We can see they're already in sickle shape. So your oxygen scan, after it was introduced, soon gained popularity and was appeared in many scientific publications. In next few slides, we are going to discuss some of the important results from these publications. So the oxygen scan was first studied in Utrecht University, that is based in Netherlands. And this was the first paper which appeared in 2019 from Minkaram and her colleagues. Let's start with graph D. All these graphs represent that oxygen scan is able to discriminate between different genotypes and treatment regimens. So in graph D, we can see there is first straight line that is of healthy control. Since as we know, there is no sickling seen in normal blood, so there is no curve or point of sickling seen in healthy control. It appears as a straight line even in deoxygenated and reoxygenated phase. The second line or second graph in graph D is for HBS trait patient. There is slight curve in that since some of the cells sickle during deoxygenation. For both the patients, EI max, that is the starting point of the line, is around 0.6. 0.6 is normal EI max for healthy control patients. Healthy controls. And the last graph is the line in black is of HBSS untreated patient, which shows severity of the disease. As we can see that EI max for that graph is very low. A point of sickling is high, and even EI minimum is quite low, indicating the severity of disease. Now we can see in graph A and B what happens when patient is started with treatment. As you can see in graph A and B, the patients were started either with hydroxyurea or transfusion. There is significant change observed in their oxygen scan graph, and we can see there is improvement in all the parameters of oxygen scan. And let's come to graph C, wherein we can clearly see there is distinction between milder form of sickle cell disease, that is HBSC, compared to HBSS untreated patient. I would like to mention here that oxygen scan is not for diagnosing various genotypes, but it is a reflection of condition of patient and severity of disease. This is a similar example. It is from Texas Children's Hospital. Here we can see that individual A or patient A has good parameters, good oxygen scan parameters with high EI max, high EI min, and low point of sickling, indicating that patient may have less dense cells or more HbF levels. And in individual B, we can see that all the parameters of oxygen scan are deteriorated. I would like to show in patient A, we can see that recovery phase is also quite good. while in patient B, recovery phase is not that good, indicating there is hemolysis. This, in both the slides, we could see oxygen scan represents or reflects condition of patient health. This is another paper from the same Utrecht University showing quantitative improvement of treatment over the time. So here in graph E, we see compilation of treatment monitoring of oxygen scan graphs. So in black line or black curve, we can see the baseline, which is where we can see that it is severe. The EImax is low, EImin is low, and point of sickling is high. After starting hydroxyurea and observing it in oxygen scan after 1 month, it was seen that there is improvement in patients' oxygen scan parameters. Over 3 months and 6 months, we could significantly see the change in oxygen scan parameters, and it is evident that there is improvement. This is extrapolated part of this graph showing other parameters. Point of sickling is gradually decreasing over the time, showing improvement in patient health. And in graph G, we can see that EI minimum is gradually increasing, showing the improvement. This is interesting case study wherein we can see two graphs of twins, 10-year-old twins. They started their hydroxyurea. Their baseline curve was similar to any other severe condition patient, and their treatment was tracked using oxygen scan. After 3 months, here in this graph, in both the graphs, we can see that there is quite a lot of improvement in oxygen scan parameters. But after 6 months, it was suddenly seen that graph went back near baseline. Here it is almost like a baseline values. And this triggered questions and investigation. On investigating, it was seen that there was increase in body weight of the streams, and it required hydroxyurea dose adjustment. On dose adjustment, and after 2 months, it was clearly seen there was improvement in their oxygen scan parameters. So this can help to avoid future complications, and it is easier to track development through oxygen scan. Now this is schematic representation of application for gene of LORCA for gene therapy. Here we can see that LORCA oxygen scan can help in patient selection. This is example of point of sickling value, wherein it can be seen that patient has severe condition. After patient selection and cell corrections and cell transplantation, LORCA again comes into picture, and it can be seen that LORCA helps to monitor treatment or evaluate effect of gene therapy, also check whether there are chimeric RBCs, and decide next flow of the treatment. This is envision workflow for clinical LORCA oxygen scan. So this is for clinical LORCA, and here we can see the initial screening method. So after diagnosing the sickle cell disease and confirming it with genetic testing comes the important role of LORCA oxygen scan. It helps to assess severity of the patient with the help of point of sickling, and it helps to design treatment plan. Also, it helps to check whether there is adherence of treatment and treatment monitoring. So there are a plethora of sickle cell disease treatments and development, and LORCA is used in preclinical research in some of these companies, and also in in some cases in clinical phase. So LoRa can play important role to communicate health status of functional RBC to patient. Here in this graph, we can see that there is baseline graph. Oops. Here in this graph, we can see that there is baseline graph I can show it with this. So in all the 7 patients, we can see there is baseline graph and there is improvement in red color for the patients. So this can help to make patient understand about their functional RBC condition, their improved health after treatment. This can encourage them to adhere to the treatment and also to monitor flow of their treatment. So now to summarize everything, LoRa has 3 tests: deformability, osmoscan, oxygen scan. It covers broad spectrum of RBC membrane disorders, enzyme deficiency, hemoglobinopathies, infectious diseases, sepsis, and blood quality. Instrument is user-friendly. It requires as less quantity like 25 to 300 milliliters. It measures quantitatively severity of disease. It helps in accelerating upcoming therapies for sickle cell disease and also to differentiate in various membrane disorders. So, what do you think if patient comes to you and asks, "Hey doctor, how has my POS improved?" Thank you. I would like to acknowledge my colleagues who are attending this conference and who have contributed to the product and to this presentation. Thank you, everyone.
Thank you. Thank you, Pooja. This was fantastic. Very impressive.
Thank you, sir.
We just glued to your talk for the last 30 minutes. So we have got the colleagues here. Any one of you would like to interact with her, ask some questions? And the audience, you have been there from almost 14, 15 countries. If you want to put some question in the question box.
I would be happy to answer some questions.
Yeah, I'm sure. Yes. So we're waiting for the questions, please. Till they can think of some question or the audience put some question in the question box, I must say the application appeared very, very impressive. The
Thank you, sir.
graphics that you've shown were extraordinary.
We are also available to answer questions offline, so that is also okay.
Well, okay, then thank you so much, Rutuja. That was fascinating, and I'm sure we will have further interactions like this in future as well.
Sure, sir. It was very exciting and enjoying session for me. And I wish everyone nice evening.
Thank you, and bye-bye.
Bye, sir.
We'll move on to the second session, and that's supported by Zydus. And this one is a panel discussion on maintenance treatment in acute myeloblastic leukemia with focus on oral agent. Moderator is Dr. Pravas Mishra, Director of Hematology and Bone Marrow Transplantation, Max Hospitals Max Hospital, New Delhi. The panelists include Dr. Akanksha Garg, Ahmedabad, Dr. Ashish Dikshit, Bangalore, Dr. Asif Iqbal, Guwahati, Dr. Chandrakala, Mumbai, Dr. Dharma Chaudhary, Delhi, Dr. P.K. Jayachandran, Chennai, Dr. Priyanka Samal, Bhubaneswar, Dr. Ranjit
Dr. Pravas? I think so. Dr. Agarwal is having some network issue. You please carry on, sir. You have to unmute yourself, sir, please.
So whenever he says, I can start.
Yeah, he'll come back here.
All right, I'll wait.
So Pravas,
Yes, sir.
start the.
We have all the panelists, sir, because I could not see all the names, but
Well, not all, but I think you can go ahead. We have got Satish Kumar, Shivudu, Ritu Jain, Jayachandran, Dharma Chaudhary, Chandrakala, Akanksha. So there are plenty of them there.
yes. So thank you, sir. And I'm going to be moderating this panel on, I'll just reduce this here. So on maintenance therapy in acute myeloid leukemia with a focus on oral medications. So these are the panelists. And the way I have, since there were, I think there were 10 panelists to begin with. So the way I have done it is that I've asked some questions and bunched together a couple of panelists. So if in case anyone is missing, the other one or two can take up the questions. So starting with the survival data, so this is from Kantarjan et al. In 2021, and they showed the survival data over the last several decades. So starting, this is on the left-hand side, we have got the age less than 60, and the other side is age more than 60. So in the 70s, as you can see on the left side, there was 13% 5-year survival, which went up to 21%, then went up to 34%, and then 49 and 55%. So since 2000 until date, there seems to be certain, it hasn't really budged much. So most of your patients will not be surviving. So half your patients will not be surviving after 5 years. On the right-hand side of this, if you look at the other graph, age more than 60, it is very dismal. And from the 70s till since the last decade, there appears to have been some improvement, but not as much as it has been seen in the younger age group. So most of this improvement on the left-hand side and also some of the improvement on the right-hand side is basically because of an improvement in supportive care. And since the 70s, we have had, the cytarabine plus anthracycline, which has been the standard of care. It has been the bulwark of our treatment protocols, intensive chemotherapy protocols for acute myeloid leukemia for the last 30, 40 years. And subsequently in 2012 and 2015, we received the approvals for hypomethylating agents, and we all know how that has gone about. From 2017 onwards, we have had a slew of new molecules which have come along. Primarily, we've got midostaurin. This is a FLT3 inhibitor in combination with cytarabine and daunorubicin. Then we have got liposomal cytarabine and daunorubicin used at a fixed 5:1 molar ratio for TAML. Then venetoclax, of course, probably the new rituximab used everywhere, left, right, and center in combination with azacitidine or decitabine. Then IDH inhibitors in relapsed or refractory AML. And then, of course, the oral azacitidine, CC486. So this has again been approved primarily for continued treatment in those patients who are in first remission after intensive chemotherapy and are not fit for any further treatment. And then oral decitabine, cedazuridine for CMML patients. So these are the notable additions that have been there in the last 4 to 5 years. And of course, we have got venetoclax, which is used either as doublet regimens in combination with hypomethylating agents or even as triplet. So the studies are there in the last ASH. We have seen it with midostaurin, gilteritinib, and quizartinib, and various other such combinations. So these are all there. Now, the issue with acute myeloid leukemia, to my mind, is that we are able to achieve a remission in about 60% of the cases, 60 to 70% of the cases to begin with. The problem is, how do we maintain them? Because most of them would be relapsing after a period of time. And that is where all of these therapies are coming in, but none of these therapies that we are looking at, even the newer molecules, have actually improved the long-term remission status. So we are trying to see if we can apply maintenance therapies. So this is where we start with the questions. I wonder if any of the three panelists are here. I think Dr. Gundeti is here and Dr. P.K. Jayachandran, I could see their names. So are you convinced that we need some kind of additional therapy or maintenance as a strategy towards changing the natural history in AML?
Yes, sir. I'm Dr. Sadashi, sir. Definitely, sir, there is a role of maintenance therapy because except APML, we don't have any maintenance therapy in acute myeloid leukemia, whether it's a low risk or intermediate risk or high risk after transplant. But maintenance therapy definitely will give us some time to definitely it's a progression free survival, you can say, or disease survival. I think I'm really waiting for the but full data, but at this point of time, I'm convinced that there is a role of maintenance therapy in acute myeloid leukemia. Sir.
Dr.
Do we
Jason
have-
Mania, sir.
Yes.
So regarding the maintenance of AML, from the data what we have, so we have data for FLT3 inhibitors as a maintenance in patients who have not got transplant. Post-transplant maintenance, we have to be very selective about the patients because of the very sparse data. How to be very important selection of patients. Whereas in pre-transplant patients who are not eligible for transplant, the main aim is to for the relapse-free survival. So I would be convinced with the data of this azacitidine, and also patients with the FLT3 inhibitors, midostaurin, as a use as a maintenance in patients who are not undergoing transplant. So something is required for them to push the disease, because once the disease gets relapsed, almost survival are dismal. We don't even we are not able to salvage at least 25% of them, and we are not able to cure at least 10%, 15% of them. So always I would try to push the disease coming back later, so that they enjoy some disease-free survival. So I would like to pretty much convince enough in the maintenance part in patients who are not eligible for transplant.
So basically, what you're trying to say is that we are not sure whether this will actually cure the disease completely, but will push the disease. I mean, the relapse will be pushed further on, something like
Yes,
myeloma.
absolutely, sir. Something like that.
So as the Dr. Sahu is not there, I believe, on this thing. So going on to the next. So yes, as you have rightly pointed out, relapse after transplant or relapse after any kind of chemotherapy continues to be our problem. And there are several issues when we are fighting this. We have got the price, of course, like for example, venetoclax, if somebody wants to give, that is extremely expensive as of now. Then various drug interactions, we are not sure how these drugs are going to interact with each other. We are not sure who to treat. Do we need to give it to everyone? Is it to be given only to those who are MRD positive, pre or post HCT? We are not sure when to start, when to stop. Then of course we also face issues with tolerability, and we currently still, as our previous panelists have just mentioned, that the data is very limited. So we still don't have enough data to support our decisions. Then if you look at this particular slide, these are patients with acute myeloid leukemia. Right in the center, you'd see lots of these molecules, everything, whether they're eligible for intensive induction therapy or intensive chemotherapy. Most of our studies and interventions are directed towards achieving that remission or trying to achieve an MRD prior to the transplant. But we know that most of the patients go on to, go on to have relapses, and that is where we need probably to focus our attention. We still do not have enough data to support any kind of therapy post transplant or even after the post chemotherapy patients. So I think we have Dr. Akansha. I'm not sure if we have Dr. Asif and Dr. Priyanka on the panel, but which group of patients must receive maintenance? Who would benefit the most? Do we need to give it post-transplant, or do we only give it after post-chemotherapy, or any other kind of ideas that you would have?
Yeah. Yes, sir. Thank you, sir, for the question. So actually, the goal of the post-remission therapy, according to me, is basically to improve the relapse-free survival, as already has been discussed previously. And also the another aspect is to suppress the minimal residual disease so that the patient does not develop a positivity of the MRD and subsequently go into the state of relapse. And another aspect is the acceptable quality of life that is required for the patient. So I think as of now, if we have to choose, which patient should receive maintenance for AML, I think it would be patients who have had high risk disease, like the patients having FLT3 positivity, they would require maintenance, especially if they are unable to undergo a transplant due to their various comorbidities, due to the age, like in patients who are above 60, 65 years of age, or having a poor performance status. So in these group of patients, as well as patients who have not had a complete CR, have had an incomplete recovery of the count, these patients should receive maintenance. And also patients, again, patients who are post-transplant, and post-transplant, again, we know that a lot of us are using maintenance in many of our high-risk AMLs in the form of monthly cycles of HMAs with or without the combination of venetoclax. So I think these patients do require maintenance. And as far as which patients would benefit the most, I think as of now, it would be the patients who have not been able to complete their intensive chemotherapy. So those patients, as well as in the post-transplant setting, equally, I think they would be benefiting the most with the maintenance.
So would you say, I mean, you mentioned that patients who are not in CR or incomplete CR,
yes,
I think in those cases, it would not be then called maintenance, because I think if you use the term maintenance, it's primarily for patients who have gone into a complete remission or are either MRD positive or negative perhaps, and then you would like them not to get into frank relapses.
Yeah, so if they are in incomplete CR, but they are not able to continue their chemotherapy further. So maybe in those patients, we might want to give them some sort of maintenance. They are not able to undergo further therapy or a transplant.
Right.
Asif and Priyanka both are there.
Oh, wonderful.
Yes, sir. Sir, I completely agree with Akansha that maintenance is probably will be benefited in the patients who would receive chemotherapy. But I think those patients who achieve a CR would benefit the most. And we have very limited options, sir. We do not have the options of other agents. We have probably to choose between midostaurin and oral azacitidine and probably venetoclax from the gray market. But among all this, oral azacitidine is one thing which excites the most. I have very bad experience with the oral, midostaurin. Even in the induction period or even during maintenance, very few people tolerate it. But oral azacitidine looks very promising to me. And I think post-chemotherapy is the one after achievement of CR, probably the best group of patients would benefit. I'm not very sure about post-transplant. We do not have much data. But again, I feel like those patients who have probably received non-myeloablative regimen probably might benefit.
Yeah. Okay. So have you had any experience of using oral azacitidine or azacitidine in any form in your patients post chemotherapy?
Yeah, yes, sir. I have had used oral azacitidine post induction chemotherapy, but I have also used it like post 2 cycles of induction and 2 cycles of consolidations and patients in MRD negativity. So, yeah.
So you had used them, just to understand, you're given them because they were MRD negative, so you don't give them if they were MRD positive?
The idea is to, sir, because these patients were high-risk patients and I was not being able to offer them a transplant. But yeah, I know this is the best not possible scenario. But again, I think we are probably learning along the way. Probably there will be a group of patients, high-risk patients who might not have a transplant. And probably we can give a much better PFS with maintenance.
Okay. Dr. Priyanka?
Yes, in my experience, that patients who are undergoing 7+3 induction, or if they are on 7+3 induction along with midostaurin, we have just continued with 3 doses of HiDAC or a post like transplant. We haven't put the patients on maintenance. But patients who are on venetoclax azacitidine, be it in a higher age group or in patients who are not able to, like their poor performance status or do not have a MAC sibling or they do not want to undergo a MUD or a haplo, in those patients, if they have achieved a complete remission, morphological remission or an MRD, we are going for oral as a maintenance. but not for the definitive, like the one we have in the trial, during the first trial, where they have put intensive chemotherapy followed by maintenance. Those who have undergone intensive chemotherapy, most of them have undergone HIDAC consolidation or a transplant post-induction. They are the ones who are eligible. We haven't put post-chemotherapy patients on maintenance. These are usually the ones on azacitidine and venetoclax who have achieved a MRD negativity or are on morphological remission.
So just to clarify, you are not using post chemotherapy, azacitidine, oral azacitidine, or any of the other drugs as maintenance if you have given them intensive chemotherapy plus minus transplant.
If a patient has undergone an intensive chemotherapy, 3 doses of HIDAC, and then patients are just put on follow-up. If in case there is a relapse, then we are again going for a second intensive chemotherapy, or if he is not suitable, then a ven or azacitidine. So therefore, we haven't put those patients on maintenance as of now. We haven't had much of experience on patients who have undergone 7+3 but could not do it with the intermediate dose RSC or a HIDAC.
Okay.
Just to add,
Yes.
currently I have one patient post-transplant whom I put on oral azacitidine maintenance post-transplant because of the traveling constraints with her, and she was not able to come to the hospital to receive her monthly maintenance for azacitidine. So I put her on oral azacitidine as a maintenance post-transplant. So she has completed around 4 cycles as of now, and she had minimal toxicity and side effects in the form of just nausea, but no major toxicities or hematological toxicities she has developed as of now.
And when did you start it? At what time point post-transplant have you started this patient?
Yes, sir. So we started it 3 months post the transplant. Once the chimerism was stabilized and counts were stable, after that I've started.
And how long are you planning to give that?
Sir, I don't know. Plan to give it for 12 cycles, but let's see how her tolerance goes. So,
right. So I think again the next question is somewhat similar. If you are asked to choose between the various molecules that are now available, say midostaurin, we have got sorafenib, azacitidine, venetoclax, what would be your ideal choice if you want to be using maintenance? Dr. Asif, if you could start.
Sir, I would choose oral azacitidine. My experience with sorafenib and midostaurin were not very good. And I have not seen many people tolerating sorafenib at the doses prescribed. And venetoclax, we have to use it along with the posaconazole, and so it is very difficult to continue for more than 6 cycles. As far as maintenance is concerned, I'll use oral azacitidine. And in the prescribed.
Sorry, please continue.
And in the intention of using it post CR, sir, I am not using it in other settings. I mean, palliative setting or any other in the frontline setting. So I'm particularly using oral azacitidine 300 milligram in the post CR, post chemotherapy.
So you would use oral azacitidine even in somebody who has got a FLT3 mutation?
Yes, sir. Right now, actually, I'm doing that because we had very difficulty in getting this patient to tolerate midostaurin for that period of time. Even during induction therapy, it becomes very difficult. So our experience were not been very good. So.
That's interesting. Dr. Akansha, Dr. Priyanka.
So for maintenance, sir, I would like to differ from the post-transplant patients have had and good tolerability to sorafenib. Obviously, the dose that we are giving, not the full dose. I don't have any experience with midostaurin, but sorafenib not had many problems. And like I said, azacitidine and other than that, the is using as a in practice maintenance post transplant. And as of now, our patients are and consolidation, not patients other than the FLT3 patients? Any kind of
Dr. Priyanka?
Sir, with FLT3 positive mutations, now we have midostaurin, even generics are available, so possibly, but one of our patients, she has been tolerating it quite well at a dose of 50 mg BD, whichever is the prescribed dose. So sometime we had some problems, but with a little reduction in the dose, again they make up and come up with the 50 mg BD. But we have very few experience, very limited experience, hardly 1 or 2 patients. Previously, sorafenib was there, but it's a very difficult molecule to continue. And regarding oral asthma, that is, I think, the most comfortable drug to have as of now on maintenance for the patients. And I agree that even for oral asthma, 300 milligram dosage, sometimes patients have a little bit of intolerance to it. Even they have some amount of cytopenias. So we reduce it as per the tolerability. But again, after a few days, they become well accustomed to the dosage of 300 mg OP.
Our sponsors must be extremely happy right now, I must say. So is there any evidence?
Because a lot of companies have now come up, so it's quite an affordable drug as of now. It was not earlier, like the patients had to visit, get it all in the IV setup.
So again, going back, so because we have now heard interesting information from some of our panelists, so it is already being used. Dr. Sadashiv, Dr. P.K. Jayachandran, do we have any evidence currently to support maintenance strategy?
Sir, there is no such thing randomized control trials. Okay, so everything is something like we don't have any proper randomizations. But what the previous discussants clearly mentioned, I think the oral azacitidine, I think, frankly speaking, most of our, at least we have started for 3 patients. All of them, they are doing very comfortable way, because initially we started with something more elderly, 60, more than 60 years. We started something this HDOC, something injectable forms, switched over to the oral side, as I said, after induction remission. They are doing very well without coming to the, because during the COVID time, without coming to the hospital also, they used to send the CBP, RFT, except some emesis. So anti-emetic should be given along with this one. Otherwise, it's a very tolerable drug. But as I said, do you have any current randomization? I don't have any answer to that one. We don't have any randomized control trial to say something, but definitely it is useful in certain categories of the population.
So regarding this, both the drugs, oral azacitidine and the midostaurin, which has been approved in the maintenance strategy pre-transplant, I think we have oral azacitidine as per the Quasar trial. Quasar trial is the one, I think it's a randomized control trial, which is proven the role of oral azacitidine, and the Ratify trial has proven the role of the oral midostaurin as a maintenance in patients who are not undergoing transplant. So I do use it. I have used it in about 5 to 6 patients in my practice as of now. I give it for 2 group of patients very commonly. More than 5 to 6 patients. Of recent, I have prescribed for about less than about 10 patients. So we use it as a bridge for transplant. In our center, we have a lot of waiting list for transplant. So I do use it as a bridge for transplant, the oral azacitidine. Previously, we used to use IV aza as a bridge to transplant. We always have about 3 to 4 months waiting list in our center. So we now are more comfortable in giving them oral aza as a maintenance. Sometimes in high risk list, we even use oral aza plus ven as a maintenance. And also for patients who are not eligible for transplant, we are using this oral aza with or without venetoclax. So as Dr. Priyanka said, a lot of patients are not tolerating 300 mg really well. So my starting dose is always 200 mg. I don't want to harm the patient because they're already in remission. So I used to start at 200 mg 14 days, or the patient is quite old, I do start at 10 days also, and then go up slowly on the doses based on the tolerance. I don't want to harm them. This is how I practice about 5 to 6 odd patients in ineligible category, and about 3 to 4 odd patients in bridge for transplant. I have used this drug. Pretty comfortable drug. I don't have any issues with this. As Dr. Sadashiv said, emesis is an issue. please, we have to prescribe MSET as long as the patient is going to take the azacitidine. Once they are given the ondansetron, they are very comfortably taking it with Aza.
Ravas
Thank you.
has also joined.
Oh, okay. Dr. Sahu has joined?
Yes.
Yes, sir. Yes,
Ranjit, would you like to take this? We have, yeah, okay.
yes, sir. So I will answer it in a different fashion. I mean, there are actually no good quality studies to refute the use of maintenance in acute myeloid leukemia. So the studies that had been conducted in the past, they were not robust enough to refute the contention for maintenance, which is successfully used in other acute leukemia like ALL. So conceptually speaking, usage of maintenance in acute leukemia, it has a role, and we could borrow it from ALL. And as told by the previous previous panelist, quasi study is one study where there was a role been crafted to be used in AML patients who are not eligible to take for the consolidation therapy. Now, when you look into useful randomized control studies like Dono 60 versus Dono 90 in older patients, Dono 90 had produced an EFS over Dono 60. Now, the question is, only 20 to 30% of these patients who were treated in the randomized phase 3 study could get some additional chemotherapy post this thing. So if you look into whether we have a role for maintenance strategy in some sort of patient, yes. Those patients who are not eligible to take further chemotherapy after 3 and 7 induction, and many of those will be, they are not very eligible to take 3 and 7 induction, I would say. But whatever patient they have undergone the 3 and 7 induction, not in a good general condition on post-ostomy 3 and 7 induction, not due for other consolidation, which is standard, at least 12 gram per meter square. So these are the patients where maintenance strategy is to be used. Now the thing is, we had been doing this practice offhand, like those patients who have CR but with incomplete CBC recovery, they are not good candidates to be taken for high dose RSC based consolidation. Now these are the clear-cut patients where a maintenance strategy using hypomethylating agent, especially oral over subcutaneous or IV azacitidine, should be preferred. The basis is, the evidence is more for the oral azacitidine, not so for subcutaneous or IV azacitidine in this scenario. But as we understand, oral AZA and IV AZA, when you look into the data of AZA-VEN versus AZA, those patients with AZA and placebo, those who have achieved a complete remission and they were continued on AZA maintenance, the duration of remission is close to 12 months. And in this study, that is quasi study, those patients who have achieved a complete remission or complete remission with incomplete recovery after 3 and 7, the duration of complete remission is close to 12 months. So I personally do not feel that oral AZA is any different than usage of subcutaneous azacitidine at a dose of 75 milligram per meter square for 7 days. So this is a clear-cut situation where maintenance is to be used in AML patients, and HIDAC might not be very preferable. Now, the third issue is these are evidence-based, and now I would talk about what had happened over the last 3 years. When this COVID pandemic was there, the patient could not even visit the hospital and all these things. This patient had to be managed over a teleconsult. Now, this was the time when post 3 and 7, many of these patients have received azacitidine as maintenance. And once this oral AZA was available, this was offhand experiences. And I could tell you, in most of the patients, this sort of strategies could maintain the complete remission. And some other doctors have also told about using it as a bridge to transplant. I also agree that even in those patients who are transplant candidates, these medications can actually bridge them well. So evidence-wise, there are not many indications, but when it comes to clinical practice, there could be few.
Thank you for that insight, Dr. Sahu. This goes on to Dr. Chandrakala, Dr. Dharma. I believe Dr. Samir and Ashish are not there here. What outcome measures would you like a clinical trial on maintenance therapy in AML to answer? And what would be your ideal maintenance therapy?
Ravas, Ashish is there.
Oh, great.
Yes, Professor.
Ashish. Yes, Ashish, you may.
No. You asked for Dr. Chandrakala. I
Yeah.
just.
Oh, no. I
Yes.
didn't realize you're there, Ashish. I didn't see you.
Okay. Yeah. Thank you for the question. So, what outcome measures? Very optimistic will be the overall survival benefit, or the we get a cure from the AML, like what we get the benefit from relapse-free survival, like ALL. So that will be the optimistic of in getting a maintenance therapy or statistical analysis of the clinical trial we would like to have. So other thing it's like is which patient should be given. First of all, we have only in elderly patients the trial has shown the CASA trial, but we are all giving for the even the younger patients also the which patients which benefit, or whether MRD positive or MRD negative, or whether the high risk patients are the standard risk patients. When you see the analysis post trial analysis from the CASA trial, it's the NPM1 patients which is beneficial. Actually, they benefited more than the FLT3, and MRD negative patients benefited more than the MRD positive patients. So these are the post trial analysis which is coming up. So in the future trials, if we answer all these questions, which patients and are the ideal candidates like MRD or a standard risk or the high risk, that will be the beneficial to stand practice in the clinical practice. We will be clear to whom to give maintenance therapy.
Wonderful. Ashish?
Yeah. So I think I'll second that thought in terms of the outcome basis. The primary thing that we are looking at from both the aspects, one is to improve the survival even in those who are MRD negative, because the survival for them is also not to the level of 100%. So we are looking at two subgroups, which are MRD positive versus MRD negative, and then trying to see can we improve upon that outcome. More so in those who are MRD negative after the intensive chemotherapy. That is one. Second, we are trying to look at even in those who are on a low dose maintenance and not a candidate for aggressive therapy, which other drug can maintain it much longer and potentially converting them from MRD positive to MRD negative. So ideal maintenance therapy from my side is something which is similar on the midostaurin, oral midostaurin form. It should be oral, it should be available and easily administrable for as a maintenance, preferably not having major side effects, easy to handle, and at the same time providing that benefit within a short time. It's merely the initial response should come faster, and then it should sustain. These are the primary points I'm looking at from the ideal maintenance. As of now, we have only one drug which has been proven in that fashion. The injectable form, whatever 3 trials that have been done earlier, have not proved to be providing a survival benefit. That was the limitation for all the previous trials that were done. One from UK, one is ECOG study. So that was a limitation. I think we have got some answers from this trial. At least it has shown a way that yes, the overall survival can also improve. And that's my take on the ideal maintenance.
Yeah, so that's wonderful. Like, so overall survival cure, which patients to give, whether to give it in high risk or standard risk, whether to give it in somebody who's MRD positive or negative, which molecular subgroups to give. And if it is MRD positive to begin with, Ashish has rightly put it as, whether it can convert it from MRD positive to negative, and whatever the effects or side effects that should be seen earlier on, so that, it doesn't just prolong and it should be easily available. Dr. Dharma?
So, Pravas, I'll go with a little comment and then I'll take this question. So
yes.
The question of maintenance treatment in AML and this maintenance, we borrowed the idea from the other CML or ALL and other. So when you look at the AML when they're relapsing and the from last few days I was reviewing something for like NGS based MRD. So AML is not like ALL, and there are so many clones which are present at the diagnosis, at the consolidation, transplant, and post-transplant. So the new clone comes, and some other clone, dormant clone, or chip, clonal hematopoiesis of insignificant, they start again mutating, and then relapse is happening. So I really don't know whether the midostaurin or azacitidine is the answer, because what target we are doing, what MRD we are talking, whether the flow based MRD are just like a blast. It's not a one blast. So I really don't know, and in practice also very difficult to practice what the maintenance you give. Sorafenib flow FLT3 AML you have started, and now midostaurin is there. So FLT3 AML, yes, you have one target, but other than really not convinced to use the maintenance in AML, because the allele, whatever you are getting at the time of the post transplant and maintenance and post, even the longitudinal you serial monitoring you do. So really not sure whether this is really helping or not helping. Second thing, the question is like, bridging is the different. The maintenance you do when you have completed the induction, consolidation, and maintenance. So it's bridging because of COVID, because of something, transplant waiting. That is different strategy. So that is not a maintenance treatment. So I am not sure, what ideal maintenance therapy should be there in AML. When you look at the gene signature, NGS, so many, the DNMT, TAT2, IDH. So whether if I'm putting an IDH mutant clone is there and I'm giving azacitidine, whether it's helping or not, really no idea, because AML is not a one clone.
Yeah, thank you, Dharma. Thanks for bringing that out, and that's exactly my thoughts too. Like unlike CML, where we have just one target, Philadelphia positive, here we don't have one target, and if we are doing one, we are going to come up with another. So yes, even I don't know the answer to it.
If you look at this, there's two beautiful papers in the blood cancer, the NGS-based MRD monitoring for AML and post-transplantation, and I'm going to speak on the ISBMT. So, there is clonal expansion, the chip mutation, the DAT mutation. So they again expand after transplant even. So the new mutation is coming. So what we are going to do with just azacitidine, or whether you are not given azacitidine, they would have done the same. The morphological CR is not the CR where you can start maintenance treatment.
Correct. Thank you, Dharma.
Sir, one comment, sir. Shall I?
Yes.
Yeah. So I think as Dr. Dharma Chaudhary said, is very rightly said, it's that any cancer is a heterogeneous. So for example, if you take the something solid tumors, if you do something NGS, we'll find more than 100 targets, 100 abnormalities. So all abnormalities may not be the dominant clone. So problem here is cancer itself is heterogeneous. So in that setup, I think we can't say something like, we can't go away from that one. Once we are using some highly sensitive test like NGS, we'll find many something abnormalities. But which is the dominant one? I think we have to see that one. And ultimately, but what he has really raised a very good point for the practical point of view. But still, there is some one dominant clone may be there. With the dominant clone, I think we have to, once we have the target, at least we have to hit the target. That is the goal of therapy. So very nice point, Dr. Dharma.
I just comment here.
Yes.
These people have followed this, the allele, whatever is gonna come, the mutation, and the same the clone, the later relapse. So it's not like in AML, if you have few clone and allele ratio is like more than 20%, it's going up. So what we call say VAF. Those are the clone actually the culprit for relapse. So in that clone, whether this azacitidine is going to work, because if you have TAT2 and IDH and it's full-blown mutant, so whether it's AJA or a blanket midostaurin for everybody is going to work. I doubt these patients would have done better without even this.
So only one drug is not a panacea for everything. Actually, definitely, the only one drug will not cure the cancers. Yeah, definitely. What you said, even if you target one target, the another target also will come out of this one. For example, same thing in solid tumors will express just that we have seen like lung cancer. We'll treat with one what you can say target. Within 1 year, 2 years, again they will develop resistance, or another clone will come up. The same way, I think what you said is the right point. I think you have raised very good point. We should keep in mind that one, it is not a panacea. The oral azacitidine is not something wonderful drug to treat or to cure the cancers or AMLs. So definitely, it's a very good point. Thank you, sir.
Since there are clonal evolution going on, we are not sure whether maintenance is going to be helpful in AML or not. Just a quick question to the panel, since Dharma raised that question.
Ranjit wants to add something.
Yes, sir. I think just a bit about about this, Ranjit. Everyone. So for each question, we'll just stick to the panel person, and we have a last point where we can. Otherwise, we'll keep on going. So just a quick question, since Dharma had raised that. How many of us are actually looking into the ratios? I mean, are we using the ratios to actually decide on our treatment, or just positive or negative? Dharma, I think, are you doing that?
Yeah, we look at the ratio when we starting the midostaurin in the induction therapy. So the post-transplant sorafenib maintenance, this is where whomsoever we use, and some few odd patient without even looking that as if what was the ratio before the transplant. So those any FLT3 positive, we are just giving maintenance for some of the patient, very high risk. Otherwise, we are not using.
Ranjit, you wanted to say something.
So about this question, it is irrespective of the allelic burden, sir. And when you look into the technique of measuring the allele burden, I mean, there are only few studies that have recapitulated the same results in other centers. So if a patient, I mean, in clinical practice, if a patient it is guided by the presenting white blood cell count and FLT3 ITD mutation. If the presenting WBC is in excess of 100,000 and the allelic burden is coming as low, I don't feel that is the right way to conclude it. They are actually high risk AMLs, and all the labs that are doing this test, they are not validated according to the standard lab. So it is not a very standardized test. But having the mutation, yes or no, it is there. You could identify it. But are you accurately measuring the allelic burden? It remains to be questioned, sir. So in clinical practice, all these patients, we treat with FLT3 inhibitor.
Right. I agree. We don't have validated lab tests. So if you look at the approvals, it is for FDA approved test. What is your experience on using sorafenib and FLT3 AML post-transplant, since that is the only one that has been approved? Or have you considered any other kind of maintenance? The question remains to the same panel.
So we have used, again, I'm saying the low dose they tolerate, the higher dose they don't tolerate. The palmoplantar, dysesthesia is really, really problem. And many people get the QT prolongation, and so the lower dose they can tolerate.
Okay. Ashish?
We have not used.
Right. And Dr. Chandrakar, would you like to add something to that?
No, actually, the same question what the Dr. Dharma was telling, the midostaurin, if you see again the post analysis from the Ratify also, it has not shown benefit after 12 months. This shows that the clonal evolution, no? So everything is up to 12 months, actually. 8 to 12 months, you see the survival. At the relapse-free survival, then the benefit is lost even in the maintenance in AML. So this itself shows a scientific background that the allelic burden is changing. So this, actually, we need to find the agent. We don't have an agent. It's just a maybe initial step, actually. We are not even talking about the maintenance in AML till now. So this is the first time we are talking. We still a long way to go. So that's a point to be noted always. We have to think that allelic burden and allelic change, clonal evolution.
So actually, again, those patients would have survived for 1 month in Rectify, 1 year in Rectify trial without giving this.
So I'll have a point to make in that. I think the poor midostaurin is being bashed up here, right, left, and center here. So I think I'll just add that is that trial never claimed it is for cure. It is mainly already it was known that these patients are going to relapse. They were unable to tolerate anything else. The idea was just to prolong the survival. So we are starting with that idea just to prolong survival. We have not yet reached the area where we can at least cure. So when we look at post-transplant setting and all, then it is different. Then we are looking at the cure. So the thing we are looking at is, even in those who are not eligible for any of these, how do we prolong the survival? So one trial at least has shown something. So yes, it is good. Now we have to take it from there and then identify
Yeah.
newer drugs.
Yeah,
Yes,
yeah.
yes.
We are just taking our first baby steps in this.
Yes, yes,
journey.
yeah, that's what actually. Some who did not go for transplant, especially in our country, many patients doesn't go for transplant, don't go for transplant. So that's where we have to think of these drugs, which can at least relapse-free survival be better.
So this is the SORMEN trial. This was given for 24 months post-transplant in patients without grade 2 or above GVHD till progression or intolerance. No MRD testing was required post-transplant, and no FLT3 inhibitors were given during the induction in the majority of the cases. 63% of these patients were not in CHR or MR. So with that, if you look at the 24-month relapse-free survival, so 15% of the patients on sorafenib had relapsed at 2 years compared to nearly 47% for the placebo. So that was pretty good. The median relapse-free survival was not reached by the 40 months. Median relapse-free survival was 30.9 months for the placebo group. And the baseline NPM mutation had a positive effect. So those people did better. And in this particular trial, they did not find any effect of the FLT3 ratio. Overall survival again was better with sorafenib as compared to placebo. Again, the incidence of many, I think 22% of these patients had toxicity, and so they had to be discontinued versus 5% in the placebo group. And among the kind of patients that seem to do well, if you look here, was that these are the patients who did well. Most who had a pre-transplant MRD negative or post-transplant MRD positive were the ones who did fine. If you look at this placebo group, 5 out of 12 relapses, even when they were MRD negative. So these are high-risk cases who are FLT3 positive. So these are high-risk cases, and half of them would be relapsing after a transplant, whether if you're not going to be giving anything else. So in this group of patients, definitely you should add sorafenib. And those reductions were there in 50% of the cases, but this did not seem to affect the outcome. The main limitation has been a poor accrual, and that has been primarily because of the frequent off-label sorafenib use. I'm going to come to that later when we are going to talk about the other oral drugs like oral azacitidine. How long to give maintenance? In the SORMEN trial, it was 24 months or till progression or intolerance. There was the only other phase 3 trial from China where they used it for 180 days and still they showed some benefit. The 2-year relapse rate and overall survival of 11.9% and 82.1% in sorafenib group compared to 31.6 and 68% respectively in the non-maintenance group. Now, if you look at the non-maintenance group, the relapse 31% was actually quite good. So they seem to have, even in the in their group of patients, these people seem to do better. And midostaurin, that has been given for 12 months in 28 day cycles. So these are the current data. Midostaurin has been added to chemotherapy and continued single maintenance in this German-Austrian AML study group. Again, this was not exactly something to find out whether, like Ashish pointed out, that this is not to see whether it is overall survival or relapse-free survival. This is mostly a hypothesis-generating study where they compared it with historical controls. The median time of receiving maintenance was just 9 months after LOHCT and 10.5 months after HIDAC. Premature termination primarily because of non-relapse causes, and most of these were because of the gastrointestinal toxicity that they saw with addition of midostaurin. This was again, they found that the event-free survival in this group of patients in the less than 60-year group and more than 60-year age group. So there seemed to be some trend towards a better event-free survival in patients who had received midostaurin. Again, this was the RADIUS trial, which again was a signal finding study. So this was not powered for any statistical significance. They just wanted to see if it is worthwhile going into a proper clinical trial. And in these group of patients, again, there appeared to be a trend towards a better relapse-free survival and an overall survival in those patients who are receiving midostaurin combined with the standard of care. This was the RATIFY trial. Now, in this particular trial, even though they did give midostaurin in maintenance, the study itself was not powered to evaluate the effect of midostaurin on the final outcomes. That is why we did not discuss that data. Other FLT3 inhibitors, we have got giltertinib, which is now currently, I think they have already completed the accrual. We still do not have the data from this. We also have a dose-finding study for lenalidomide. So lenalidomide has been used in multiple myeloma. So in this particular study, they found that you can use about 10 to 15 milligram of lenalidomide, just like in myeloma. We still don't have any data. And coming to azacitidine, despite this particular study, which gave 5-azacitidine as a maintenance, which there was no significant difference in terms of survival or relapse-free survival. There was a recent meta-analysis where they looked at 5,599 studies, and then they boiled down to 21 studies, which had 809 patients, of which hypomethylating agents were given in 10 studies with azacitidine in 443 patients, of which one was a phase 3 study. They found that the patients who received midostaurin as the hypomethylating agents as a kind of a maintenance, the 2-year overall survival of 65.7%, 2-year relapse-free survival of 60.9%, favoring a maintenance over a no maintenance kind of a regimen. Similarly, in those patients who had undergone a transplant, they did not have any significant adverse outcome in terms of acute GVHD, chronic GVHD, or any GVHD of any grade or severity. There are these several trials which are now undergoing on hypomethylating agent-based maintenance therapies. We have got a phase 3 trial on oral azacitidine versus placebo. We have got with decitabine and bortezomib. We have got venetoclax with azacitidine again, and we have got venetoclax with azacitidine here as a phase 3 trial. That would be interesting. We know about the toxicities that venetoclax has, and this would be interesting, and this data would be interesting. So coming to the final slides, have we achieved any kind of clinical equipoise? Now, if equipoise, I don't think we have. I mean, if we go by what is happening clinically, most of our people are already convinced that yes, it is useful. So I don't think we are going to be getting any worthwhile clinical trials where we are going to be adding oral azacitidine or any of the agents and get sufficient number of patients on that particular trial. You can see what happened on the sorafenib with just 80 patients on each arm, because most of the patients were already receiving sorafenib as off-label, off-clinical trial. So have we achieved, do we actually have any clinical equipoise, or are we clinically ambivalent? What are your thoughts on the applicability of maintenance and any speculations for the future?
So my take on this is mainly, as of now, I'm reasonably convinced for those who are not eligible for aggressive chemotherapy. So after the good control of the disease, if we have to choose anything and they cannot go for a transplant, I'm quite open to using it because the risk of relapses are very high. Obviously, it is not primarily aimed at cure, but potentially aimed at the cure, assuming that there might be possibly some spurters whenever there is a clonal expansion. Possibly there's going to be a prevention of that, or maybe a control over it and providing a longer control compared to what it can be otherwise. So yes, applicability is there. I am not yet convinced about its use in those with the aggressive therapy, bone marrow transplant, unless I get more robust data in terms of its use for a better cure rates that I have found. Yes, for the future, I actually would bet on the FLT3 molecules. I would think they are showing a way in terms of what we can use further. So yes, FLT3 inhibitors, newer FLT3 inhibitors will definitely be something that we can look forward to. IDH inhibitors, yes, one of those the molecules is one of the things that we can look out for in terms of having a response there. But that is from the cure point of view, in case we are using after a good control and trying to achieve MRD negativity in those situations there. But I mean, the use for that is subject to the confirmation on the properly designed trial. Whatever we apply as a theory here has to be ratified then.
That's where I think we are not going to have one, because almost everybody is already using it.
What is my thought was, probably I'll not name maintenance, and for those who are elderly patient who are getting the hypomethylating agent, and this continuation of the therapy. So, like, there's indefinite therapy with HMA till they relapse. So probably that is the scope. And yes, as Ashish said, the particularly target specific molecule, whether newer your FLT3 inhibitor or IDH inhibitor, so that kind of will be given as a maintenance for those specific subset of patient. But blanket one drug for all as a maintenance after achieving MRD negative like ALL, probably the future will tell.
Yeah. So drugs for if you have a target, give the target-oriented drug. If not, then give one of the blanket drugs.
Yeah. So I also feel the same thing what the previous speakers also told. The applicability is definitely in patients who cannot tolerate the high DAC, or if they can tolerate maybe one cycle of high DAC. Those are the patients, elderly patients, or even sometimes 3+7 only if they cannot tolerate. FLT3 patients is not going for transplant. We have started in 2 patients. One was FLT3 who had sepsis in induction, and they were not planning to go for transplant. So we started them in the cytidine. So those are the patients. Sometimes it is still applicability is there. We do. It's only to delay the relapse. So we need to have a targeted therapy. So we need to wait for the future. A lot of trials are showing a good response with IDH1, IDH2 inhibitors. So those are the maybe the targeted therapy based, maybe used in AML as a maintenance.
Right. So that's all from my side. And if any of the panelists have got any other final questions and answers, we can take it. We have got about 3 or 4 minutes remaining. If not, sir, Professor Agarwal, I think it's over to you then.
Thank you so much, Dr. Pravas Misra, for conducting this panel discussion on maintenance therapy on AML. As we have a couple of minutes, and as Dr. Davar is with us, of course, he's there for the next session, but can I just request Dr. Davar to chip in with his just few comments for 2-3 minutes on maintenance therapy in AML?
Yeah, sure. Hi, everybody. Hello, good to speak to you all and see you all on video. So for maintenance, it's very big, kind of open-ended area, and I think we're splitting it more into MRD versus true maintenance-based approaches. The only drug, of course, approved in the United States right now for maintenance is the CC486 oral azacitidine. And, it's a bit difficult in some cases to find the ideal population to use that because it's approved in people 50 to 70 years of age who had received intensive induction chemotherapy and then could not go to transplant. I think that's the key factor. And, today we usually make that decision very early on when we see the patient. If I see somebody who's 67, 68 years old, and I do not think he's a transplant candidate, then we're usually leaning towards HMA-Ven therapy for that person early on. And so then the oral azacitidine option is not really at play. Yes, we have a few patients where we give them intensive induction. They look very fit. They get really, really sick and fall apart during induction, and then I cannot transplant. This is a minority. I would say maybe 10% or less where we could consider it. And availability of donors is at least, here, and I think there as well, not a problem with haplotransplant and even cord transplant. So that niche population of people who got intensive induction, were fit, and now cannot go to transplant, at least we're not seeing. And part of that is probably because HMA-Ven has started kind of moving down the age. We're using it at 70, even 65 to 70 with borderline fitness, and then of course adding other agents to it. I think post-transplant maintenance, there's been much more uptake and enthusiasm, especially with the FLT3 inhibitors. Sorafenib, as you all know, has shown 2 randomized phase 2 studies with positive EFS and OS, one from Germany and one from China. And we have been using FLT3 maintenance at MD Anderson and had published previously our experience. So we continue to use that. I think gilteritinib will be even better maintenance. There is a large BMT-CTN phase 3 study of gilteritinib versus placebo that's going to complete enrollment this year, and it hopefully will be positive and show us more data. In our experience, we've probably treated 30-40 people with gilteritinib maintenance post-transplant. It is very, very well tolerated, much easier than sorafenib or even midostaurin. So I think gilteritinib or maybe quizartinib in the future will kind of emerge as maintenance options of choice. And then IDH inhibitors, I agree, whether they're alone or in combination with AZA are options. So So I think today, and then the biggest maintenance that we're really looking forward to seeing the data is aza-venetoclax maintenance, because there are two studies. One is post-transplant with aza-venetoclax randomized phase 3, and one is post-induction consolidation. And I think there you will see a bigger difference. So in the future, FLT3, I think definitely maintenance, post-transplant, post-induction consolidation, maybe single agent, maybe in combo. IDH, yes, I think those definitely we're using. Aza-venetoclax may be, but we'll have to really manage myelosuppression toxicity. Post-transplant has been our experience. It can be done, and we'll have to see the benefit. And then immunotherapies, I think, will eventually emerge in the next 5 to 7 years, whether these are NK cells, CD47, and these are much less myelosuppressive, often better tolerated, and may work specifically in low MRD maintenance settings. So I think, yeah, this is where we're looking.
Thank you so much, Naval, for adding your experience to this wonderful 1-hour panel discussion that we have had. On behalf of Mumbai Hematology Group, Pravas Mishra and all the panelists, thank you for this very, very wonderful session. And now we move on to the last part of this marathon session today. The next 1 hour is, we have the program which is supported by Astellas, and I request Astellas to take over, please.
Thank you so much, Agarwal sir, and good evening to all the attendees. So I am Dr. Kritat Naman Singh from the medical team of Astellas Pharmaceuticals, and I welcome all for the symposium. So acute myeloid leukemia is one of the commonest adult hematological malignancies, as we know, and many of the cases, they relapse or are refractory in nature. In addition, mutations like FLT3 mutations have been found to be associated with poor prognosis. Hematologists face many challenges in managing FLT3 positive relapse refractory AML, and hence it would definitely be important to throw some light on this particular topic. So to discuss and talk more on this evolving treatment landscape for relapse refractory FLT3 positive AML, we have two leading experts from India and US respectively in the field of hemato-oncology. So as a chairperson and expert for today, we have Dr. M.B. Agarwal sir, and sir needs not much of an introduction, and sure everyone attending this symposium have great idea about his experience and expertise. So sir has more than 3 decades of experience in managing leukemia and hematological malignancies. And after completing his MD from KEM Hospital, Mumbai, he also underwent training in the UCH in London and the Royal Free Hospital, London. Apart from the number of professional academic achievements he has, Agarwal sir is also the president of Mumbai Hematology Group, as we know. So I thank you, Agarwal sir, for presiding as the chairperson for this particular symposium. And along with him, we have with us the speaker and the expert, Dr. Naval Dawar, who is currently an associate professor in the Department of Leukemia at MD Anderson Cancer Center, Texas. He has many years of experience in managing hematological malignancies at one of the most premier institutes in the world. And he's also American board certified in oncology, hematology, and as well as internal medicine. Besides, Dr. Dawar has great experience as a clinical investigator with focus on molecular and immune therapies in AML, and is the principal investigator currently for more than 25 institutional, national, as well as international trials. He has also published more than 300 peer-reviewed manuscripts so far, and is on the editorial board of numerous hematology specific journals. So I also welcome Dr. Dawar and thank you for being a part of the symposium as a speaker. Also, I would urge the delegates to please put your questions related to this topic in the chat box so that the experts can take them during the discussion time after the speaker session. And now, without wasting much time, I would like to call upon Agarwal sir to please take the proceedings further and give a brief introduction on the topic. Thank you so much.
Thank you, Dr. Kritat. So we have this program which is supported by Astellas for next an hour or so. The title of this session is Evolving Treatment Landscape in the Management of Relapse Refractory FLT3 Positive Acute Myeloblastic Leukemia. So emphasis will be on that part of acute myeloblastic leukemia. Just a couple of slides to set the ball rolling. The community that is present over here today listening to us are about 300 plus delegates from 14 to 15 countries. Most of them are senior hematologists, medical oncologists, but half of them are students. So there are some basics here that FLT3 is one of the common mutation in acute myeloblastic leukemia. And of course, there are other mutations which are also equally common. And this is just a slide telling you that the FLT3 story began almost in 1990, that is 30 years ago. And on the right half of this picture, we have various agents which have become available for the treatment of this entity. And this just tells you that the present recommendations are that in the front line, you have approval for midostaurin with chemotherapy for both ITD and TKD. Post-transplant maintenance, the approval is for sorafenib, and for relapse refractory, it is gilteritinib. So you diagnose a patient, you do the FLT3 testing, you find it to be positive, you do the induction therapy, and the patient may be refractory, or you go ahead, patient relapses, and you do the FLT3 testing, and it's positive. And then this is the patient who is relapse refractory, which we'll be requesting Dr. Nawal to discuss. And of course, the compound that we are going to concentrate on is gilteritinib. Dr. Nawal doesn't require introduction to Indian community at all. He has been more than a guest speaker, a friend, a colleague. He's visited India a number of times. He hails from India, and it has been that we've tried our best to get him almost every year, except the last 2 years because of the pandemic, we couldn't get him, but he has obliged us by giving large number of webinars. I've lost the count. I think we've troubled him every 3 months, 4 months to talk to us, and he's always added so much of information to the previous talk, as it has been a new subject altogether. Again, he has been introduced, but I am going to complete the formalities. He's associate professor, director of the Leukemia Research Alliance program in the Department of Leukemia at MD Anderson. He's a clinical investigator with a focus on molecular and immunotherapies in AML and other myeloid diseases. He's principal investigator of over 25 ongoing institutional, national, and international clinical trials for these diseases. These trials focus on developing a personalized therapy approach by targeting specific mutations or immune pathways expressed by patients of AML, evaluating novel combinations of targeted immune and cytotoxic agents, and identifying and overcoming mechanism of resistance. It's published over 260, and this may be a little obsolete figure, peer-reviewed research articles. He's on the editorial board of numerous hematological journals. He's a co-director of the MD Anderson Heme Onc Fellowship Leukemia Rotation, and he mentors numerous fellows and junior faculty. Before I invite him, I must say that he is an extremely approachable person. Any patient, any difficulty from anybody of you, just put a mail to him and he's there to help you out. So now I invite him to deliver his lecture on evolving treatment landscape in the management of relapse refractory FLT3 positive acute myeloblastic leukemia. Over to Naval.
Thank you. Thank you very much, Dr. Agarwal, for the very glowing introduction. And always my pleasure, actually, to speak to all our friends and colleagues. As you said, I grew up in India. I went to Grant Medical College, and my mom and dad are still in India, and I come frequently, and I would love to come again, hopefully in the near future as the COVID situation calms down. And as you said, very happy to help via email, phone call, for any patient questions, simple questions, difficult questions, whatever it may be. So pleasure today to speak about FLT3 based therapies. Let me see here if I'm able to share. It's not letting me share the screen. Okay. It's weird. Not sure why it's not letting me share. If the Astellas team have the deck by any chance and can pull it up, I can.
Yeah, sure. I'll just share the screen. Yeah.
Yeah, I don't
I'll
know
do
why.
that from my.
Okay, thank you very much. Yeah. And then I can just say next, or you want me to take control of this screen?
Yeah, you can just share next. I'll just stay this. No problem.
Okay, perfect. All right, so I'll be speaking. Thank you very much. Yeah, that's, I don't know why It's giving me some weird password requirement today. But yeah, so I'm going to be speaking on FLT3 mutated AML, which is a topic of great interest personally to me. After Dr. Jorge Cortez left about 4 or 5 years ago, I have taken over leadership of most of our FLT3 trials at MD Anderson, and it's a very exciting area, the FLT3, the IDH, and hopefully in the future, the MLL, NPM1 menin-targeted therapies. And so I'll talk about what's currently available because as Dr. Agarwal outlined, there are medical students, fellows, so I'm going to go over some of the basics, and then we'll go into what I think is going to be more exciting in the next 3 to 5 years, focusing predominantly on combination and sequential approaches, as well as mechanisms of resistance. Next slide, please. These are my research funding and consulting disclosures at MD Anderson. Next slide, please. And this is a disclaimer. So as Dr. Agarwal mentioned, I will highlight this symposium is sponsored by Astellas. The slide deck is from me, and all of the information and data here is my opinion on how to approach FLT3 mutation and FLT3 testing. And then you can read through the rest of the disclaimers. Next slide, please. Okay, so I think first of all, to start with, in AML, there has been a lot of therapeutic progress. We all acknowledge that in the last 5 years, 9 drugs approved, many in the pipeline, hopefully will keep going. And, we're starting to compare AML to myeloma as the next major hematological malignancy with multiple breakthroughs. And we also have to realize that this did not all happen in the last 5 years. In fact, for 20 years before that, huge efforts had been started by multiple groups in the United States, in Germany, in UK, to understand the genomics and the molecular structure of AML. And that's really what led to a lot of the breakthroughs and eventual approvals 15, 20 years later. And this, you see, is now reflected in the ELN 2017 and a more recent ELN update as well, where now molecular mutation testing is routinely recommended in addition to cytogenetics. So historically, we always check cytogenetics for binding factor AML, APL, adverse cyto deletion 5, deletion 7, deletion 17, inversion 3. But now we also see in the standard NCCN and ELN categories, we are recommending for all patients to check at baseline NPM1, FLT3, IDH, TP53, RUNX1, and ASXL1, at least these. Of course, if there is ability to get a broader genomic panel, as we do at Anderson or some of the big universities at America and Europe are able to do, and probably in India as well now, that's great. But at least these 6 are critical for prognosis, for transplant decision-making, and most importantly, potentially for frontline therapy, as in the case of FLT3, and maybe in the future for IDH and NPM1. Next slide, please. So the other thing that I think it's really important to note is that even though karyotype is the single most important predictive factor, which I think still remains true to some extent, although there have been some papers, including one from the WashU group from Dr. DeBershon and colleagues in New England Journal last year, which I would highly recommend to look up, where they used whole exome sequencing, and they actually claimed and were able to show that just using whole exome sequencing, they are able to adequately stratify AML into favorable, intermediate, adverse at a much better differentiation and prognostication than using traditional cytogenetics, FISH, NGS. And I think we will move there as these techniques become cheaper and more accessible, whole exome, even whole genome sequencing. But I would say today, yes, the most impact that we can identify is still based on cytogenetics. Next slide, please. And then it's important to note that within these different cytogenetic subsets, there are other mutations that can play an important role. One of the things about FLT3 that I really want to highlight, and I get a lot of emails from both US and ex-US say, I have a 50-year-old with a FLT3 mutation. What do you recommend? Is this high risk, low risk? And so the point I'm making here is really I cannot answer that question because FLT3 does not stand on its own. There are 2 important things, minimum, that I would like to know, or any of us would like to know. One is the FLT3 allelic ratio, or what we call allelic burden. Is it high? Is it intermediate, low? And the second is the co-occurrence of at least NPM1. That's kind of a simplistic view, but there are other mutations, but at least those 2, because if you have a NPM1 mutated, FLT3 low, then you can actually still be in the favorable risk group. On the other hand, if you have a NPM1 wild type, FLT3 high, you can be all the way in the poor risk. And then if you have an NPM1 mutated with FLT3 low, you could be intermediate. So FLT3 mutation patient could be in any of the prognostic group. So what really is important is to know the allelic burden, NPM1, and potentially other co-mutations in the future, like WT1 and others that are still in research, but definitely the NPM1 mutation status is important. Next slide, please. So here we see that, some of the data looking at FLT3 mutations and their association with prognosis and the different ways of checking for FLT3 mutation. And this is really important because I think FLT3 mutational testing is critical to, selecting frontline FLT3 inhibitors, identifying the appropriate ELN and CCN score, and then of course the decision for transplant to some extent. And these are some of the different technologies. At MD Anderson, we usually use PCR as well as NGS-based FLT3 approaches. And you can see with the NGS approaches, the time is very variable. That 3-day probably comes from some of the centers like ours and some centers in Germany, as well as now in UK that have optimized testing. And we actually do get our NGS result in 3 to 5 days. But even in the US, most academic centers, we had a discussion actually just last week on this through the NCCN, are still taking between 12 to 14 days. And these are large academic centers, many of them, Sloan Kettering, Dana-Farber. So there is an effort to tighten and centralize rapid NGS testing. I actually think Germany has done this in a national scale in a very good way, and others are trying to do it. But what some of the other centers are doing is doing a separate FLT3 PCR, because at this point, that is the most actionable and important mutation to add a FLT3 inhibitor to induction. And here you see the leukostrad. There's others as well that are out there. We have our own PCR at MD Anderson, and these usually do come back in 2 to 3 days. So for example, at Sloan Kettering, Dana-Farber, they send a PCR out, they get the result in 3 days, and then they also send in parallel their brother NGS that comes 2 weeks later, but they do not wait on that for treatment. They use that for subsequent prognostication, transplant decisions, research, salvage therapies. Next slide, please. So here you look at the differences between PCR and NGS, different methodologies. You don't need to go into the details, but PCR basically can target one gene. If done appropriately, PCR can actually go to higher sensitivities. These are using modalities called digital droplet PCR beyond the traditional capillary electrophoresis PCR. And especially for MRD, PCR is becoming the modality of choice, especially for NPM1 and FLT3 MRD assessment, where we can go down to 10 raised to minus 5 sensitivity with PCR compared to only 10 raised to minus 3 to 10 raised to minus 4 with flow cytometry. NGS, on the other hand, has the advantage of being broad, and you can look at multiple mutations at one time. You can have 80, 100, 300 different genes. Usually, most standard NGS panels do not have a sensitivity below 1%. There are now some error-corrected NGS sequencing that can go down to 0.1, claiming maybe 0.01. But still, I would say for MRD testing, both in large studies as well as with the US FDA, PCR is the only one that has really been accepted as a potential endpoint. And that's kind of what we have used for our FLT3 for MRD testing. Next slide, please. So now kind of moving more towards the therapeutics of AML, which is my kind of main area of focus. I've shown this slide before here at other meetings with Dr. Agarwal and colleagues at India. And you see every time we're happy to show that we can add more drugs to that bar. So we have now 9 drugs approved in the last 5 years from 2017 onward, including targeted therapies, 4 of them, 2 FLT3 inhibitors, midostaurin, gilteritinib, I'll talk about more, and then IDH inhibitors, enasidenib, ivosidenib. Of course, one of the drugs that is a critical player in all of these combinations, as you'll see going forward, is BCL2 inhibitor, venetoclax. And then there are other options, maintenance that we briefly talked about, CC486, as well as gemtuzumab, which is a antibody-based treatments, and CPX351 or Vyxeos, which is actually the only chemotherapy in these 9 drugs per se to be approved, but has a unique way of being delivered in liposomal formulation with better bone marrow penetration and less mucositis and tolerability. Next slide, please. And so this is our approach. This was in a review we published last year, actually a year and a half ago now, looking at how to prognosticate and stratify AML treatment. What you can see is clearly we're not treating AML as one disease, and we're not even treating it as just a fit and unfit AML as we used to just about 7-8 years ago, where if you were fit, you got 3+7 or FLAG-IDA sort of approach. If you were unfit, you got AZA or decitabine or low-dose Aracy or hospice. And you can see that things have changed quite a bit in the last 5 to 6 years. And in fact, even in this review, we will start in the future, hopefully adding menin inhibitors for the NPM1 MLL. So even this may become outdated very soon. But here, what we're looking at is for frontline patients who are reasonably fit, where you do think intensive chemotherapy can be safely delivered. We don't usually push, as I was mentioning, intensive chemo now in patients above 70 and even between 65 and 70. If I think they're borderline, I'm quite comfortable to move to HMA-VEN because we're getting very similar remission rates. And if my goal is to take them to transplant or to maintain them, I don't push for the 3+7 in the borderline patients. But below 60, yes, we're still using intensive chemo for most of our frontline fit young patients, and even between 60 and 65, the majority we do that. The question there is, what do we add to it? If they have a FLT3 mutation, we usually check for that. We add a FLT3 inhibitor. If they have core binding factor, this is important for the residents, fellows, medical students. This is the two things you never want to miss in an AML before starting therapy, or even if you started, you still don't want to miss it, are APL and core binding factor. These are the most curable forms of not just AML, of most leukemias. APL translocation 1517, extremely high cure rate without chemotherapy, without transplant. Atraarsenic for 4 months, patient 98% cure. So you do not want to miss that. Every AML patient should have a FISH for 1517 done. And the second is core binding factor. Again, you can do cytogenetics or FISH for inversion 16821. This is not a very small group. 15% of AML are core binding factor with intensive chemo, high dose cytarabine, anthracycline based, with the addition, ideally, if available, of gemtuzumab. Cure rates are close to 80-83% in recent published data. So these two you don't want to miss. We always check for those. Then the FLT3, as I mentioned. For secondary therapy-related AML, one could consider CPX-351 Vyxeos. This has shown a phase 3 randomized survival improvement over traditional anthracycline cytarabine. I think the question is, what can we add to it to make it even better? Because still the 5-year survival rates are about 30%, a little better than 20% with 3+7, but more to be done. And then we are trying venetoclax in combination with intensive chemo for all the others, non-APL, non-core binding, non-FLT3, non-secondary AML populations. And then you see for the older AML, similar use of HMA-VEN as the backbone, but may not be sufficient on its own. We will see the data of the Viale study where at 2 years, about 40 to 45% are cured, which is great. In the older unfit population, historically, only 10 to 15% would make it 2 years and beyond, as you know. So 40, 45% is great. But of course, can we get that even higher? And that's where we're adding a third agent, if we can do it in a safe way in clinical trials with IDH or FLT3 inhibitor, or potentially CD47 targeted drugs. And TP53, I think, is emerging now as the most unmet need for AML. It doesn't matter if you're young or old. It doesn't matter if you're fit or unfit. Outcomes are uniformly poor. At this year's EHA, actually, there will be 3 different abstracts put together by our group and others looking at outcomes in TP53 MDS across real-world analyses and retrospective data, as well as in AML. And you will see it does not matter what treatment you get, 6 to 9 months across the board for all ages and fitness. So this is really where we're hoping immunotherapy, CD47, as well as NK cell-based therapies and potentially other drugs will emerge. Next slide, please. So this is just kind of a background, I think, for some of the younger members in our audience who will see some of the future next slides that I'm going to show. This is what you need to remember as where we started, and not ancient history. This is 2002, 19, 20 years ago. FLT3 was first identified by 2 groups. The German groups published on this, our group published on this, and then very soon after that, the British MRC published on this. All of these showed that FLT3 ITD mutated patients, 5-year overall survival was between 20 to 25%. So very high risk. In fact, in 2 of those studies, the highest risk, in spite of cytogenetics, age, comorbidity, secondary therapy-related ECOG-PS, the highest risk on multivariate was attributed to the FLT3 status. So 20% at 5 years was what we started with FLT3 mutations in the fit patient population. Next slide, please. And then of course, there were a lot of different analyses as we did for Philadelphia positive ALL, where we looked at the impact of allelic burden, co-mutation, cytogenetics, and as would be expected, but of course we have to still show it for evidence-based analyses, is that as you had higher FLT3 allelic burden, so if you were 0 to 0.25 allelic frequency, 0.25 to 0.50, so each quartile increase was associated with a reduced CR rate reduced EFS, reduced OS. So basically, the more the AML was FLT3 driven, the less chance you had of a successful outcome. Now, important to note, this was all in the pre-FLT3 inhibitor era. And there it stood as being true. It's still true with the FLT3 inhibitor. However, all patients benefit with the FLT3 inhibitor. So there are two separate questions. Is a high FLT3 allelic burden still adverse? The answer is yes. Do high FLT3 allelic burden patients still have an incremental benefit from the FLT3 inhibitor? The answer is still yes. So we still give FLT3 inhibitor to everybody, but we still know if somebody came with an allelic burden of 0.85%, that this is a high-risk person. My best shot is give him FLT3 inhibitor, intensive chemo, get him into remission, get him into transplant, do maintenance, throw the kitchen sink, because this guy will remain high risk even with the FLT3 inhibitor. Next slide, please. So this is now, probably the key slide of where we are with different FLT3 inhibitors. So the ones in the orange are the ones that have approval somewhere in the world. So midostaurin with chemo based on Ratify is approved in most regions across the world, in India, in Europe, in USA. Gilteritinib in salvage relapse refractory AML as a single agent is approved across the world. Quizartinib, long story, a lot of issues, some political, some related data. I'm not going to get into those. We've been very, very involved at MD Anderson since Jorge time to our time with Quiz. I think it's a great drug. Both Gilt and Quiz, I think, are fantastic drugs. It did get approved based on a positive phase 3 study in Japan, but it was not approved in Europe and USA. However, now the frontline phase 3 study, Quantum First of Quizartinib, the press release is the only thing we can share, has been declared, and it is positive. So we strongly believe, as do most experts in the US, that this will bring Quizartinib hopefully to the market. And that is great, because I will show you that there are different mechanisms of resistance with Quizartinib, Gilteritinib, and very similar to imatinib, nilotinib, dasatinib, ponatinib, there is a important use for all of these in specific patients based on their underlying mutations, emerging mutations, as well as comorbidities. And then others such as crenolanib also are in development, still not completing their phase 3, so we still have to wait to see the future. And then there are specific new FLT3 inhibitors that are being developed, just like ponatinib, for what we call the activation loop mutations or the signaling mutations. So these are able to overcome those activation loop mutations, which quizartinib, gilteritinib, sorafenib, midostaurin cannot. So those will be hopefully like the ponatinibs that overcome all resistant mutations in the AML FLT3. Next slide, please. So this is kind of looking at the differences, and this becomes important because people always say, oh, which is the best FLT3 inhibitor? And I actually think that's just like saying which is the best TKI in CML. And till today, as you know, with 20 years of experience, there's no straight answer to that because there's no best. It just depends on the patient. And so here you see there's a difference between the type 2 inhibitors like sorafenib, quizartinib, and the type 1 inhibitors like midostaurin and gilteritinib. The big difference is the type 1 inhibitors can cover both the ITD and the TKD mutations, so both the common types of FLT3, whereas the type 2 inhibitors are very potent. Quizartinib actually in the lab is the most potent of all, but it hits only the ITD. And so guess what? The mechanism of resistance you see is based on the mechanism of action. So with the quizartinib, the main mechanism of resistance is you hit the ITD very hard, but then there's a on-target mutational escape. The FLT3 starts showing a TKD mutation. Quizartinib cannot hit that. And so we see about 30 to 40% of people who fail post-quizartinib have a TKD mutation escape. Now one would say, well, of course, that means the type 1 inhibitors are better, but not really, because the difference, what happens is, yes, you hit ITD and TKD, and AML is just very difficult and in a way very smart, and it still finds a way to escape, but it does not do an on-target mutational escape. You see off-target emergent parallel pro-survival mutations like RAS, MAP kinase, PTPN11, BCR-ABL even. So that's important because a lot of these off-target mutations could be covered by quizartinib, and the TKD that happens after quizartinib could be covered by gilteritinib. And so I think these drugs will eventually be used well in sequences to improve the long-term survival of our patients. Next slide, please. So here, I think one of the important things we've already kind of discussed, the frequency FLT3 is seen in about 35% of all AML, 30 to 35%. It is much more common in young AML and less common in older AML. So in the young AML, it's about 35% of all patients. In the 65 plus, it's about 15 to 20%. And that's why you'll see a lot of the FLT3 studies are done predominantly in the younger AML because it becomes harder to find sufficient numbers to complete randomized studies in older AML population. Next slide, please. Now, talking about some of the clinical data, the first randomized phase 3 study actually showed the benefit of a FLT3 inhibitor in any setting was actually in the frontline setting. This was 7+3 with midostaurin versus 7+3 placebo, gold standard, multi-center, international placebo-controlled randomized phase 3. This study took 10 years to complete, actually 12 years from the time of start to approval. And we love this study, but we do not want to ever do a study like this in AML. I don't think we will because of all the new drugs and people already moving with the multiple combinations. But this was an important study to get that first drug approved. You do see that there was a survival advantage. You also do see that the survival advantage is not huge. It met the significance benchmark. Yes, clinically, I think it's good to have a survival advantage, but I think we can definitely do better. And that's where we hope the gilteritinib, quizartinib combos will come in the future based on their ongoing studies. Next slide, please. Now I like to show this slide. And if you remember, I had mentioned, remember that slide where FLT3 ITD had a 5-year survival of 20% in the German, MD Anderson, and British studies. So now you start seeing the improvements happening. And this is just the first step with midostaurin. So now that we knew FLT3 was adverse, we knew we had to transplant these patients, and we knew we had to have a FLT3 inhibitor. These 3 pieces of information led to us doing midostaurin early, taking people to transplant, monitoring closely. And now you see that if you actually do those steps, get a person in remission with 3+7 mido, which is majority of people, 70-80%, take them to transplant in first remission, you could have a 5-year survival now coming close to 65-70%. So that's quite a nice progress going from 20-25% to 65-70%. But I think we can still do better, maybe with the second generation FLT3 inhibitors coming in, and then maintenance post-transplant, which is not really done much in this study, but is being done more and more. So I personally feel in the next 5 years, like Philadelphia positive ALL, we're going to start seeing not only that FLT3 mutated do as good, but may even be more favorable than non-FLT3 with better targeted therapies and better maintenance options post-transplant. Next slide, please. This is just some of the safety data. You know, midostaurin is a safe drug toxicity-wise, but it's a difficult drug. And you know, it sounds weird, but it's just patients don't like it much. If you have ever seen the pill or smelled it, it smells really, it has a strong smell, and often patients have difficulty taking it too long a period of time, but it's actually quite safe. We don't see many unexpected or severe emergent toxicities. The 2 things that we do see are rash, which is a little bit more. It's not a dose-limiting toxicity. It's not one where we've had to stop therapy or discontinue it. And there's slightly higher nausea. But I have had a lot of patients just saying that it's difficult for them to taste, or they have to take it with the meals, or they have to take it with some flavored drinks. And I think that is one of the hurdles we have seen, especially in the post-transplant maintenance with both midostaurin and sorafenib. But otherwise, yes, I think it's safe, and you know, most patients eventually are able to continue taking it once they know the benefit. Next slide, please. Now, what are we looking for in the future? And so here you see on the first block, I'm showing the results of the RATIFY, the phase 2 randomized study. You can clearly see the remission rates were improved, 66 versus 59%. That did meet statistical significance. But then you also see, and remember, these are phase 1-2 studies that we're showing on the right. So there is always a bias there, but still to see the signal of CR rates close to 90% is very, very encouraging. And to some extent what we expected, because even the single agents, gilteritinib, quizartinib, are much, much more powerful, both in lab and in clinic, than midostaurin and sorafenib. So we expect that there will be a more powerful response. And the nice thing is they're also quite well tolerated. And so now these are now being looked at in phase 3 studies, which are completing soon. Quizartinib 7+3 versus placebo 7+3. That one already has been completed, actually, Quantum first, and we know it's positive. The data will be at the summer meetings this year, so very soon. And gilteritinib 7+3 versus 7+3 placebo. There are 2 studies ongoing, one in the US randomized phase 2, which is expected to complete later this year with the Precog Alliance group. And then there's one with the HOVON group in Europe that is a longer study, which will probably take a few more years. But I think we will hopefully see these data coming very soon in the future. But for today, midostaurin is the standard of care. It is the one that is commercially approved by insurance, and the one we are using with induction, unless we have a trial with gilteritinib, quizartinib frontline. Next slide, please. And this is what I was highlighting. This is all we can share at this time until the ASCO-EHA meetings. But this was a large, again, multi-center, placebo-controlled, randomized, gold standard, phase 3, 3+7 quizartinib versus 3+7 placebo. Now, immediately, the students in the room will say, or the residence fellows, like, why is it against 3+7 placebo? These are the difficulties of doing clinical trials. So what happened is when this trial was designed in 2014, actually, I was involved with Jorge in the discussions of the trial design. The midostaurin data had not become available. And so the standard of care at the time this study was discussed with the FDA and locked was using 3+7 with placebo. And so that's how this study was initiated. And once you start a randomized phase 3 and lock the design, there's a lot of work that goes behind that, usually a year, 2 years of planning, then that cannot be changed. And so this started, and then about 2 years into the study, we saw the 3+7 MIDO data, which was positive and changed the standard of care. But the FDA is regulatory body, and so it will hold to its decision. Now, the question is going to happen, and you'll see a lot of discussion on this if you listen to the EHA and ASCO post discussions, or if you go to the meetings on what do clinicians feel. And I think that's going to be the question. Is 3+7 quizartinib going to show that much of a clear benefit that it will replace 3+7 midostaurin? This is the question that remains, and we will discuss more about it once we can share the data openly. Next slide, please. So this is also looking at some of the data that is available for 7+3 gilteritinib. Again, this is a single arm study, but you do see the response rates in this study with about 70 patients were pretty high, 82% CR/CRI, very well tolerated. In fact, the early mortality, 60-day mortality in this induction study was 0, which is quite fantastic for a induction intensive chemo approach. Next slide, please. And this is the survival from that single arm study, last updated about a year ago at ASH 2020, where we see now 3-year survival coming close to 65, 70%. This is good. Now, I don't know if this is great because this is kind of similar to what we have seen with gliasorafenib, 3+7 midostaurin, maybe a little bit better. So I think we need to wait for the randomized data to see over time how this plays out. Also, these patients may have different risk features, other factors that need to be assessed. But definitely, tolerability-wise, the combination of gilteritinib has been very well tolerated, and one we have used with other backbones like Glia, Flag-Ida, and found to be very effective. Next slide, please. Now, maintenance, I'm not going to spend too much time. I know you had a nice discussion here on maintenance. The key point here is maintenance in FLT3. In my view, I would say 90% of the experts in the US in FLT3 is established. You have 2 randomized phase 2 studies. Yes, these were not phase 3, and yes, they were not powered for survival, but I think the data here is sufficient that EFS, OS were both met, even though EFS was the primary endpoint. Both of the studies showed that you could deliver the therapy. Both of them did show that there is difficulty in giving sorafenib the full dose, and that between 50 to 70% of patients would have to come down to lower dose. So from 400 BID down to 400 Q-day or even 200 Q-day in about 1/3 of the patients. But even in those who had dose reduction, they seem to have a similar degree of benefit if the reduction was done for toxicities. So this, I think, established FLT3 maintenance. I think the big question is, yes, it's established FLT3 maintenance, but has it established sorafenib maintenance, or can we do better? And that's where the gilteritinib phase 3 using the same approach is going to come into play. Next slide, please. And this is just a few of the points from this study where as I was mentioning, dose reductions did occur in about 50% of the patients with sorafenib. However, discontinuations were not that high, about 1/5 of the patients. So some people do have to discontinue, but 80% can continue the treatment. And as expected, the most common adverse effects were GI, as well as electrolyte abnormalities, skin toxicity. We do see it more in post-transplant. We do see it more because some of it can be a flare of the GVHD. But I would say all in all, it can be done. We usually start with 200 BID in our approach, usually somewhere between day 40 and 60 post-transplant is ideal. If it's a little later, it's okay, up to day 90, sure. And then we usually 200 BID for 6 to 8 weeks. If the patient is tolerating, we may try to go to 400, 200. We almost never go to 400 BID. If they're not tolerating, we often do come down to 200 once a day or 400 every other day. But continuing some form of maintenance really seems to be more critical than trying to push for a higher dose at the cost of toxicity. Next slide. And this is the study I was mentioning. Now, this is again the gold standard, phase 3, larger study. The previous studies were between 90 and 120. This is about 400 patients almost. And here you see it's the other nice thing with the study is it's been designed to look at MRD at multiple time points, pre-transplant, post-transplant every 3 months with a high sensitivity 10 raised to minus 5 PCR MRD. And why is that important? Because the big question we really have is, does everybody need maintenance, right? Yes, 60, 70% needed, but could there be this 30%? Maybe they're PCR negative at 10 raised to minus 5 pre-transplant, PCR negative 10 raised to minus 5 post-transplant, PCR negative at 10 raised to minus 5 3 months post-transplant. Do I need to give this person maintenance, yes or no? So we don't know right now, but this study will help answer those kind of questions. On the placebo arm, there may be some of these people who are in such a deep remission pre-post-transplant that they did as well. And of course, that kind of information is important because, again, I don't think 5-10 years from now, we're just going to say maintenance, yes, maintenance, no. I think it's going to be more about who gets maintenance, who needs AZA gilteritinib, who needs gilteritinib, who needs maybe venetoclax gilteritinib, who needs nothing. So some of these questions, hopefully we will get much more detailed answers. And I think this study will be critical to really unfold the field of post-transplant maintenance FLT3 mutation. And hopefully we will start seeing some data by the end of this year, possibly from this study. Next slide, please. So this is our summary of, kind of what's happening, what we're doing at MD Anderson. We published this as a review in Blood Cancer Journal for those of you who want to read the more details. MD Anderson, what we're doing is not necessarily what everybody else is doing to some extent. We are using a more potent induction backbone that we have used for many years of FLAG, IDA, CLIA. And there's two big reasons for that. There's actually data showing that the use of cladribine especially seems to have a favorable effect across the board. There's a paper in JCO from the Polish group, did a randomized study of cladribine, idarubicin, cytarabine versus 3+7, and actually showed both EFS and OS survival. But more importantly, when you look at that paper in JCO from Holowicki a few years ago, the FLT3 group seemed to have the greatest benefit from cladribine added to the intensive chemo compared to all others. So that's why we really are focusing on cladribine. And then there's also data showing higher dose cytarabine from the MRC had a benefit in the FLT3. So trying to optimize the FLT3 frontline, cladribine seems to have a distinct benefit. Cytarabine seems to have that. And then, of course, the most important is adding the FLT3 inhibitor. In our trials, we use gilteritinib currently in standard of care. That would be midostaurin. Try to get them to CR. We try to get most of these people to transplant. One of the big questions we get is, which FLT3 mutated patients do we transplant? The simple answer today is all of them. There's no FLT3 mutated patient who we don't transplant. People could argue low FLT3 NPM1. Actually, Musa Yilmaz, one of my junior colleagues, just published in AJH. You could look it up. Even with very low FLT3, less than 10%, with or without NPM1, transplant still seem to have a survival benefit versus no transplant. And so based on that, we today don't feel that we can confidently avoid transplant in any FLT3 mutated patient. Those with the low FLT3 who get transplant do better, which is good, but you cannot avoid transplant completely, is our opinion. And then post-transplant, we do maintenance for these patients. Next slide, please. So now moving to relapse refractory setting, I'm going to talk about, some of the developments there. Next slide, please. So here, it's about 60 to 80% of patients who will still relapse. I think this number is maybe coming down a little with our better inductions, maybe 40, 50%, but still a sizable number of patients will relapse. So this is still an important group. And those who relapse have a very poor outcome. All of the prognostic factors we talked about don't matter in relapse. Even core binding factor does poorly in relapse. So once a patient relapses, it doesn't matter if they're FLT3, core binding factor, APL is the only one maybe you can still salvage a good amount, but relapse is the most overpowering negative prognostic impact. And we see that with survival between 5 to 8 months with whatever you use today in general for relapsed AML. Next slide, please. So the treatment approaches, this is a very simplistic slide. We don't, view it this anyway, nowadays. But in general, those who have a late relapse, we can still salvage them with the intensive induction. So let's say you have somebody who got 3+7 MIDO, 2-3 consolidations, didn't want to go to transplant or couldn't go to transplant, or even went to transplant and relapses a year and a half later. This is uncommon, as you know. This is 10, 15% of relapses, but that person still has RLC sensitivity. We would still give them reinduction maybe with FLAG-IDA sorafenib or 3+7 mido again, and then we would consider second transplant. But for the majority who relapse within 12 months and who, you know, are either primary refractory or early relapse, that is not an option. Next slide. So this is the NCCN guidelines today, and it's amazing. Every 3 to 4 months we discuss and we change them. You know, for 20 years we didn't have to change them. Now every 4 months, which is great. We're very happy about that. But the NCCN is continuously in flux. So currently the guidelines we have are for relapse FLT3 is gilteritinib. Yes, we all agree category 1. I'll show you the Admiral data. HMA sorafenib is an option. We can use it after gilteritinib. We still, in the community, people still do that if they don't have other trials. And then PKD gilteritinib still works. You will see hopefully very soon data of venetoclax gilteritinib, and the hope is that maybe that will move into the NCCN guidelines based on the exciting data we're seeing. And then for IDH, enasidenib, ivosidenib, and then you see the intensive chemos, we put them all together because we don't really find a big difference between what type of intensive chemo you get for relapse. So whether it's cladribine-based, high-dose cytarabine, fludarabine, etoposide, all of them have very similar outcomes, 6 to 8 months survival in the relapse. A lot of people used to argue about them, but really we feel any of them is suitable backbone. What really matters is if you can get a targetable mutation and what you can add potentially to these chemotherapies, a FLT3 inhibitor, IDH inhibitor, or other targeted therapy. And then of course, lower intensity like HMA, HMA-VEN are options as well. Next slide, please. This is just to highlight that point that, you know, it doesn't really matter what type of intensive chemo you got. This was a very interesting study of L-cytarabine, which eventually did not make it, but in the control arm, they allowed you to use any chemotherapy. And so for those who debate a lot about HIDAC or MEC or FLAG-IDA or LODAC or HMA, it didn't really matter. All of them had a response rate of between 15 to 25% CR/CRi and a survival of between 3 and 5 months. So I don't really think that that debate is one we are having anymore, but more about what specific targeted immune therapy can be used. Next slide, please. So this is now some of the quizartinib data. And as I said, quizartinib unfortunately was not approved in the US and Europe, but the phase 3 study did meet its that primary endpoint and did show statistically significant survival improvement. One can see that the margin of benefit is not as, you know, intense as one would see with gilteritinib or with some of the other drugs. And so after a lot of discussion and debate, unfortunately, this drug was not approved except in Japan, but we're hoping now in the frontline data, there will be a clearer signal and quizartinib could be approved and used in the frontline setting. Next slide, please. This is some of the safety data. You know, with quizartinib, one of the big key things we need to think about is QTc prolongation. That's the most common side effects we can see with quizartinib. It does cause neutropenia. That's quite manageable. That's not been a big problem. And even the QTc at the lower doses, you know, quizartinib when it first started development was used at 120, 150, 180 doses. This was in 2011, 12. That's where we saw a lot of the QTc. But over time, we started seeing that the 40 and 60 doses actually were very similarly equivalent, actually almost exactly the same CR/CRi rates, but had much less QTc signal. Very few patients had grade 3 and 4. And so at those doses, at least our experience, we've treated a couple of hundred patients with quizartinib in different trials, is that the QT issue is not really a problem. And in general, this can be well-tolerated agent. Next slide, please. So now moving to the phase 3 Admiral study, the design of this study is basically relapse refractory FLT3 mutated patients who are usually in the first salvage situation, so primary refractory or early relapse, who could get, traditionally we would give them intensive chemo again. So if they got 3+7, we'd give them FLAG-IDA or MEC or HMA versus gilteritinib randomization. And the primary endpoint was overall survival. Now, this is really quite an ambitious study if one thinks about it. You're using a single oral agent targeted therapy and competing it with 3-drug FLAG-IDA, 3-drug MEC, which is what 80% people got, either FLAG-IDA or MEC, and still saying that this is not equivalent. I would say if I'm a patient, if this is equivalent, I would take the oral outpatient well-tolerated agent versus the 3-drug chemo. But in fact, we're going to say that the targeted oral therapy is going to be superior to intensive chemo. You will never see such a trial design in solid tumor. This is quite an ambitious, aggressive trial design. And then, of course, transplant, if appropriate. Next slide. And here we see that the response rates were all improved with gilteritinib. This was very much expected because even the phase 2 with single agent gilteritinib, we were seeing close to 50 to 55% marrow remission, CR, CRI, CRh. And here you see that number, the overall response is being maintained close to about 50% CRC is what we usually call it, as compared to intensive chemo where the CRC is only 22%. So this is also important because a lot of people claim, oh, with intensive chemo, I can get this response, that response, maybe at some centers, maybe in individual patients. But when you aggregate patients, flag-IDA MEC, in people with FLT3, failing 3+7, the response rate is quite low, 20-22%. The CR rate is even lower. And so I think the study showed two things. One, that gilteritinib is potent as a single agent. And the second is that salvage chemo is not really that effective when you really look at it in a randomized study fashion. And so personally, I would never use salvage chemo alone in a relapsed FLT3 patient. I would use a FLT3 inhibitor, yes. Really, I would use a FLT3 inhibitor with something, and we were talking about what the combinations are. But I think this study really showed that salvage chemo alone in a FLT3 mutated relapse is not very effective. Next slide, please. So again, I will mention that gilteritinib is actually very, very safe, one of the safest drugs. The couple of things we have to watch out for, there can be an increase in liver enzymes. We see this commonly, usually grade 1, 2. Most of the time, we don't have to do anything. We watch it. We change the concomitant medications if any of those are hepatotoxic. Sometimes we have to reduce the dose. Very rarely we've had to hold the gilteritinib. We do see some GI colitis in some cases. This was described in the Admiral study as well. So you have to watch for that. If you do see it, it's rare, 1 or 2%, but it may be an indication to hold therapy for a few days if needed. And then QTC interval prolongation is super rare with this drug, not a big problem. And the tolerability, it doesn't cause much side effects. Patients seem to be very happy on it. They don't have any taste or nausea or GI issues. So gilteritinib, ivositinib, enasidenib, and quizartinib are these next generation targeted therapies that seem to be very well tolerated and liked by the patients. Next slide, please. And of course, this was the key data. This was updated, actually, survival by Sasha Pearl, who led this study. And you can see here that the median survival was clearly improved. You can see a big difference there between the curves, 9.3 versus 5.6. But you can also see that at 2 years, everybody is still failing. So I think, yes, better response rates, better CRC, better CR, better CRh, better quality of life, transfusion independence, and survival improvement, but the cure fraction or the long-term survival, we need to do more. And that's why gilteritinib, I think, is a good starting point, but the combinations are really where we are focusing a lot of our attention. Now, there is a group of patients, if you take them to transplant after gilteritinib, even in relapse setting, there's about 30-35% who could be cured. So maybe you can cure some of these people with gilteritinib followed by transplant, but for the majority, gilteritinib alone will prolong survival, which is great, but won't be long-term curative on its own. Next slide, please. So just talking a little bit about resistance mechanisms, I'm not going to go into too much detail in this. There's a lot of published data out there. I did mention that, you know, the mechanisms of resistance to drugs like gilteritinib, which covers ITD and TKD, are off-target. And there are two big off-target pathways that now have emerged as being important drivers of resistance to the type 1 FLT3 inhibitor like gilteritinib. One is the RAS-MAP kinase. This is a group of mutations, RAS, RAF, PTPN11, NF1, and the other is BCR-ABL. And the third is what we call the gatekeeper activation mutation. So for those who know CML, like the T315I gatekeeper mutation in CML, we have identified a gatekeeper FLT3 mutation, the F691, that drives resistance to all FLT3 inhibitors. And so there are efforts to develop next generation FLT3 inhibitor, like we did for ponatinib in CML, to overcome that gatekeeper, maybe in FLT3 in the future. Next slide, please. So this is a, you know, first, if you're looking for a review focusing on resistance mechanisms and next generation treatment options or sequences, this was one that we had published in Cancer Discovery a couple of years ago. Here you can see that FLT3 is much harder than, Philadelphia positive ALL or CML. There's not one pathway that always drives the disease. So you can see resistance on target, off target. There's involvement of tumor microenvironment. There's involvement of apoptosis and anti-apoptosis balances, and as well as RAS-MAP kinase and others. So it's going to be harder, and we need either combinations or sequential approaches to really overcome this. And ideally, maybe doing single cell mutation analysis to identify the emergent resistance pathways and target them. And I think that's where we're going in the next 5 to 10 years. Next slide. So now moving to combinations, which can, is maybe beyond the standard of care, but I think it's moving very, very, very quickly. For those of you who maybe attended ASH or see on Twitter, this is really what's being talked about a lot. So this is a nice slide that Dr. Yilmaz, my colleague, put together showing the evolution in the last 10 years. So we use azacitidine, azamidostaurin. Response rate's not bad, 50 to 70%, but survival, 8 months. Maybe a little better than AZA, 6-7 months, but really hard to say. Gilteritinib, aza, quizartinib, aza, we had small studies, phase ones, showing some improvement, up to 80% response. Quizartinib, aza is published now in Hematologica. Survival was not bad, 16 months. This was in above 70-year-old population. And then, of course, aza-ven, multiple studies, the phase 1b, the phase 3, showing high response rate, 70%. But unfortunately, survival, especially in FLT3 ITD, was only 11 and a half months. So not as good as we had hoped and not as good as the non-FLT3 ITD patients on the HMA ven. Next slide, please. Just keep that. And so then we said, okay, maybe using a FLT3 inhibitor with HMA is the way to go. And that led to this study. And again, here you see one of the issues with clinical trial development. Not to fault this trial. I mean, it was designed at a time when AZA was still the backbone. But this led to a lot of problems in the eventual conduct of this trial, because this trial was AZA gilteritinib versus AZA. That RMA closed very early, gilteritinib alone. But what had happened is while this trial was running between 2016 and 2021, AZA venetoclax came along. And in the US, around 2018, everybody moved to AZA venetoclax, 70% response, good survival, taken for transplant. And so the enrollment moved almost all to Europe. And even in Europe, a lot of them, they knew that they could use a FLT3 inhibitor because this was an open label study. This was not a blinded study. So a lot of patients who got randomized to the AZA arm, the patient and the physician already felt that, oh, the FLT3 inhibitors are already showing data, gilteritinib's out there, sorafenib's out there, quizartinib maybe. And so we see this in the results that were shown by Dr. Eunice Wang, shown at ASH, will be published soon, that the AZA arm patients came off very quickly after 2 cycles, and then 50% of them got a salvage FLT3 inhibitor compared to the AZA gilteritinib arm, where patients were not taken off as early, and very few, only 10% got a subsequent FLT3. And so what happened is you had dilution of the AZA alone arm, because what it really ended up becoming was AZA gilt versus AZA followed by gilt or sorafenib. So everybody got a FLT3 inhibitor, which I think for the patients is the right thing, but the study basically was impacted and the OS benefit could not be shown, because it basically showed that even if you're given salvage a FLT3 inhibitor, you can still get the survival to be improved. And so that really led to a negative study. There are some subsets that benefited, but we kind of had to go back to the drawing board now. Of course, this has also led to a lot of discussions about endpoints in AML for those of you who are interested in research and academic progress in AML. And a lot of people feel that this study highlighted that using RFS or MRD negativity is really the way to go, because all these studies for OS, just like in myeloma, are going to be diluted by effective salvage therapies. Next slide, please. So this is a study that we're quite excited about. This is a multi-center effort. Jessica Altman, myself, Sasha Pearl, Mark Levis, all involved. A lot of preclinical data. I mean, many times we do things empirically, and we probably would have ended up doing this empirically anyways, but actually there was a lot of preclinical data for different institutions, including MD Anderson, Sloan, Tony Letai's group, all published very high synergy synthetic lethality. And one of the interesting things is gilteritinib and quizartinib actually also block MCL1, which happens to be the most important resistance mechanism to BCL2 inhibitor venetoclax. So that was a nice mechanism of functional synergy. And as you can see here, the study has been now completed. We showed the updated data at ASH, the manuscripts in review, and very high response rate. CRC was achieved in 80% of the patients. And even with patients who had a prior FLT3 inhibitor, like midostaurin or sorafenib with induction, we still see a 80% CRC rate. So this really has established this as a very powerful combination. It's not approved, and it has to be published, but the NCCN may be interested in this going down in the future. In the US, we've actually seen a lot of the physicians, including academic and community, have moved to this, especially if we're trying to get a patient to transplant. This is very effective at getting a marrow remission, molecular clearance, and then within 1 or 2 cycles moving transplant. The negative is it is more myelosuppressive, and that's why if you're trying to give this to a 78-year-old for 1 or 2 years, it's going to be very hard. You have to drop the venetoclax quickly to 14, 10 days. But if you have a 50, 60-year-old, you want to get him in remission, you want to move him to transplant 1 or 2 cycles, this is a very good regimen. Next slide, please. This was the update we showed, basically just showing continuing high response rates, prior TKI exposed, prior ven exposed. They all respond. A lot of the responses are more marrow remission. Count recovery is suppressed because you're using a very powerful combo of ven and the FLT3. The nice thing is that even in patients who did not have count recovery, we still see FLT3 molecular clearance in the majority of those patients who achieved a marrow remission. And again, I think for a salvage patient, moving quickly to transplant with this approach is giving us some curative potential, especially in those who achieve the PCR negativity. Next slide, please. So in the last couple of slides, so we said, yes, GILT is good. When GILT looks better, not randomized, but looks better when you look at 50% versus 75, 80% remission rate, 20% molecular versus 60% molecular. In the US and Europe, the train is moving. People are already adopting that. But then frontline, we had problems with AZA GILT, was negative because of, I personally feel, trial design issues and change in standard of care while the trial happened. AZA-VEN, good, but 11-month survival, so we don't want to be stuck with that for the next 10 years. We want to improve on that. And synergy between VEN and GILT. All of this information leading to, can we now do AZA-VEN GILT? Nick Short, one of our colleague junior faculty at MD Anderson, has started an IST, and there's larger multinational study in planning for this as well. But you can see very early, I will highlight very early days, right? Only 15 frontline patients were shown at ASH, but all 15 at the ASH presentation had a remission. And what was really interesting was 14 out of 15 had a true CR, all counts recovered, marrow remission, and 80% of them were molecular clearance. Now, maybe it's a fluke, maybe it's early, but we have never seen anything like this in frontline FLT3, not with HMA-VEN, not with HMA FLT3. So we think that this could be the regimen of the future, but I will mention, and this has been discussed a lot in different panels, that there is more significant myelosuppression. And when we do this combo, we do only 14 days of venetoclax, and we drop the gilteritinib to 80 milligrams. Even then, one should expect 35 to 40 days for count recovery. Now, the good thing is, with good antifungal antibiotic prophylaxis, good experience, academic centers monitoring, mortality is very low, less than 5%, but we have to be aware of the myelosuppression. But I really think this is going to be the future in the next 1 or 2 years as more data and more learning on how to use this. I think we may have a very powerful regimen for frontline older FLT3 patients, and maybe not even just older. If this works so well in above 65, 70, in the next year or two, as we get more confidence, people are starting to say, why not give it to 50 and 70? Do you have to give them intensive chemo if you could potentially get such a response, molecular clearance, and try to get them transplant? I think we still have to wait for more mature data before we make those switches, but that's where the field is heading. Next slide, please. And this is just a nice analysis. This is a paper is also in review by Dr. Yilmaz that we put together just to compare, because people said, can you really show difference? And at MD Anderson, we had the ability to have doublets, intense HMA with FLT3 over the last 10 years with quizartinib or gilteritinib, sorafenib, and now we've started with triplets. And you can see just comparing, this is not a randomized study, but comparing over time in the last 10 years, when you do the triplet, you can see clearly doubling of the PCR negativity, doubling of the flow negativity, improvement in the true CR rate, and survival is looking quite good. Remember, this is again older unfit. So if we see a 3-year survival above 60%, really one will start saying, why should I be giving intensive chemo even to 50 to 70? This looks good enough for me to move. And that is something that, again, as I said, is being discussed. Maybe we're moving into multiple myeloma land where we will start replacing intensive chemo with optimally designed doublets and triplets coming in the future. Next slide, please. And so that's the last slide here, and just showing that, why do we need multiple drugs? And you see, because there's different resistances to different drugs. Midostaurin has its benefits, given in the frontline setting. Quizartinib has problems with cardiac. So if I have a cardiac patient with issues, CHF, I would lean towards gilteritinib. Gilteritinib can have some GI and liver issues. So if I have a patient with that, maybe quizartinib, and of course, mechanism of resistance, and then crenolinib. I think the jury is still out. We're still trying to figure out how this drug will fit in. But in the end of the day, I think all of these drugs are going to be important to be used, and there will be use for these in each patient. So the more, the better for our patients. Next slide. Okay, and as Dr. Agarwal says, I promise to respond to emails and happy to take any questions, and always happy to help all our colleagues, especially from India, my country. So yeah.
Thank you so much, Dr. Navid. As I said, we hear you every 6 months and everything looks so different, so new, full of knowledge and experience. I had a lot of questions in my mind written down on paper. You have answered everything. I don't have anything left to ask.
That's great. Yeah. No, I'm sure questions will come up. That's our job. More questions to be created.
So here, please go ahead. You can open your videos and please come over whatever questions you have. You are very, very innovative, so you must be having some very novel. And the audience, if you want to put some questions in the question box, please go ahead. Dr. Rima, go ahead. So somebody said the ball rolling.
Good evening, sir. Sir, is the allele ratio important in deciding the dosage and which inhibitor to choose, sir?
Simple answer, no. The allelic burden. So the best data with it is with midostaurin. So there's a paper in Blood from Donor, Constance Donor is the first author last year. You can look that one up, where they looked in the ratified study population. I think they had about 80 patients where they were able to look at the allelic burden of FLT3, and they found that basically those who had a high FLT3 allelic burden, they continue to do poorly, but they do less poorly with the addition of midostaurin. So you cannot switch the high risk to favorable. That would be great, but that doesn't happen. But they still do less poorly. And those who had low allelic burden, they generally do well, but they do even better with midostaurin. So what they showed was that midostaurin incrementally gave you benefit in all different FLT3 allelic burdens, but at the end of the day, higher burden did poorly in general. And so you should definitely consider transplant earlier in that population.
Thank you. Dr. Stalin?
Yeah, good evening, sir. That's a very nice lecture. Thank you for those insights. Sir, my question is, what is your current experience of using azacitidine plus midostaurin in a relapsed FLT3 positive ML who is not fit for a intensive repeat induction chemotherapy?
I couldn't cut the last part of that question.
So, hello. So for a patient with relapsed FLT3 positive AML who is not fit for an intensive induction therapy, so what is your current experience of using azacitidine plus midostaurin combination therapy?
Yeah, there's actually data on this many years ago. Jorge Cortez, when he was in our group, I forget the first was one of our fellows 8 or 9 years ago, we published it. Basically, the response rate is about 25% for azamido in intensive chemo failure. Now, in the US and probably in India, this is happening. That population doesn't exist much, right? Because we're using mido frontline with 7+3. So most of the salvage population post 3+7 mido, we're switching to the guilt or quiz. My view is that mido is modest potency as a FLT3 inhibitor, was the first one got approved. That was great for the field. But if I had to use a combo, I'm really much more towards guilt, whether it's with HMA or with VEN, or even with intensive chemo, there is small data sets there, or maybe with quiz if it comes out in the future. Azacitidine, of course, does have decent data, what one could consider. So I would probably have azamido as lower in my view for salvage option.
Thank you, sir.
Thank you, Stalin. Dr. Ranjit, your question?
Yeah. So that was a very nice presentation, sir. So FLT3 inhibitors are both a selective FLT3 inhibitors or a non-selective FLT3 inhibitor. So in both the situations, in AML, both in treatment naive and relapsed refractory, which one would you use preferably and why, sir?
Yeah, so I think a lot of this goes to, there's two things, I mean, I think what one I look at. So one is the type of FLT3 mutation, right? So if you have a TKD as part of the mutation, whether it's a TKD alone, TKD also called D835. So if you have a TKD alone or a TKD with ITD, then gilteritinib or mido are the options. And as a single agent, gilteritinib is much more potent, 50% response. Mido I didn't show, but there were old studies showed about a 5 to 8%. So it's not very powerful as single agent. And even in combos, we're seeing that single agent potency carries forward into the combos. So gilt with AZA or ven with gilt or AZA ven gilt. So I would use a gilt based for TKD relapse. And then for ITD alone, I think the jury is still out. I think gilt is still obviously approved and the drug I would still use as an approved agent. I think once we see some of the data with quizartinib, it'll be interesting and I'm sure people will consider using it. In the front line, you will see changes very soon when I think the EHA data comes out, because there, historically, 3+7 Mido has been the only option. It's used for ITD and TKD, but the 3+7 quizartinib data will be important. That'll be only for ITD. And my feeling is that will start having more and more people use 3+7 quiz. So I think 3+7 quiz for ITD frontline, maybe in the end of this year, 3+7 Mido for TKD frontline today, and for salvages, a gilt-based approach, probably a combo such as ven-gilt or aza-ven-gilt, and then transplant, either after induction or after salvage as soon as we can, post-transplant maintenance. I think we will have a good chance of curing a number of these patients at different time points in the course of their disease.
Our Dr. Ranjit is our Davar from India. His concepts of AML are crystal clear, and he's a tremendous, very, very good person in this field. His questions have been very, very appropriate, and his knowledge is tremendous. So we call him our Davar.
That's awesome.
Thank you, sir. Thank you, sir, for this comment.
It has been very, very impressive. Last 1 or 2 years, I've been hearing him. In one of our best paper award, he got the prize for his work. And
congratulations, yeah.
He's published things in New England Journal. Okay.
Fantastic, yeah. Congratulations.
Anybody else has questions? Okay, I think your talk was fantastic. Everybody has everything sorted.
Thank you, thank you. Love to see you all in person soon, hopefully.
Over to Esther's.
Thank you so much, Dr. Davar, and thank you so much, Agarwal sir, for that seamless session. And as Dr. Agarwal sir said, that it was so good that the questions were less, but definitely the subject is updating, and maybe soon we can have another session where the future trials can also be discussed related to FLT3 RRA. So with that, that's over for me. So thank you so much to all the panelists, to all the attendees, and to both the speaker and the chairperson for this. Thank you so much.
Thank you, Dr. Davar. Have a wonderful day ahead, and good night to everybody from India. Bye-bye.
Yes, thank you.
Thank you so much.
Bye. 10 o'clock. Bye-bye. Okay.